So once again, a very good morning. At the outset, I would like to thank Cochrane India Network and World Health Summit organizers for giving us this opportunity of sharing and discussing this very important issue through this panel discussion, which is on foundations for a healthy future, strategic actions for comprehensive preconception care. I extend a very warm welcome to all eminent uh, panelists and our chairperson for accepting our invitation and sharing their experience and thoughts on this very important issue of preconception care, and also to our eminent guests in the audience. Let me introduce myself. I'm Dr. Aarti Srivastava, working as research medical scientist. Um, and I'm a gynecologist by training and working in Indian Council of Medical Research headquarters, New Delhi. Before shifting here, I was working in Human Reproduction Research Center of ICMR in Obs Gynae department in KG Medical University. And I worked for almost 30 years and did more than 35 or so projects on maternal and child health, which were basically on contraceptive methods, clinical and operational maternal and child health projects. Now coming to our eminent panelists and our chairperson, I would request them that as I call them to please take their places on the stage. Before calling upon the panelists, first I would request our chairperson for the session, Dr. Preeti Kumar, to please come on stage. She is a MD gynecology from KG Medical University, Lucknow, is currently professor and head in the Narayana Medical Institute in Kanpur, UP. She has been and is most actively involved in working tirelessly in maternal child health care and is promoting it through various national and international platforms. She is chairperson Maternal and Perinatal Committee, SAFOG, from 2023 to 25, is Vice President North Zone Elect FOXY for 2026, and has been a very efficient chairperson of Safe Motherhood Committee from 2020 to 2023. She has many projects as PI on important maternal and child health issues, and as you can see from the slide, has many awards to her credit. Now coming to our eminent panelists, I'll call upon Dr. Himang Shah. Dr. Himang, please come here. He is a public health specialist by training and has worked in public health nutrition and management. He leads the Child Health and Development Portfolio of Children Investment Fund Foundation in India. He has almost 15 years of experience leading different public health and nutritional programs and working with state government, UN agencies, international NGOs, and private sector. Now coming to Dr. Anchita Patil, our next panelist. She is MD Community Medicine. Sorry, I'm missing out on this. She is MD Community Medicine with over 2 decades of experience in public health. Currently, she is with Gates Foundation India, country office as the lead for MNH, maternal and newborn health. She is focusing on implementation of evidence-based guidance on identification and management of MNH complications like PPH, prematurity in priority states. She has worked with Government of India as expert for preparing national policies and guidelines on RM and CHA areas such as SBA, Basic Emergency Obstetric and Neonatal Care, 24/7 PHC, etc. She has worked with bilateral and multilateral organizations like USAID and UNFPA. Coming next is Dr. S.M. Dharir. He is professor and head of neonatology, KLE Academy of Higher Education and Research, Jawaharlal Nehru Medical College, Belagavi, and has been working for Women and Children Health Research Unit on multiple projects to improve maternal and newborn health for last 20 years. Next is Dr. Mubashir Angolkar. She is head Department of Public Health in Jawaharlal Nehru Medical College, KLE Academy of Higher Education and Research, Belagavi, Karnataka. So she has been PI for major projects that have been funded by ICMR, DST, and NIH. She serves on editorial board of reputed International Journal of Population Health Management and National Journal of Indian Medical Health Association. Next panelist is Dr. Gitanjali Kataguri, professor in the Department of Obs and Gynae in S. Najlingappa Medical College, HSK Hospital and Research Center, Bagalkot, Karnataka. She has been former chairperson of Clinical Research Committee in Karnataka State Obstetric and Gynecology Association and has participated in several completed and ongoing international research projects focused on women's and children's health, including prevention of preterm birth, antenatal corticosteroids, maternal and newborn sepsis, preeclampsia, adolescent nutrition are few of them. And our last panelist is Dr. Parag Bhamre. He is country lead maternal and newborn health, Jipaigo, India, and technical lead for women's cancer prevention. So Dr. Parag Bhamre is a medical graduate and a public health professional with experience of working with leading public health organizations like Jan Swasth Sahyog, WHO, Vadhwani AI, and Jipaigo. His focus areas are immunization, MCH, and women's cancer initiatives. His unique experience spans both the public and private sectors, with a strong background in designing and deploying frontier solutions, including AI, machine learning innovations in these sectors. So due to constraint of time, I have been very brief about the accomplishments of our chairperson and panelists. I hope they don't mind it. And now coming straight to today's discussion. So although we have been providing care during pregnancy, and it is crucial in preventing many issues and achieving the best possible pregnancy outcomes, but with stagnating maternal and neonatal morbidity and mortality, it's coming increasingly apparent that antenatal care alone is insufficient, since it fails to address health issues and conditions that develop prior to pregnancy and in early few weeks when the woman is hardly aware that she's pregnant. So WHO has defined preconception care as the provision of a range of health interventions to women and couples before conception occurs. The aim is to improve health status and reduce behaviors, individual and environmental factors that could contribute to poor maternal and child health outcomes. So preconception care is the earliest window of opportunity that we have and involves various health interventions, including health prevention and promotion, risk assessment, and clinical and behavioral interventions. So in today's panel, how I think we'll move around is that we would first like to have introduction to what is the global evidence about the preconception care, the components and the benefits observed. Then we will come to the local evidence in India, and in it we'll be hearing from our panelists how they have experiences in some important components of preconception care over here. So first of all, I would request Dr. Hemang. I would like to tell us that what is the global scenario of preconception care, and can you shed light on the evidences across world about preconception care and their benefits? What were the components included and how they are being implemented? Over to you, Dr. Hemang.
Thank you so much, Dr. Aarti. And I must say that there are multiple parallel sessions that are happening as you are already aware of, but this is one panel session where there have been multiple conversations between the panelists just to think through, because this is a newer area. Some of the discussions that we have been hearing in other sessions, their potentially both what is known, like what are the interventions, but how is also pretty much known. But it is more about how do we now increase the access to those interventions and quality of these interventions. For this particular interventions, to some extent what is known, to a large extent how is not known. So some of the discussions that Dr. Preeti and Dr. Aarti has led, that has also helped us panelists to understand what are the missing pieces in the entire prevention care package. So I'll just briefly cover some of the key points. First is on the overall burden of drivers because of which there could be potentially adverse outcomes for children as well as mothers. So around the world as well as in India, there are large number of pregnancies which are unintended or unplanned, and when pregnancies are unintended or unplanned, then whatever kind of care that is provided during antenatal period, it still might not be sufficient for appropriate perinatal outcomes. There are also pre-existing health conditions including nutritional deficiencies, exposure to harmful substances, which again hampers the fetal growth as well as maternal and child health outcomes. If we look at some of the drivers which leads to this adverse outcomes, they can be divided into 3 layers. What are the immediate sort of driving factors for adverse outcomes? What are the immediate? So immediate sort of drivers are more related to the individuals, and what are the whether nutritional risk or lifestyle risk for the women herself. Some of the intermediate risk factors are more with respect to what is happening at the family level, and more underlying risk factors are at the systemic level, political level. And if we address or if we are able to provide appropriate preconception care package, then there are a host of outcomes that we can try and influence. So we can try and influence mortality indicators, we can try and influence low birth weight, birth defects, maternal mortality, preterm birth, SGA. So there are, and as we move forward towards this discussion, we'll also try and understand that it is not about a single intervention which will try and bring out this positive or beneficial effects. It will have to be provided in terms of a package. And if it is not provided in terms of package, these individual interventions might not lead to intended effects. So what are the nutritional risks? The available evidence shows that pre-pregnancy underweight is one of the major risk factors for both preterm births as well as SGA babies. And as we have been discussing in some of the other sessions also over a period of, like yesterday also and also tomorrow, is that if you look at India and also some of the Southeast Asian countries, the burden of both SGA and preterm is pretty high as compared to some of the African countries. So if you look at African countries, the peak of malnutrition starts to happen around 6 months and onwards. But in India, the peak happens at the time of birth and somewhere around 4 months. What it means is that some of the interventions that we are thinking about will have to happen in antenatal period and during the preconception period. At the same time, as we know, there is double burden or triple burden of malnutrition as we are seeing in India, in other South Asian countries, which is there is underweight on one side, but there is also obesity. And even if there is pre-pregnancy overweight, it has significant effect during pregnancy in terms of preeclampsia, in terms of gestational diabetes mellitus, and other perinatal outcomes, including macrosomia, NTDs, and congenital heart defects. So what is the evidence currently on the interventions? So there is a lot of evidence and very strong evidence on micronutrient supplementation. So folic acid has been there in most of the guidelines for quite some time. But there is also a lot of evidence with respect to micronutrient supplementation and even nutrition supplements in the pre-pregnancy period. At the same time, lifestyle modification and lifestyle changes which can have effect during the pregnancy period as well as for perinatal outcomes. The other part of the global evidence and the package, when we think of the overall package, what will also be important is to think about birth spacing and the age at pregnancy. Again in India, but also in other countries, age at pregnancy and the inter-pregnancy period is something which majorly affects what is the kind of services that can be provided during pregnancy, but also what are the outcomes that we are looking at. while there are direct biological benefits of the pre-pregnancy care, there is also a lot of evidence which says that if preconception care is provided, it also improves the care during pregnancy. So for example, there will be improvement in early registration during pregnancy. There are more chances of 4 antenatal visits being completed. So it is not just about the biological effect of interventions that are done in pre-pregnancy period, but it will also help in improving the care during the pregnancy. And overall, if we see, particularly in Indian context, the overall burden of high-risk conditions during pre-pregnancy period is also pretty high, which again points to the fact that if we start at say 14 weeks or 16 weeks of pregnancy, A, we will not be able to reach the entire population, and B, even if we reach entire population, we will not be able to make material change in terms of the outcomes that we are looking at. So overall, the prevalence of anemia, as we have been discussing, is pretty high. The use of tobacco is pretty high. Alcohol not that much, but this 4% use of tobacco is also in only certain pockets. If you look at individual tribal district data, or in some of the other countries, the use of oral tobacco might be very high. This sort of matrix, I've just kept this not in terms of what are the core interventions or what is it that needs to happen. It is just to showcase the fact that if we focus only on nutrition, or if we focus only on medical conditions, or if we only focus on lifestyle conditions, we will not be able to bring about the change that is required. So the idea is that there are this is the evidence from almost 34 meta-analysis which demonstrates that the potential benefit of strategies that address multiple preconception risk factors. So if we miss individual risk factors, then again the additive effect which will be there of working across the care package will not be realized. So it is important to look at all the components, including delay in pregnancy, increasing spacing, micronutrient supplementation in terms of folic acid deficiencies, pre-pregnancy overweight, pre-pregnancy substance abuse, and vaccine preventable diseases. And while all of these interventions individually affect the perinatal outcomes, there is also additive effect of some of these interventions working together. And so this is just a summary of the papers that I've used for this particular presentation, which says that there is strong evidence in terms of all these interventions, both in terms of the outcomes during the perinatal outcomes, but the evidence quality is also pretty strong for all of these interventions. But there are also gaps that probably we'll discuss subsequently. Thank you.
Thank you, Hemang. You have rightly mentioned about the, the problem of pregnancy is actually in India. What I think, because I'm not a public health specialist, I'm an OBGYN, so maybe my terminologies may not be as a public health specialist, but as I think, because I have worked a lot in the ground, and we know that the fact that almost 70% of pregnant women in India are high risk. Because, anemia is one of the contributing factors, more than 50% are anemic. More of the ARTs pregnancies which are coming up, more of the NCDs which are, cropping up, early diabetes, so I think the India is a country where we cannot go by the Western world. We have to make concrete, the guidelines and strategies for India. The second thing is now the concept is now changing from healthy pregnancy to healthy babies. It is now healthy women, healthy pregnancy, healthy baby, and healthy future. Because everything starts in utero. Even the baby which is being developed is growing inside the fetus in the mother's womb has a high risk of developing diabetes if the mother is diabetic. So the concept is that the baby should not know about the medical conditions of the mother, because if my baby comes to know that my mother is diabetic, the baby is also likely to be diabetic. I think two important things that need to be addressed more here in our country is violence against women. I have seen as a clinician that almost 1 in 3 women are suffering from some kind of violence against, in women. And the second thing is the psychosocial aspects, because the mental issues are now on a rise in our country, and Japaigo is already working on those mental issues. I think these are the two very important areas that we need to address here when we talk about the statistics of pregnancy in our country. Thank you so much. Now we can move on to the next speaker.
Yeah, thank you so much, Dr. Preeti, for the insightful comments. And that brings us to what you were just mentioning, that we need to have something local. What is the evidence that we have? So do we have Indian trials and experiences about preconception care? What is the evidence emerging from them? And throw light on the interventions, how and when they were delivered. What are the challenges in implementing, and what benefits were observed? So Dr. Anchita, I would request you to please throw light on this.
Thank you, Dr. Aarti. I would just like to begin with a disclaimer. The study that I'm presenting is not mine. I feel almost like an imposter here. It was done by SAS, the Society for Applied Studies, and it's basically a proof of concept study. So the idea being, we all talk about preconception care, we talk of good quality antenatal care, and saying, whenever we don't see things going right, we say the quality of the intervention wasn't appropriate, we should have done this, if we did this. So the idea was, if we put all those interventions together, do we really see a change in the outcomes that we expect to see? So as I said, what they worked on, this particular team, was not just the delivery of health interventions, but also those related to nutrition, WASH, that is water, sanitation and hygiene, and also some psychosocial care interventions. And they worked on it not just in the preconception period, but also throughout pregnancy and in the early childhood period, to look at the outcomes at both birth and when the baby was 24 months of age. So what were those outcomes at the end of pregnancy? They were looking at birth weight, the length of the baby, prematurity, and whether the baby was small for gestational age. A slight difference from birth weight, but yes, it's important. And then at the second year, they were looking at basically the stunting scores. So how did they actually design the study? They used the community itself as a lab, and tried to follow very stringent protocols on all the services that they were delivering. The lab, the population, was basically randomized twice. So women who were planning to get pregnant in, say, the next 6 months to a year, were initially divided, randomized for receiving preconception care and not receiving preconception care. And when some of these women did get pregnant, they were again randomized to receive the pregnancy and early childhood care or not to receive it. So basically forming in the end these 4 groups: preconception care alone, pregnancy care alone, preconception with pregnancy care, and the routine, which is the control group. And this is how they managed to compare. Now the interventions that they covered, as I said, covered a vast range of areas. In the preconception period, they looked at all the possible health and medical conditions that the woman could be suffering from. And as Hemang said, it had to be a package that has to be delivered for it to make an impact. So they looked at medical conditions, be it hypertension, diabetes, hypothyroidism, RTI, STIs, and whatever, and they were referred to doctors for treatment. If normal iron supplementation was given, if she was anemic, extra iron was given, if her BMI was low, additional food was given, so as to correct the BMI before she got pregnant. Then there was a lot of talk on mental health, that they worked with the woman, and they were tracking the mental health using a certain scorecard. And even on the hygiene and sanitation, how to work on it, and things like filters and water purifiers were also provided. So very, very intensive intervention. Some of those things were also done in the pregnancy period. So you can see an ideal scenario of, all that should be there in the pregnancy. And now we do talk about 8 ANC contacts and not 4. So that was done during the pregnancy, and the baby was taken care of, and so was the mother during the early childhood period also. So the growth of the baby, the lactation, the complementary feeding, etc. Now, what did they find at the end of the study? What they realized was that at the time, so the women who received preconception care vis-a-vis who did not, when they entered pregnancy, the one indicator that they saw a significant change in was moderate to severe anemia levels, and you can see that highlighted in bold. There was about a 55% reduction in moderate to severe anemia levels, and it kind of makes sense because these women, were provided with all the services that were there that could have been provided, and moderate and severe anemia management. So they entered pregnancy with a healthier hemoglobin level. At birth, then what happened? So at birth, they realized there was a reduction in low birth weight and SGA babies, about 13 to 15% reduction. And this was when we compared the preconception intervention vis-a-vis no preconception care. I am not really looking at the other groups because we are talking of preconception care at this point in time. The package, of course, if you in fact look at the last column, that is, it has, if you give it as a package of both preconception and pregnancy care, the impact is larger for this. Then at 24 months, interestingly, what we see is a reduction in stunting. Now this itself is a huge change, because stunting is something we've not been able to impact, and it's supposed to have an intergenerational impact. In fact, the earlier randomization was done keeping the mother's height in mind, because of course that generation. So across the two groups, they tried to balance out the maternal height. But despite that balancing out, we see an almost, or rather more than 50% reduction in stunting and in underweight. That, I think, is a huge impact, and it can have a large intergenerational effect. I have not deliberately not gone into the details of the study, one, because I was not engaged in it. So any questions that you have, I will refer you to the right people at SAS. But this study was so important because theoretically, we keep on talking about what should be done and it will have an impact, but we've never really tested it out. This was the brainchild of Dr. M.K. Bhan, who's no longer with us. And he said, let's just do it and see whether it really makes a change or we're just talking about it. So in that way, it's a game changer. Just from a implementation front, I think one of the biggest challenges we will face is how to deliver this package together. It's a very, very extensive package. And as a study, we've not been able to separate out the impact of the different elements of the package. So if we miss out on one, what will be the impact? So something for us to think about. And I will just end there.
Anchita, wonderful deliberation on WINGS trial. Lot to learn from this trial, that multiple interventions may be required. So what should be the first question as a clinician? Are you wishing to get pregnant in next 1 year? Because 3 months is not just the period for preconception counseling. You should also utilize the interpregnancy period also. Absolutely. Because you need to counsel, because this is the simplest way out that we can do. We can avail every opportunity because the medical conditions can, sometimes the patient may not be hypothyroidism, even maybe after 3 months he may develop diabetes or thyroid. So multiple opportunities should be used for as a preconception counseling. That's very, very important. The second thing is you highlighted about the anemia, because yesterday also we were having a lot of discussion on anemia. Lot of papers now are coming up that ferritin deficiency in periconceptional or preconceptional period has more impact on the neural development of the baby, yes, rather than having a deficiency during the pregnancy. So even in a non-anemic women with, if you see your blood parameters with a low little bit MCV and low, high RDW, you just think about the ferritin deficiency and please do check it, and if it is there, then definitely, because we are not following the Government of India guidelines, supplementing every week the iron tablets and all. So please do check that, because this is upcoming papers and upcoming recent trials that ferritin levels in a periconceptual period is also very, very important. So a lot to be done in periconceptual period and preconceptual care, but thank you so much for your inputs on WINGS trial.
Thank you, Dr. Priti.
So we see lots of hope with your SAS study for preconception care and for our mothers and newborns. So as we know, Indian women keep their own health at lowest priority. It becomes a very important issue. And as a neonatologist, I request Dr. Dharir to please comment on what is his experience of working on maternal nutrition and its impact on newborns. Because probably that impact will sort of give impetus to our women to look after their own health.
Thank you, madam. At the outset, let me thank the organizers for having given me the opportunity to share our experiences that we gained while implementing the multi-country, multi-center randomized control trial to look at the impact of maternal preconception as well as different times of pregnancy, the supplementation with nutrition and its impact on birth outcome, mainly focusing on the primary outcome of birth length. So as I said, this was the 3-arm trial where the arm 1 was supplemented with LNS, that is lipid-based nutrient supplement, 3 months or more than 3 months prior to the pregnancy. The second arm was supplemented with supplement at 12 weeks after they became pregnant, and the third one did not get any of the supplement. And the intervention here is a small quantity lipid-based nutrients, which was 20 grams in weight, and they also got the balanced nutrition and calorie supplement in case if their BMI was less than the what is supposed to be, and also if they did not gain the adequate gestational age during their pregnancy. So they got additional supplement also in addition to the basic supplement that is supposed to be given as a intervention. As I said, the primary outcome here was the birth length. In addition, there were many multiple secondary outcomes of public health importance. So to enroll women into this study, we used a survey. We conduct this survey for the last more than 15 years. From 2008 onwards, we do conduct a survey of women of reproductive age, where this is conducted by using the Anganwadi workers and Ashas. So each Anganwadi worker or Asha goes to their communities or the families and then conduct the survey and enlist the mothers who are likely to conceive, who are not likely to conceive. So the focus of ours was the who are likely to conceive. So these women were followed up every day, and if they were eligible to be enrolled into the study, they were enrolled into a different arms. So that is how this survey has been very useful for us to conduct not only this study. There are many more trials which are being conducted in Belgaum using the maternal newborn health registry. So this is a NIH funded project which is going on from 2008 onwards. Coming to the study sites, the study, as I said, conducted in DRC, Guatemala, Karachi and Belgaum. So these were the 4 sites for the women first trial. There were 24, for this analysis we only did for Pakistan and India, that is South Asia. So there were 24 resource poor rural communities from Belgaum in India and Karachi in Pakistan. We screened 5,496 women. amongst which 3,836 were consented and randomized to the trial. And we obtained a live birth, in the sense there were 1,320 live births, of which the primary outcome was obtained in 972. So primary outcome here was the birth length measured before 48 hours of life. So just a brief about small quantity LNS which was used, which contains multi-micronutrients, 20 grams in weight, provided 118 kilocalories, and it had a half-life of shelf life of 18 months. In addition, if the mother BMI was less than 20 kg per square meter, or if they had an inadequate weight gain. So inadequate weight gain was based on recommendations from the Institute of Medicine. That was the recommendation that was used. And this provided 300 extra calories to the mother, whoever received. And as I said, gestational was established by doing ultrasound in the first trimester for all the enrolled mother into the study. And newborn anthropometry was obtained within 48 hours after delivery. So there is a lot of, the discussion or the importance given to the BMI, baseline BMI, early weight gain, and the gestational weight gain, and its impact on fetal growth and birth outcomes. So therefore, we wanted to look at whether the baseline BMI, early weight gain, and gestational weight gain were having any impact on fetal growth as well as the birth length. So the early weight gain is from time of enrollment till 12 weeks. Gestational weight gain is from 12 weeks to 32 weeks. So these were the two periods that we tried to look at. So when we looked at that, the adequate gestational weight gain had a higher birth length and weight, which was statistically significant. And when we further analyzed, the baseline BMI, early weight gain, and gestational weight gain were independently associated with birth length as well as the birth weight. So thereby indicating that it's very important to have a adequate weight gain early in pregnancy as well as the gestational weight gain. So this is what that we found as a secondary analysis of the paper. Coming to the primary findings of this trial included. So there were significant reduction when we compared between the arm 1 and the arm 3, the one which received preconception nutrition and then continued till delivery, the one who did not receive the supplement. There were significant, that is 26% reduction in small for gestational age, 44% reduction in stunting, and stunting reduction at birth goes a long way in improving the birth outcomes as well as the neurodevelopment. So therefore, the significant finding of this trial was a significant reduction in stunting at birth to the tune of 44%. And there was also a 24% reduction in wasting. So in addition to reduction in SGA and stunting and wasting, we also had a reduction in low birth weight as well as the underweight. So all the parameters related to the baby's outcome, that is growth parameters, were significantly less when you compare between arm 1 and the arm 3. So the key messages from this trial was there should be a system to identify and follow eligible participants. If you don't have a system, then enrollment into the study becomes difficult because you really don't know who are likely to conceive, who are not likely to conceive. And there should also be a mechanism for uninterrupted supply of supplements and consumption monitoring. It's very difficult if you don't have the uninterrupted supply, then the mother may run out of these supplements and then we may not be able to assess the impact of intervention. And more importantly, we also need to monitor the consumption. Sometimes, mothers have their own way of, consuming. They may think that this is not important, this is important. So therefore, it is important for us to monitor that consumption. And also we need to adopt different methods of supplement consumption and its modification, because all mothers may not receive the supplement that we provide. They have a taste, flavor and all those things. Because in our own trial, many mothers used to complain of a metallic taste, in the beginning. So therefore the supplement was modified by reducing the amount of zinc that was present in the original LNS. So therefore modification of the supplement is also important, and should have a system in place to address the issues and challenges, because when you implement certain such trials, we also will have definitely the challenges and issue which need to be addressed in time for it to be solved. So thank you.
Thank you, Dr. Dharid. I think your institute is one of the prime institutes for conducting the various trials, and we recently have Lancet series on the role of and Jane is here with us. So it's a beautiful publication. We must all go through it. How micronutrients help in the the growth of the baby. The only question I want to put to Dr. Dharid is why the weight was not considered when you're taking the length of the baby after the supplements, because these also the weight is also, the baby's weight is also, low birth weight is improved. So why the weight was not the criteria as a primary outcome in this case?
No, the length was the primary, because we wanted to look at the
Stunting part.
Stunting
Okay.
part.
Okay. Thank you so
There
much.
was also improvement in the weight.
Weight
Not
also.
that it did not improve.
Okay.
But
That was
not
the secondary
secondary.
outcome. Okay. Thank
That
you
was
so
the
much.
secondary
Thank you so much. Now, Dr. Aarti, you can move on to the next speaker.
So that was really encouraging, I would say, the study and the outcomes. In current times, we are facing major environmental challenges like global warming, pollution of air, water, soil, and also substance abuse. So Dr. Mubashir Angolkar, I would request you to tell us, do we have some research and evidence regarding how it's affecting maternal and child health? And are there some strategies there to minimize and counter these environmental challenges? Over to you.
Thank you, Dr. Aarti. At the onset, I would like to congratulate the organizers and thank Cochrane India team for having us here. To answer your question, Dr. Aarti, yes, we do now have worldwide evidence that climate change intensifies risk for pregnant women. Environmental stressors like air pollution and increase in ambient temperature, heat waves, thermal stress, toxic chemicals, substance abuse have been associated with poor pregnancy outcomes such as miscarriage, low birth weight, preterm birth, developmental anomalies, and stillbirths. Not surprising that these stressors cause highest risk among the socially disadvantaged. A systematic review of 68 studies has shown that prenatal PM2.5 exposure is significantly linked with higher risk of preterm birth, low birth weight, and stillbirths. In India, Bhardwaj et al. Showed that there is a 40% risk increase for low birth weight and 70% increase in preterm birth for an exposure of PM2.5. And all of us know there's no state in India which does not have elevated rates of this, so something of concern. Heat waves and extreme temperatures also affect, and with every single degree increase, there's an elevated risk of preterm birth by 5%. Exposures to extreme heat during the third trimester have shown that there is an increased risk of 31% for preterm birth. We also see similarly for small gestational age, term infants, if they are exposed to extreme heat or heat waves in the first trimester, the risk increases by 4 times. Both extreme cold and extreme heat will show the similar effect, and ambient temperature and air pollution mediate 36% and 56% heat wave and air pollution respectively for small growth SGAs. For stillbirths, with again every single degree increase in temperature, there is a raised stillbirth odd of 5% and an increased risk by 18% in heat waves. 4 consecutive days of hot days being just before the delivery, there's an elevation of 3% risk for stillbirths. And if it's above the threshold, it can also go to a 10% increase. Yang et al. Have shown that non-optimal temperatures account for 10% increase in stillbirths worldwide. Natural disasters like flood, droughts, particularly in Indian studies, we have seen that it increases the risk for stillbirths by 8%, miscarriage for 5%, pregnancy loss risk by 8%. Droughts worsen maternal malnutrition, anemia, and increase miscarriage and IUGR risk. From first trimester, if there is an exposure for heat waves, and in the third trimester, if there is an exposure for extreme rainfalls, both have shown that by 150% the odds will increase for low birth weight. Of course, in Africa, we have extreme temperatures where again there's a neonatal mortality raised by 5%. Floods, droughts induce psychological stress, food insecurities, and infectious disease risk, which then exacerbate the preterm and fetal growth restrictions. Particularly in India, women working in the agricultural field exposed to pesticides like organophosphates and PFAS, there has been association with miscarriages and anomalies. We all know that in rural India, 40% of our households rely on biomass fuels. This indoor air pollution contributes to stillbirths and neonatal deaths. So we have systematic evidence that links these environmental exposures to a significantly high risk of adverse pregnancy outcomes. 20 years back, I was on a study that was multicentric, and we were looking at women smoking during pregnancy and outcomes. And it was global multicenter, and in India particularly, we did not find women smoking. And even if they were smokers, they were aware of the effects of smoking and were not smoking in the period of their pregnancy. This publication was 20 years back. Today I was surprised when I was doing this that we see an increase of use of tobacco among pregnant women, and this has led to an increase of stillbirths by 23%. Alcohol further doubles the risk of stillbirth and congenital anomalies. A global review further highlights that these risks are amplified in socioeconomically disadvantaged population. And I think your second part of the question, we will come back to it later. So, yeah, question.
Thank you, Mubashir. The experience is really, live. When we go to the airports and you see a smoking area, you see more females rather than males there smoking. So it's very important, pertinent to carry on more researches in our country regarding the environmental and substance abuse. And the second thing is the alcohol intake. It's rampant now. Most of the females are now having alcohol, and there's no limit of amount that is safe in pregnancy. So these are some of the very important things that need to be addressed in our country. Yeah. Thank you.
Thank you.
So thank you, Dr. Mubashir. Coming to Dr. Geetanjali, our next panelist. The question for you is, a positive nutritional status, as we have seen from many studies, has a big impact on maternal and neonatal outcome. So from your experience, at what stage we should start addressing it to avoid its adverse effects or complications? And also if you can comment that being an obstetrician, in your experience, what else you think needs to be addressed before a woman conceives or starts her pregnancy? Over to you.
Very good morning to everybody. At the outset, I thank the organizers for giving me an opportunity to share my thoughts on this platform. And I bring warm greetings from my institute, Asnijlingappa Medical College, Bagalkot. So ma'am, your question was about when we should start this preconceptional approach to women. And I think given the fact that Dr. Hemang just presented that most of the pregnancies are unintended, forget about unplanned. So it's very difficult to catch these women before they are trying. And I think in my 20 years of serving as an OBGYN, I've had 4 women from my part of where I work, the rural communities, 4 women who came to me and said that we're planning a pregnancy, so please tell us what we need to get tested or do before. So I think it's really very, very, of course, India is, though it's one country, we are talking about so many different kinds of scenarios. And so I think that not labeling that adolescents are the ones who are going to become pregnant and not looking at them only as focusing that they are the ones who are going to become pregnant, so let's look after them. But I think that's a stage at which we can target. So I would like to share a study that we had done. So the title is here. It was focusing on adolescent nutrition. I will tell you some of the findings that we found, and also a school-based intervention which we found very, very effective. So there was a preliminary qualitative study, and I think, as we all know, we found that pregnancy was a stage which was very, very important for everybody. So the family members, the neighbors, the community, the medical professionals, and the girl herself was very focused on what she's eating and how she is living her life, etc. But adolescence as a window or something which leads on to the pregnancy was underserved, and we felt that this is a good opportunity for us to intervene. And though the government is spending so much of money and maybe a lot of effort and a lot of ways to bring about the the interventions for the uptake of good nutrition and iron and folic acid for the adolescents, these were generally not taken up very well. We found what we labeled as a vigilance versus awareness approach. We also had school teachers as part of our qualitative study, and they used to stand with sticks and tell the children, eat the vegetables. We are giving you the vegetables to be eaten, not thrown. And they used to say that eat the iron and folic acid tablet. I've given it to you to eat, not throw. But the children, of course, found ways to avoid it. So this was perhaps because they did not know why it was important for them to eat and why it was good for them. So creation of the awareness was possibly the missing link, and we felt that a school-based intervention would take care of this. So we had an intervention which was co-designed by inputs from the nutrition experts, to the school teachers, to the community, to the medical professionals. Everybody was involved in what we should actually be telling the children. The material was adapted from the Anemia Mukt Bharat and National Institute of Nutrition websites. We mainly created a colorful book, 30 pages booklet with a lot of pictures which the children could relate to, the activities shown in there or the foodstuffs which are shown in there, which made it all come real to them. And it was to be delivered by the teachers over 7 weeks as half-hourly weekly sessions. 6th and 7th standard girls and boys of 3 Kannada medium government schools were our target beneficiaries. And we did a pre and post test to assess the knowledge, and also interviews with the teachers and the students at the end of the intervention. So this was our interventional material, the resource material that we provided to them. I have a sample of the card. So this is on the Anemia Mukt Bharat website as playing cards. But we adapted them to be something like A3 or A4 sheets as the school wanted. And it's on both sides. The kids reads out, I'm Tuntun Tamatar, I have so much Shakti, I have so much protein, etc. So the children interchange the cards every week, and they learned in a fun way. And this is the intervention in session. And I'll just go on to the main outcomes that we found. So we found, I think the most important thing is that the teachers' awareness improved. The teachers told us that they changed some things in their own kitchens, in their own houses, how they looked after their children. And teachers, government school teachers, being the teachers that they are, they want to pass on this information to the kids. And they did it so passionately, and this was reflected in the students' pre and post results. And we also heard of improved practices. There was no need of the stick anymore. Children wanted to eat the vegetables, saying, oh, the bengan is good for me, and the drumstick is good for me, etc. And they went to this principal and they asked them for the iron and folic acid tablets, because it was COVID and the supply had stopped. They said, why aren't you giving us the iron and folic acid tablets? It's so good for us. And of course, the teachers opined that this intervention was very, very useful, and they said that it should be included in the national curriculum. Some quotes that we had in the qualitative interviews. Some children are not very bright, a teacher said. They have difficulty in reading and writing. Even such children found the book very useful. They used to see the pictures and understand. We have explained to our family members, a student said, we have explained to our family members that we do not get harmed by the tablets in any way. The teachers also take them. They're supplied by the government, but we do not eat too many vegetables, and this incorporates all that. It has lots of iron content. So this was the change that we found at the end of the study. In fact, the teacher, to be very frank, the teachers also used not take the tablet. Though they are supposed to be taking it and showing the children how to take it, but at the end of the intervention, even the teachers started taking the tablets. So to conclude, we had a short educational intervention which we found very effective, delivered by school teachers for the adolescents, and it was helpful in creating awareness about anemia and its prevention. Yeah, okay. So ma'am, your second question as an OBGYN, so this is entirely personal, and at the outset I will just say that this doesn't cover the entire spectrum of the medical disorders that we might encounter. A few lines about each of them. So anemia, as ma'am already told in the beginning of the panel, we generally as OBGYNs, we target delivery time, by which time the woman has to become non-anemic, and then we are very happy with that. But there is enough studies to say that even at the beginning of pregnancy, if the woman is not having enough of iron, then her baby is going to be affected anyway. So preconception is the time at which we should have better iron stores for the child to grow well. And the government has many schemes in place, but visibility of these schemes is not there. The beneficiaries do not know that these schemes exist, and that's why perhaps there is a poor uptake. Over diabetes, of course, somebody who is already known to be diabetic, because of the risk of anomalies, we want their HbA1c to be very well controlled. Anybody who has an HbA1c of more than 10 would definitely be advised to not conceive because of very high risk of anomalies. HbA1c of 6.5 is ideal, but anything which is lower down is good. And I think the one important thing about preconception is somebody who has got GDM today is the potential candidate for being diabetic, overtly diabetic in the next 3 to 5 years. So they require a postpartum follow-up, not just one visit, but maybe yearly visits before you can declare either that they're safe because the lifestyle modifications have led to improvements or not. Preeclampsia awareness, somebody who's preeclamptic today knows that she's already at high risk for preeclampsia in the next pregnancy, or she has come with her sister. Then talk to her that yes, you are also at increased risk. And coming for ANC care early, starting aspirin early at the time that it is useful is going to be definitely of benefit. There is also some studies which show that yoga and meditation for women who are at high risk of preeclampsia has decreased the incidence and could be something that we need to explore further. Hypothyroidism, luckily most of the hypothyroidism we see is subclinical hypothyroidism, but somebody who is hypothyroid right now needs to know that she has to come early in the next pregnancy so that she can start, either an increased dose might be required for her. Obesity, cardiac disease, epilepsy, chronic medical conditions, including hypertension, increased patient awareness, how pregnancy will affect her condition, how her condition will affect pregnancy, lifestyle modifications, optimizing to the extent possible before the pregnancy, and importantly, change of the medication to something which is safe in pregnancy. I see so many people continuing enalapril or continuing the sodium valproate when they should have definitely been changed to something else. Becoming thalassemia aware, I think this is something which because we see iron deficiency anemia to such a great extent for all the anemia that is there in pregnancy, we forget the other parameters. But thalassemia, of course, because if both partners have thalassemia minor, we could have a baby affected with thalassemia major, and this is definitely something that we should not have in our practice. Cascade screening, that is the screening of the relatives of one index case. But there's thalassemia minor or thalassemia major, screening the relatives is something which should be done, but maybe because it's got so much of implications, social implications, that my daughter will not get married because she's thalassemia minor. So people don't want to know and they don't want to get screened. But there are examples of countries which have actually been able to come down with their incidence by doing this kind of screening. A simple review of the CBC, which is a test which we order for every pregnant woman, a complete blood count, not only looking at the hemoglobin. Yes, hemoglobin is important. RBC count, RBC indices gives you a clue that this could be a case of thalassemia and not purely iron deficiency. And something which I'm very passionate about is the PPI-ICD. So this woman is healthier, this baby is healthier, and the future baby will be healthier. The family is happier if we use PPI-ICDs. Perhaps there should be more of a push from our side. Counseling in the antenatal period and at the time of delivery will increase the uptake. I also have a few friends of mine who said that they're not comfortable using the PPI-ICD because they feel that they're not well trained enough, and also because they find it difficult to remove the copperty after a cesarean section. So I think some amount of training also and more push from our side will see that this intervention is up there.
Thank you, Geetanjali. I was, really impressed when you presented in the research conference at Belgavi, the present presentation. So I wanted to speak about it here also. So I think the adolescent is the best time for preconception counseling, because recently, just 2 days back, I got a patient who had 7 miscarriages. And then again, she came at 12 weeks of gestation. So, this is the scenario in India. So they don't get the opportunity to do a preconception counseling, take care of them. So adolescent is the best time, and we have several opportunities, like Foxy is conducting menstrual hygiene programs, IMA is conducting menstrual hygiene program, we are talking about PCOS, we are talking about HPV vaccination, the cervical cancer prevention. So a lot of platforms can be used for these nutritional. I think that's the best thing. With the parents, we can counsel them regarding this. The second one is the hypertension. I'll just give you an example. We had, I think Parag is witness to it. We had a call from Tripura that 25% of the maternal deaths are happening because of the cardiovascular failure. So we were really shocked. We are talking about the hemorrhage, we are talking about the lot of things, but why this cardiovascular failure? The reason was that the hemoglobinopathies were missed in that region. In the tribal areas, they are not able to take the blood pressure properly, so most of the times the blood pressure is missed. So again, PPH is also one of the interventions, because anemia and PPH both are linked. So we are going to train some of the tribal areas where we are taking these 3 interventions, where I was talking to Anchita. It is being funded by the Gates Foundation. So it's small amount, but still we need to do a lot of things, and at least we should not miss on anemia, we should not miss on hemoglobinopathies, we should not miss on diabetes, we should not miss on hypertension. Just my experience when we did a Vistrit project with the USAID in Jharkhand in 40 facilities, you will not believe the prevalence of GDM in those areas in the private sector was just 5 to 10%. But after the training with OGTT 75 gram, it went up to almost 35%. So 30 to 35%. Lot of challenges. They were using glucon C, glucon D as a 75 gram glucose load. They were not asking the patient to come at the correct time. They were not aware about the cutoffs for GDM. So lot needs to be done in our country. So these are some of the interventions that we need to look into, just because an adolescent is the best time for counseling for preconception care. Thank you so much, Gitanjali.
So that brings us to the last panelist. Dr. Parag, I would like you to throw some light on how best we can incorporate or integrate preconception care in our existing healthcare scenario. And also if there are some existing initiatives, either in private or public sector, and how best to address at programmatic issues, the funds, the platform, the guidelines, etc.
Thank you so much, Dr. Preeti, Dr. Aarti, and organizers for this opportunity. I can't speak before I hear all of you, because we heard about a lot of evidence. Now it's time to action. But before I begin, when you look at my, I would say, a session title, and if I ask you a number, please let me know what comes to your mind. And the number that I want to ask you is 17. Look at the title and the number is 17. What comes to your mind? Any thoughts? Anyone? Age, okay. Because we just spoke about adolescence. Number of years it takes from evidence to action. Anything else? Exactly. So while Dr. Hemang's point is also almost somewhere there, but what Madam said is absolutely right. Number of programs that are there right now in RMN and CHS space. So initiatives or existing interventions that we can actually leverage if we want to do what all our esteemed panelists have just mentioned. And in fact, 17 is the lowest number. We know that all health is a state subject, so different states have different interventions. But today I'll just briefly tell you what are those initiatives which we can actually leverage if we really want to incorporate all the evidences from global, national, the environment related, adolescent nutrition related, and some of it I'll also speak about mental health and how we have actually utilized the existing initiatives for incorporation of mental health initiatives. Because as we know, if I'm not in a good mood, I'll not probably, do what I'm intended to or expected to do, or I might go for some sort of a substance abuse or something, right? So let's get into all that. So very simple slides and not going to make it very complex also. But there are n number of government initiatives all along the continuum of care, right? So preconception care, though it's currently getting mentioned as an intervention which is not at all addressed, I agree on that. But there are opportunities, there are platforms where we can actually, integrate all of these ideas that our panelists have mentioned. RMNCHA, like I said, 17 plus interventions. There are dedicated family planning programs that are running in the country, have run in the country, and have shown the result. There is a national nutrition mission, which is known as the, one of the most important convergence related mission that got launched in 2018 by our, ministry and known as Poshan Abhiyan. Obviously, there are RKSKs and, Ayushman Bharat Wellness Program, Ayushman Bharat Health and Wellness Centers actually also got launched around that time, which provides us opportunity to talk about wellness, right? And probably for the first time, you have professional right at the health, right at the village level, who is actually talking about wellness, who is actually providing services not only for the care of the woman or managing her diseases or family's diseases, but actually talking about wellness, conducting yoga camps, and even doing the nutrition-related counseling for that matter. So all these different platforms is something where we have n number of opportunities to integrate preconception care, right? So there should be a targeted interventions and indicators along these RMNCHA strategies, right? So currently the entire framework might not be covering it. We all collectively might have to do a lot of brainstorming, like Dr. Hemang mentioned at the start of his talk, that when we were working on this panel, and thanks to Aarti ma'am for facilitating a lot of conversations, because it helped us to actually identify those potential gaps, and we realized that these RMNCHA indicators that we monitor today might not be actually catering to preconception care related pointers. The subsequent one could be the packages, right? And there are a number of packages. The latest one that we have been able to develop with SIF support is a Sukhi package, which is getting considered in state of Karnataka. The full form of which is mentioned there, but it actually talks about different layers within the preconception care that can be, that can be of interest if you're thinking of capacity building, awareness generation. The one thing I like to also mention, which Gitanjali ma'am, talked about, is PPISD, right? So we all know, some of us might have heard about Mission Parivar Vikas. It's a very interesting initiative and very, very proactive initiative of Government of India on family planning. And there are three very, critical ideas in that, and I'll just mention those. There are many other packages to it, but one is there is a vehicle for awareness called as Sarthi. Right? Again, to ensure that it is actually locally embedded, right? So, say Sarthi van is actually goes on the ground, not only during election campaigns, but actually goes on the ground and talks about family planning related, messaging. Can we leverage all of that for some positive messaging around preconception care, right? The second one is about Saas Bahu Sammelan, right? The Sammelan of mother-in-law and the daughter-in-law. So again, we know that whenever a couple gets married, the first question or the first pressure in the family is, pota kab aayega, nati kab aayegi, right? So the thing is, how do we leverage these Saas Bahu Sammelan ideas, which have been we have been there for family planning, right? Probably we can actually leverage and take all these different interventions from different trials on those Sammelans, right? The third, and the point I want to mention is that there are existing initiatives which provide us such a good platform, right? And they have lot of acceptance that is well demonstrated for years to come. Now, beyond, many times, and as we go more aspirational, we have Foxy leader with Dr. Preeti's, like Dr. Preeti here. So not only public sector, but private sector has also come up with many initiatives, right? And many a times Foxians or the professional associations are led by clinicians. So some of those interventions are clinical in nature, right? But those interventions, because they have been well demonstrated for years, also provide us good opportunity to integrate some of the preconception care related ideas or interventions, right? So let's say one very well-known one is Manyata. It actually supports private small nursing homes or small hospitals on better quality for antenatal, intrapartum and postpartum care. But it starts with antenatal care. So can it start from preconception care? Absolutely yes. Why not? So we just have to add those layers to the existing work. And I'm very glad to share that the current Foxy president, Dr. Sunita madam, and I'm sure Dr. Preeti will talk about it, has actually come up with a presidential flagship initiative called as Sampurna, which is on Swastha Janma Abhiyan, which is on preconception care. So the entire dream of current Foxy president, respected Sunita madam, is to mainstream preconception care and position preconception care and ensure that every pregnancy in India is a pre-planned pregnancy, right? And not the unintended or unknown ones, right? So these opportunities are, are really, really interesting. And I just wanted to mention that even in private sector, we do have a lot of places where this can get integrated. 15 minutes. Yeah. Now, how do we do it, right? So I just talked about platforms, but how can we do it? How do we do it, right? So this is one example, and we tried this in with Government of Madhya Pradesh in Jabalpur district on integrating mental health services, right? These are, you may find it as a complicated slide, but just to tell you, it's a 5-pillar approach in which the first thing is simplify complexities, right? Preconception care, yeah, nutrition or mental health, you have every other person giving you some other counseling, right? It's very easy these days. But how do we demystify the scientific, evidences that all my esteemed panelists have already talked? But how do I demystify it? How do I simplify it? And how do I take it to not only to frontline health workers, but also to the directors and managers of the health systems? Because they also need to have that confidence that yes, I can manage this, right? So that's sort of a demystification. The second one is I know everything, but I don't practice it, right? So that particular gap, just training is not going to help. So that is the second pillar. And for mental health also, pointers are mentioned there. But for mental health also, what the attempt that we tried is to ensure that all the knowledge is into skills and all the skills are actually also getting practiced. And when I say skills, it could be as simple as that the ability to question, ability to elicit responses about any of the, awarenesses that we are trying to, or the topics on which we are intending to create awareness. The third thing is streamline workflows, because many times, like medical disorders got discussed here, but many times you screen people, we identified that there is a problem. But if I'm a auxiliary nurse midwife, if I'm a CHO and I don't know where to send the patient, when I know that they have some trouble, but what to do next? Every time answer cannot be the regional center or a district hospital or a private doctor in the block. So I should be having that complete understanding about the workflow, And in Jabalpur, like I was saying, we have been trying this in collaboration with NIMHANS and Government of Madhya Pradesh to actually institutionalize screening solutions and then the stepped cut approach for the subsequent response, right? So I'm just talking based on that experience. And finally, we will definitely identify clients who need additional care or a special care. So linkages and connecting them to that levels is also important. Overall, this is again a simple, just kind of an infographic to tell that and it's like a Venn diagram, right? If we are really doing it, we have to have a overall situation analysis, because India is not one country, like many countries in one country in a way, right? So when it comes to context. So can we first have a very thorough situation analysis, identify where environment solutions are of prime importance, identify heat pockets, identify areas where substance abuse is at a different level, and then create some sort of an integrable model, in which we also do implementation research, right? So maybe next time if we get something similar opportunity, we would like to share about a couple of implementation research studies that we are trying to do here. Because doing trials is one thing, but what happens when it comes to the real world setting is something that we would really like to, encourage all of us and, every one of us to think about, and then create such platforms where things get discussed about it. Also celebrate best practices, because there are some very good development partner based or driven models that they have already demonstrated. How do we celebrate and then talk about those things? I think that's my last slide, but thank you so much for patient listening and this opportunity.
Thank you so much, Parag. I think you have highlighted very, very important aspects. Though it is always important to utilize the existing platforms, because it becomes very easy to implement those things. So I had an opportunity to work with you on perinatal mental health. It was really a learning experience for us, and we are now escalating to South Asian region as well. So now, thank you, Parag. The only point that we are missing here somehow is the counseling of the male partner. in preconceptional care that we missed out during the discussion. The other one is the genetic screening is also equally important, because sometimes you get genetic diseases and you don't want to give a newborn another genetic problem. So these are some of the important things, because it should be a holistic approach. So the entire panel here, you know, we have experts from ICMR, Dr. Aarti, we have 2-3 people here who are from the research academic background, and we have public health specialist Hemang, Anchita and Parag, and me as a Foxy, you know, or representing some organization or maybe private sector. The irony is that when we talk about the public health, because I have been linked a lot with the public health, the irony is that the most of the concentration is towards the public sector. Somehow, even if you talk as an OBGYN, many of the private sector would not be aware about all those platforms, existing platforms. So we need to bridge that gap of public-private sector, you know, that's very, very important that we need to talk about it. And then we come to the last part of is some of the recommendation pointers. When we talked about heard about all the panelists, we framed some of the recommendation pointers here for you all. So I would like to comment all the panelists just one by one, their reflection on these pointers. Number one, I would start from Hemang. Hemang, what are the inputs? Because we have just 10 minutes. There are certain barriers in our community for providing PCC, and you know, and there are some facilitators, and you know, there are research opportunities also available. So your comments on this, how best we can, you know, go ahead with it.
Thank you. I think now, like as I started, some of the interventions are known in terms of what, but how to implement within government system is something it might take a lot more effort. And as Parag mentioned, there is a need of a lot of, so there are two main aspects. One is a lot more of implementation research, and second is the cost effectiveness of each of those packages. And so in one of the yesterday's session, what I heard was that what would it take for a good intervention to be scaled up in government system. And some of the points, one of our earlier coal secretary had spoken about, that how does an intervention or a program get scaled up in government system, and there are few basic requirements, and those requirements are that intervention should be politically acceptable, socially desirable, technologically feasible, financially viable, administratively doable, judicially tenable, emotionally relatable, and environmentally sustainable. So what we are trying to do here is not easy. So it will not happen if we do it in 1 district or 2 districts or 4 districts. It will have to happen even as pilot, or even in terms of implementation research. It will have to happen in 10 different states, in 20 different districts, which will then give us an idea about all these factors, whether or not it is scalable, whether or not it is cost effective and emotionally acceptable, etc., etc. So it will need a concerted effort by multiple institutions with high risk taking appetite, and then if we implement it in multiple contexts, probably we'll able to highlight the how part of it, and that will be then helpful not just for India but also for some of the other LMICs.
Thank you, Hemang. Your answer was, you know, as complex as implementing PCC in a country. So thank you so much. And now coming back to Anchita, because, you know, Gates Foundation had been a great support for the Indian government, also to the ICMR. So next question, Anchita, to you is that, how would you position preconception care as a national priority for women's health? What are your thoughts on this?
You know, there is enough evidence, and I think if we focus it as an intervention for the future of the country, it finds value. There is a lot of concern about the nutrition and the undernutrition in children, stunting in children. So maybe this as a pathway to lead to better thriving of children is something how we want to place it. The concern, I think, is how do we do it, as Hemang said. There is, after the WINGS trial, in fact, there is a great interest from the Niti Aayog and the leadership and ICMR to see how we implement. There the community was a lab setting, but how do we implement it in the real world? So with their thoughts and our thoughts, and with SAS back again, we are doing an implementation research in the state of Himachal to see how this rolls out. And we're already running into practical roadblocks, some of which Hemang mentioned. One is funding. So if you have to give extra food, पैसे कौन देगा? Filter खरीदना है, पैसे कौन देगा? So those kinds of additional things which do not exist in the current program, where do we get money from? That's one big question. Who does it? Of course, is a big question. And how do we reach out to this group? Because we have to understand this is a very diverse group. Adolescent pathway is one way of doing it. But if we consider that the median age at first childbirth is 21 and the adolescence ends at 19, is that change kind of long enough to carry it through the first pregnancy? And that's the median that we have. So obviously there are many women who are getting pregnant at later stages. And then what about the interconception period? How do we reach out? Some of my thoughts, actually emerge from what Parag said is, let's use something like the Mission Parivar Vikas, where they're approaching the newly married couples with, say, gift baskets, etc., and including contraception in it. Can we add other material to that gift basket about preconception care? Second, I would say when we talk of family planning, we often kind of equate it to contraception. But it is actually about planning. So contraception, I feel, fills that negative space. The actual thing is when you're planning for the family. So maybe our space is whenever somebody is coming for contraception, reversible contraception, we should tell them that when you decide to stop this, please come back to us. Not if, for a change, please come back to us, because that means you are planning to have a baby. We may be able to help you have a healthier pregnancy. So that's something, from a very practical front, if we talk of family planning, help them plan and think this through whenever somebody is approaching us for contraception. So those are some of the things that were just coming to my mind as I was helping other people. But let's hope the WINGS trial reveals something. And yes, there is already interest in the higher leadership.
Thank you so much, Anjita. Now, moving on to Dr. Dhade and all the three experts here. Gitanjali, first I would like to come to you. I think adolescent platform is a doable option. Let's talk what is practical and what we can do for preconceptional care. So what is there in my thought is we'll take your material and through Foxy, we'll try to implement as far as possible in all the schools. So I ask for some of the copies to get into so that we can get it printed. So what would be your recommendation as such for the preconception care as far as the adolescent training and the teachers training, as you mentioned, about the parents teaching that is concerned?
Ma'am, I think we targeted 6th and 7th standard children. That was because the primary school ends at that time, and we felt that there could be some school dropouts who never reached the secondary school, and so maybe actually that's the most vulnerable population, the ones who are dropping out. So perhaps this could be something which is like taken up even in the higher classes, is what we felt. And we mainly focused about nutrition and anemia, but maybe some other things also could, because we're having it over a prolonged period of time, so we could have more material which is relevant to be brought in. And we felt that these children were also very good ambassadors for us. They took back the message home. They were demanding particular kind of food. They were not allowing the mothers to repeat the food. So that's a good thing that they were taking forward. So I think that, thank you ma'am for thinking about taking this forward, but I really think that the teachers' workforce is being underutilized by us.
Thank you so much. Now coming to Mubashir, this is the topic which is less researched in our country. So what do you recommend as a research option as far as the environmental stress and substance abuse is concerned in our country?
So at two levels, at individual level and at policy level. Individual level, I was surprised that there is a meta-analysis showing that yoga has a lot of good effects in reducing anxiety and better pregnancy outcomes. It helps regulate thermoregulation. So one is at personal level, behavior changes. We should really look at yoga as another option, not just for healthy lifestyle, but also for pregnancy. And yes, things that are known to us through maybe school education programs and trainings of our field workers, we can again try to reiterate in them how to reduce carbon footprinting, how to conserve water, plant more trees, things that are known but needs strong reiteration and behavior change to get it done. At policy level, yes, we need to put maternal health into the state climate action plan, and maybe even the Department of IMD can help send, in the antenatal care services, we could add it that they send alerts when there are heat waves or things so that care can be taken about it. Urban greening.
I would like to
Just 2
interrupt
minutes,
and
one
say
minute,
that,
yeah.
we
Okay,
have
one-
to be very concise because the other
Yeah.
session
So much done, but much to go also, and it comes down to behavior change. We really need to take things a little seriously and do our bit. Thank you.
So just last comment and reflections from Dr. Dhaded and Dr. Parag again.
Single sentence.
Just a very small comment from Parag and from Dr. Dhaded, and then we'll close the session.
Just one thing, because it's a area which we all are still learning. I just believe that we should have adequate models in a way across different parts of the country. Not thinking about scale maybe at the start with, because then adequate innovations might not be happening. But pilot to scale, we have to create those models and then take it forward.
Dr. Dhaded.
The important thing is, if we have to implement all these, we need to have adequate infrastructure, because loading the current public health system with more and more responsibilities may not be possible to achieve. And also there has to be a close, linkage between the public and the private health system, so that whatever the private does is, taken up by the public and then implemented for the better care of the public health system. Thank you.
So thank you so much, everyone. The just last comment I want to stress upon is the postpartum period. I think that's a period where the mother stays with you for 1 or 2 days. I think that's the opportunity where we are missing on anemia, we are missing on many of the tests, and we are missing on many of the aspects regarding lactation. So that's a period that we can also utilize, because start counseling from that point of time if she has missed preconceptional
For the
care and
next
counseling.
pregnancy,
Yeah,
it's
thank
very
you so much, everyone. Now, Dr. Aarti.
Ma'am,
Thank you
just-
so much. I had the unpleasant task of cutting this short, but I can see in the audience our World Health Summit president is there. A very warm welcome to you, Dr. Excel Price, and thank you for being there. And a vote of thanks is the most important thing, but it's going to be very hurried, to our President, Indian Council of Medical Research, the Director General of Indian Council of Medical Research, and to the organizers of this World Health Summit, who have done a humongous task but done very wonderfully, and for the World Health Summit President to bring it to India and to give us an opportunity to be there in that very important interaction. And last but not the least, to our panelists and to our chairperson for being there all the time and making lots of efforts. And I would like to thank Dr. Anju Sinha here, who gave us an opportunity to be here, Cochrane India Network President. And for a last, just 1 minute, we have mementos from our organizers. So I would request, yeah, please, sir. It is such a great opportunity you are here. And Dr. Anju Sinha also to please come. So first and foremost, I would request. So I request it for Dr. Preeti. In serial, I would ask Dr. Hemang to please come forward and accept it. Anju ji, आप उस तरफ चले जाइए. I'll request them.
Very interactive and very important session. Very nice presentations.
This is for Dr. Hemang. Dr. Anshita, please come.
Next. Anchita Bhatt.
Yes, Dr.
छोटी चीज़ों में सोचते हैं, पता नहीं कि सरकार को बुरा कब लगे हम लोग। और हर एक सेक्शन से पहले जितने भी हम लोग लिखते हैं, आई ऑल्सो गेट्स का लिखो, मैं सारे पहले पेज ये होते हैं कि सरकार के साथ हम सबसे हम सरकार को मदद करेंगे। जो भी जाति के लिए करते आपको भरोसा क्यों नहीं हो पाता? किसमें कौन थोड़ा गड़बड़ है, उनको अलग से मिलने he also engaged
All the panelists, please come forward.
You did a very well good job from beginning. You spent a lot of time in organizing all this.
Pleasure, because this is something very dear to my heart. I really
So we
feel
are-
so frustrated when we find fields with so many issues. I feel why these people were not addressed, these problems should have been addressed before. Right?
We will be working with Sanju Agarwal. Thank you,
When
madam,
I
for
saw
all
him
the-
sitting, I said, ये तो वही personal photo. फोटो वाले हैं. मुझे नाम ही नहीं याद था. मैंने हिमांग से कहा, मैंने कहा नाम ढूंढो जल्दी से. मैंने कहा एक बार फोटो से मैच कर ले. मैंने फोटो से हिमांग से कहा नहीं परफेक्ट. एवरीथिंग वाज कवर्ड. थैंक यू सो मच फॉर दिस अपॉर्चुनिटी.
मैं कर रही हूँ. We'd request everyone to please sit down for the session. नहीं, Ayako is also there, right? सीट देख लो, फिर सुरभि के लिए एक्स्ट्रा करनी पड़ेगी. नहीं, we need 9. We need one more chair. एक second. smaller rooms here. After this. Oh yeah, the last These are the windows are coming, we'll give you the smallest.
Tight squeeze and maybe number of panelists, equal number of
Should we start? Sir, I'll call you. Don't want to miss the opportunity of introducing you.
The print is coming. Just one moment.
What print? It's okay. तब तक मैं लोगों को बुला लूँ.
So we'll start the recording as well. If we're starting, I'll have to ask them to start the recording as well.
ठीक है. हाँ? Also with ADB. Also with ADB, sir. He's working with us. Okay, we're looking forward to start this session. Tapping the demographic dividend, strengthening the early childhood development. I am personally very excited because of the panel that we have on board, because they're truly the champions of early childhood development in the world, if I may say. So really, very excited. And with that, I would like to start welcoming the panelists. We'll start with Ms. Ji Sun, who's the director at ADB. She of Human and Social Development, so we call it HSD at ADB. She has about 20 years of experience in the international development. She's led various ADB projects in education, skill development, and health and social protection in South Asia. Jisun, we welcome you here. It's extremely important to have a director who's supportive of ECD, and we have that in Jisun, so very happy to have you here. Next in, I would like to call Dr. Dinesh Arora, who is a physician. No, sir, please come. An economist by training. He's currently the principal health specialist at ADB with over 20 years of experience. An unmatched enthusiasm for everything and anything that he does in public health. His mantra is, there's no competition in extra mile. And I know it because I work with him personally, and he truly lives by it. I would like to call Ms. Uma Mahadevan, who's the Additional Chief Secretary and Development Commissioner, Government of Karnataka, handling the Department of Panchayati Raj and Skill Development. She's one of the foremost pioneer in early childhood development in ECD. Her work continues to inspire many of us, and she's truly the champion of ECD. And when you talk to ma'am, you realize there's nothing that you know about ECD that ma'am doesn't know, or any person or network that you could talk about, and ma'am would know about that already. We'd like to call up Dr. Indu Bhushan, who's also my personal favorite because he's a former Indian bureaucrat, economist, and the former CEO of Ayushman Bharat. He's currently the advisor at Pahel Foundation. He has about 40 years of experience in healthcare and public policy. Also, the best boss you can ever have. So if you're looking for work, you should work with him. Then I'd like to call up on Mr. Sampath Kumar, Sampath Sir, who's Principal Secretary and Development Commissioner at Meghalaya. Sir is one of the leading innovators in ECD. We have been working with him, and it's been the most exciting and out-of-the-box thinking that we've been doing with him. So he's really, once again, the champion in the Indian government services for ECD. Then we have Dr. Shivam Gupta, who's an associate professor with Johns Hopkins and also working with Asian Development Bank. He has about 20 years of experience in primary health, health system strengthening, but also when you're looking at monitoring and evaluation in ECD, how to break that into simple terms for all of us to understand, you really get from him. And lastly, but not the least, Ms. Surbhi Chaturvedi, who's the, I should get the designation right, and yeah, Senior Program Officer, Maternal, Newborn, and Childhood Nutrition at Bill and Melinda Gates Foundation. She is, one of those people, colleagues that you want to work with because she's so passionate about the subject, you think you're going to learn more. That's what Surbhi is for me. But unfortunately, I did not get to meet and work with her. But we have a project where it's actually come as an inheritance with her. So thank you, Surbhi, for giving us the ECD Meghalaya project and contributing to that. I hope I'm not forgetting Cynthia. Oh, because you were sitting there. Not least at all. Yesterday over dinner, I was telling her maybe she should be my next boss because Friday nights were so much fun with her. But she's the UNICEF representative to India. She brings with her decades of leadership experience and expertise in championing the cause of children and women. Prior to India, she was working as a UNICEF representative to China. Okay, so these are all the introductions.
Asta, may I come in? We also acknowledge the presence of Ms. Ayako. she's our senior health director. And thank you so much, ma'am, for coming. And perhaps in the end, we will request you for some remarks over the panel and how does it. By the way, Asta, looks like you're looking for a job, right? Everybody you want to work with. So that's the impression which I get once you give the moderating session.
Maybe you should think about promotion, sir. Okay. Since I am the moderator, I'm going to throw a lot of rapid fire questions that nobody's prepared of. Really use this opportunity to put them on the spotlight. So when you ask questions, I'd encourage you to ask difficult questions as well, because that can be fun. And I won't get to moderate them again. And they're all senior to me. So we're going to use that moderator privilege / immunity. But we're really going to start with this one slide that I had. Can we start with that, please? Before we start the sessions, I wanted to show you a story, actually, show you a photo of this woman that I met in Karnataka. They're going to put it up. She works in the fish market, so her husband goes and he catches the fish, and she goes and sells it to the market. You see an infant with her. She's moved to Karnataka from a rural part to work in still rural Karnataka is what we would call, but really she has no support system there. I want you to think, and maybe you will get the answer throughout the panel, what happens to her infant between 0 and 3 before there are any support facilities present with that child. The best she could give was another child who was perhaps just a few years elder to the child, to the infant, right? Moving on to the next slide. In contrast, I wanted to share a photo of my friend, actually. I've taken permission from her. When she had a child, this infant was taken to all the public health policy discussions. I don't know if she'd become a public health practitioner or not, but whether she will have a head start or not, I'd leave it for you to decide. She had a boss who was looking after the child while she was in the office, and that was the right one is the work from home that she got while she was raising her infants. So a really supportive work environment is what I say. Next slide, please. And this is the nurturing framework, 5 principles that most of you know, so not going to spend time. You know good health, you know adequate nutrition, IVCF practices, exclusive breastfeeding, but also think about security and safety, not just physical, but also social, that one gets by living alone in a fish market or handling the child who is just 2-year-old when you are 5 yourself. And also the 4th principle of responsive caregiving. So the parent knows how to interact, how to do serve and return, how to look at the body language of the child. How important are those to get a head start, even if we put them in the same primary school? Just think of those things as we go through the panel discussion. Okay. First, I would request Jisun to start with the opening remarks for early childhood development. She's also our director, so very important, so please make sure that our agenda gets highlighted and you ask good questions so we continue to work in ECD. Thank you. Over to you, Jisun.
Yeah. Hello. Thank you very much, and sorry for the rather cramped spaces. But this is like where the big ideas, like in a small space, like one child's mind, it will grow out of this room and the convention center and then out to the world. So good morning, colleagues, partners and the health professionals and representatives from the government. It's a pleasure to be part of this very important session focusing on the early childhood development, where there are many important topics and then highly technical topics has been discussed in this great forum. I feel this is most critical one because we are here to discuss about our future, which is our children. At the Asian Development Bank, we see early childhood development not a separate segment, but it's a foundation of the development. As ADB is committed to a prosperous, inclusive, resilient, and sustainable Asia and the Pacific, it is not only for our children, but we see this as by our children, as they grow as a productive citizens across Asia and the Pacific, and then they will shape the future. Across the region, many countries have made a remarkable improvement. Especially a lot of commitment has been made. Since 2016, countries across Asia and the Pacific has stepping up their commitment to early childhood development and education. We've seen this through important regional agreements like Putrajaya Declaration in 2016, Pacifica Call to Action 2017, and Kathmandu Statement in 2018, and most recently Bangkok Statement in 2022. Despite these progress and a high-level commitment, the Asia-Pacific region still faces big challenges in ECD. Services remain fragmented. Health, nutrition, and early learning and social protection often operates in silos. There is insufficient support for the ECD workforce. This is like a serious issue. Many caregivers, particularly in the low resource settings, are undertrained, undervalued, and overworked. For example, Anganwadi workers here in India are primarily tasked with caring for children and ensuring their development. But oftentimes, they are given a lot of other tasks because their presence in the community and proximity to the mothers and children. And most importantly, equity is a real concern. While almost all countries adopt universal basic education, but oftentimes ECD is not part of it. And then, of course, ECD is not only about education, it's like a comprehensive nurturing care, as Asta highlighted. Access to and quality of ECD is very much dependent on the family income. Children from poor families, urban slums, migrant families, and those with disabilities still struggle to access service. Inequality starts from the very beginning of the life cycle, and then equitable access to quality ECD is an important policy instrument to bridge the gap between the haves and the have-nots. And then we kind of often call like the earliest intervention is the best equalizer in the equity. Research has shown that intensive investing in early childhood development generate the highest rate of return. That is why a development bank is so interested in this, because it comes with a high return. It leads to a better education, health, social, and economic outcomes. During the first few years of life, about 700 to 1,000 new neural connections form every second, laying the foundation of lifelong learning and behavior, which is becoming even more important in the age of artificial intelligence. And children's brain develop continuously, shaped by every interaction with their surroundings. About 90% of the adult brain is fully developed by the age of 5, making infancy and the early childhood the most critical period of cognitive, physical, emotional, and social development. Investment in ECD, therefore, is a critical step to tap on demographic dividend. As WHO says, there is no better investment than investing in the health and well-being of children. I think UNICEF would also agree too. In Meghalaya in India, with the great initiative from the state government and very innovative integrated approach, ADB is embarking important intervention in ECD, demonstrating the intersectoral and the all of the government approach. And then we kind of very glad to hear from the very man who actually started that innovation in this panel. I'm joined by many eminent speakers today to discuss about many relevant issues and the innovations for cross-sectoral equity-focused investment in ECD. We'll also hear some of the important emerging issues that we need to address while we make the effort to improve ECD interventions. The demographic dividend is not automatic. It has to be earned, and then it starts with the children. Thank you very much.
Thank you, Jisun. With this, we're going to deep dive into some of the questions for each panelist. We'll start with Dr. Dinesh Arora. So, we've been working on, public health professionals have been working on stunting and wasting in India for decades and decades. When we started our careers, we were working on the same issue. But these seem to be very stubborn indicators and this very slow rate of improvement that we have achieved in the country. What do you think are some of the key factors that are contributing to this stagnation, and how can we overcome them? If you can please highlight some of this aspect.
Thank you, and thank you, Jisun, for those over-encompassing comments. Whenever we meet the government, we discuss, the first thing comes is these indicators are stubborn. Let's demystify, why do we call it stubborn? Let me classify these indicators as outcome, intermediate, and process. Stunting, that's your height for age. When I joined health department in Kerala 2005-06, Sheila is sitting here from Kerala, I used to say 50% is stunting in India. Like every second child is stunted. In 2015-16, when I joined NITI, this figure went down to 38%. In last 5 years, in 2021, which was before COVID, it's just 35%. So that means it has plateaued down. Now, when we were students, we were told, it's easy to score from 60 to 90%, but beyond 90%, it's very difficult to get marks. Hey, but what's happening on stunting? They are stopped at 60% itself. So when we are saying 38% stunted, that means only 62% are kids who are normal, and then it's plateauing down. It's very worrisome state because this plateau should have happened at 90%. Something is missing here where we are not able to deal with. The second is normally we confuse wasting and underweights. Now, underweight is your weight for age, and that has improved a little bit, but hasn't improved much. Wasting has been again stagnant. In fact, for the last 15 years, it has stayed at around 19%, 18%. So this is where we are saying these indicators are stubborn. They are not being tackled, and let's come back to it. So I'm surrounded by champions across the sites, perhaps which will work more on solutions, and then perhaps we have, more delve details into that. The third indicator is anemia. 60% children anemic. And now the research shows anemic has socio-emotional, cognitive impact. In fact, anemia has transgenerational impact for even adolescent women when they have pregnancies, especially in teenage pregnancies. And then the dietary diversity. The data from NFHS, and if you believe NFHS data, 11% is adequate diet for our children. And then if we talk about demographic dividend, I think it's a long way to go. And this is where I think when Jisun says, perhaps this is the most critical, I think there is no second opinion that early childhood development is the most important. And indicators have not changed. If we have something, we say that something gets measured, gets implemented, then something is wrong here. Now, let's understand what are those reasons why it's not. It's actually multifactorial. We have been talking in Anganwadis about nutrition. Let's be honest. Kids come to Anganwadi to have food and go away. Sorry, that's a reality. Enrollment is around 40 to 50%, so that means all are not coming. We are not still sure about access, leave us out quality. When we say Anganwadis have to come and become school readiness kids, I'm not sure if we are actually dealing with the criteria of school readiness anywhere. Most importantly, our institutional mechanism is 3 to 6 years, Anganwadis, daycare centers. Hey, I just heard Jisun saying the first 1,000 days are the most important. What happened to first 0 to 3 years? Why is there no solid institutional mechanism, I think, which is now coming up with both these champions sitting next to me, but we haven't seen this happening actually. The Palna scheme has just come, and very, very rudimentary to say because it just covers 10 to 15% of the kids. So why is 0 to 1,000 days, there is no institutional mechanism when we say this is the time when children develop immunity, socioeconomic development, and cognitive development, and perhaps studies are divided that in the first 1,000 days, if children are not coming up to that mark, perhaps stunting may remain irreversible. And this is where the interventions need to start. And the most important point is governance mechanisms. We still work in silos, health, WCD, education working separately. we need a coordinated mechanism, and I think I will request Mr. Sampath. One of the best exemplars has come across is how the ECD mission has come up in Meghalaya, which is multi-sectoral. For 0 to 3, I'm sure we will hear a lot from Uma ma'am, what pioneering work she is doing, perhaps, which should be done across India. I'll stop here, but I think my next point actually will be, when we talk about access here only, nobody is talking about quality. Nobody is talking about the safety of those children's spaces. Nobody is talking about the ratio of staff which is required there. Nobody is talking about accreditation like we have NABH for health. So in fact, yesterday we did talk to Mr. Kotia from NABH and saying, hey, can we work with you in Karnataka and Meghalaya to get quality standards for daycare centers and Anganwadis? And how do we partner with the private players to bring this up on mark? So I'll stop here, but I think a lot to ponder upon when we say early childhood is development, but I think this needs to come into action now. Thank you.
Thank you, sir. Very important point, and also I think a good segue to really talk about what's happening in the country right now. Maybe I'd start with Uma ma'am. Ma'am, you're doing some really pioneering work with Kusina Mani, and while we learned some of it, we were absolutely thrilled to see the progress it's made. We'd like to know about the story as to how it happened, how it evolved, what were the challenges, and how did you overcome them? Because there's lesson there for all of us, all the other states as well. So, ma'am, over to you.
Thank you, Asta. And thank you to ADB for putting together this very, very insightful panel. Glad to be here at the World Health Summit. Karnataka, the story actually starts a few years ago when it all started with 1975 when the ICDS first came into existence with Meena Swaminathan's report, and Karnataka was fortunate to be part of that story with 100 Anganwadis in that first phase, started on October 2nd. That has now grown over 50 years in Karnataka, like rest of India. Karnataka now has close to 70,000 Anganwadis. Now these cater to 20 million kids in the, as Dinesh said, the age group of 3 to 6 is the one which comes to the Anganwadi. But let's remember that ICDS is a very complex scheme which also is supposed to reach out to pregnant women, to breastfeeding mothers, to adolescent girls. That has tapered off to now aspirational districts, but it needed to cater to adolescent girls, one very neglected part of our communities, and also to children between the age of 0 to 3 with growth monitoring, with immunization and feeding practices and so on. Complex program. If you're pulling at one end of the tablecloth, you're pulling away from another end. So in Karnataka, when we realized that we needed Anganwadis to work longer, if women needed to be able to go out for paid work, then we realized that if Anganwadis are working for 7 hours, then you know, it impacts whatever home visits were being done. Which, of course, as Dinesh said, what gets measured gets done. If it's not getting measured, whether the home visits were being done or not, we have to leave it to the intrinsic motivation of an underpaid and undertrained workforce, and feminized workforce, who also have their own other domestic and other responsibilities, given the way our society is. So this being the case, we looked at, in Karnataka, 2017 or so, I remember placing, we had a Chief Minister's review meeting for the state. And I remember I was in planning at that time, not even in WCT. And one of the disturbing indicators was that our maternal mortality was still in 3 digits at that time. And that was not the case with surrounding states in southern India. And we wanted the Chief Minister and we wanted the highest level to look at it for 5 minutes and discuss this. Well, that discussion went on for about half an hour. We talked about what other states are doing, what we need to do, and it was obvious, no-brainer, common sense, along with the research, Heckman curve and all of that, that we needed a life cycle approach, that we needed to target the youngest population, we needed to do things about child marriage, about teenage pregnancy, but also we needed to do things about helping women with better nutrition. So we started many things at that time, and this is another one of the complex things about the sector that we're talking about. we can't choose to throw up only one ball at a time. We need to have several balls in the air, and one or two of those might fall down, but you need several balls in the air at any time. So we said we'll start eggs in Anganwadis. We said we'll start milk 5 days a week. We added a layer of green leafy vegetables. We added sprouts at 11 o'clock as a mid-morning snack. We focused on, I remember showing exactly the 2 slides from the World Development Report to both the Chief Minister, the Chief Secretary, as well as to Anganwadi workers across the state. The slide that showed the MRIs of a brain of a child, 2.5 months old, the well-nourished child and the stunted child. And this is how we communicated. I remember at that time asking about the word protein. In Karnataka, I'm not a mother tongue Kannada speaker, but I asked what is the word for protein. And they kept saying paushtikate. Paushtikate means nutrition. And it was only when we went back to the academics and the Kannada specialists that we found that there's actually a word, Sasara Janaka. So when the word itself is not in our mind map, right, where is protein, energy, malnutrition, and where is the consciousness of bringing protein into the rural diets? The second thing, if you look at the National Nutrition Monitoring Bureau data, protein, availability of protein has been decreasing. Prices of protein increasing. Affordable local protein is not available at the rates that are required. So all of this being the case, we started talking about looking at neighboring states. Telangana was one. I think the MD from Telangana was here, MD NHM. Telangana and Andhra. Neelam Sawhney had started a wonderful program of hot meals for pregnant women and breastfeeding mothers, which we immediately borrowed and started in Karnataka. I remember saying that we will propose a 19 rupee meal every day. Basically, the Anganwadi ICDS cost norm was 7 rupees. We said we'll top it up to 19 rupees using only state resources. This was all the result of that one slide being discussed in the Chief Minister's meeting. So 19 rupees, and then I remember the Development Commissioner, I'm now Development Commissioner, but the then Development Commissioner, all those years ago, asked me, what does Andhra and Telangana, what are the cost norms in Andhra and Telangana? I said, it's 21. So he said, why are you being conservative? We should also ask for 21. So that's how we managed to get it done. We had to do a bit of advocacy, but in fact, the Principal Secretary Finance, Ritesh Singh, was then Secretary Expenditure. I remember the then Additional Chief Secretary Finance had written, please discuss in my file, asking for the 400 crores of additional money. It was the last year of that government, and getting a 400 crore fiscal space in the last year is quite a mammoth task. Ritesh walked over, he spoke to me and he said, ma'am, I'm going to walk over and get this done. I'll discuss it in case. But that's how we started hot meals for pregnant women, 21 rupees, with 4 different kinds of protein, dietary diversity, milk, egg, green leafy vegetables, lentils, and a chikki at the end. But that was only the initial thing. The fact that women were coming to the Anganwadi created a collective. There are incredible superstitions. I still remember the early days. Women would sit facing the wall and eat, right? In the first week, we were getting pictures from the field every day. But within a week, they started feeling so foolish facing the wall and eating that they turned around and started smiling and eating. So that was really exciting times. I still get goosebumps thinking about it. The fact that it could take off. There were various other challenges about caste, for example. Women said that our children will eat, but we will not eat if XYZ caste cooks for us and so on. So we said we'll not bury that under the table. We will talk about it and we'll say how foolish of you in 2017 to be saying this. You all live together, your children play together, you shouldn't actually be doing this. And we said our job is to get the food to you. If you don't eat, that's your problem. Then there were, husbands and in-laws and mothers and so on who said, no, they'll have to walk for 40 they'll have to walk and come this many steps in the sun. But we said a bit of sunlight is a very good thing to do. And then we found that the women themselves were reporting better feeling of well-being. So there was a study done by PHFI, Dr. Giridhar Babu, which actually found that birth weight improved, anemia reduced, gestational weight gain improved of pregnant women. But the most unexpected benefit, which we hadn't actually expected but were happy to see, was that on some scale, mental health scale, the Edinburgh mental health scale, women reported better mental well-being, which was really outstanding. So that was how it all started. But at the back of my mind, there was still this fear that we're not doing anything for children below 3. Of course, we took up certain other steps for adolescent girls and so on. After that, as it happened, Sanjay Kaul and I were on the ECC task force of the Government of India. And by that time, I had moved into Panchayati Raj. It worried me also that we only have this component of take-home rations, which is a mix, a powdery mix for children. Now, powdery mixes are very, very complicated things. They can be uneven in quality, all kinds of quality issues, which we all know of. They can get shared, they can get leaked. If they're good quality, they'll get leaked or pilfered. If they're poor quality and if they get shared within the family because the amount itself is small, just doesn't reach either the child or the children who need it. So we felt that when all the research shows that you need to give hot food several times a day, responsive care, all of that, why are we not able to reach this group? So by that time in Panchayats, we had started 62 pilot childcare centers, just as an effort to see whether the moment had come. These moments come at certain times in our lives, okay, in our careers. I feel the moment for primary education came at the end of the 20th century in India, with Mahila Samakhya, with Kasturba Gandhi Balika Vidyalayas, with all that push, Sarva Shiksha Abhiyan, all of that. We were able to bring girls into school. When I started out, I would take pictures if a girl was going to school, because by and large, the norm was that girls were not in school and they were washing vessels and looking after their siblings. That has changed now with effort. And so here was a moment. I wanted to see whether the moment for childcare for under 3 had come. We found, and I remember we sent a team to young IS officers to the field to 4 districts. People kept telling me it's a need in urban areas. I said, what do you think rural women do? Because we looked at the MG Narega data and we found that there were thousands and thousands of people above the age of 60 who were registered as active job card holders and working on the fields. So who was actually looking after the children? It was the elderly, it was the women with reduced mobility, it was the women who had no option to go out for paid work. And that's why small little babies were falling into bowels or eating peanuts and choking, or different kinds, or just not getting the nutrition or the responsive care or stimulation that they needed. And that's why we started 62 pilot creches. Now 62 pilots where we said that there are 2 legislations. I'll just take 2 more minutes. There are 2 legislations. One is MG Narega, which says that wherever there are women working and small children, you have to provide a childcare facility, and you can use MG Narega wages for a childcare worker over there. That's one. Now, if you have 45 degrees heat and people are working in the dust on desilting tanks, that's not the ideal place for a small child who's 2 years old to be running around, and for a woman with a disability, more often the norm, to be the childcare worker who's looking after that child. That's not ideal. The second is in the Panchayat Raj Act itself, that we had this provision that a creche is a mandatory requirement. This was brought in 2015. However, these legal provisions are used usually as good to have, or as, homilies, or as penal provisions if you want to penalize somebody. But they're never actually activated in a progressive and positive way. We said, what if we tried this? We found 2 years ago in March, the month of March is always another window where you find some savings, and we said that what if we found that there were 40 crores for something which was not getting spent, and we said we'll use this and we'll make an announcement that we're going to do 4,000 creches. I just, we just pushed it, and somehow the magic worked and the moment happened. We were able to start 4,000 creches, able to start. Again, it's not without its difficulties. You get the glass on the table, but it's a leaky glass and you're pouring water and the water keeps pouring out. Panchayat started saying, where's the space? I said, you have to find the space. It's in your act. You have to find the space. Find an old Anganwadi building, find a classroom, find something which is available. and do this. Then people started saying, why don't you just expand the Anganwadi? I said, have you ever seen a 2-year-old child run around? You have 3 to 6-year-old children sitting around and being taught. You cannot give the same care to 2-year-old children, 1.5-year-old children, 6-month-old babies. You have to. Then somebody, it was often men who would tell us, why are you separating the mother and the child? I said, you're taking the child, you're asking the mother to take the child into a dusty, hot area, which is not good for the child, all of this. So we had to argue all of this. We said this 40 crores will be used to give 1 lakh a year to 4,000 panchayats. But the rest has to come from panchayats' own funds, untied funds. You have to provide. These are your children, your community, your this thing. We trained 8 creche workers per creche using Narega, because in Narega you can only work for 100 days at a time. And we wanted 25 days overlap so that the children don't have separation anxiety when new creche workers come in. We said the three things the government will guarantee is 1, safety, 2, hygiene, and the third is quality of the training. So mobile creches became our training partner. We didn't pay mobile creches. Philanthropy came in, CSR came in, and that's how we started. Still a long way to go. We still find that sometimes in the rainy season, the creche shuts down, 1 or 2 months, then getting it started again. But now we have 50,000 children enrolled. At any time, 30,000 children regularly coming. Smaller children, attendance tends to be a bit up and down, because either because they fall sick a little bit, or because the mothers or fathers go, take them somewhere, various kinds of things. But we're getting there. This is a model that needs to work, because we have I have 6,000 panchayats in Karnataka. I can easily take it forward to 2,000 more panchayats. But we have 2.5 lakh panchayats, gram panchayats in the country. Panchayats are the space, because as Dinesh said, other departments work in silos. The panchayats have to work as a local government. And it's not just the job of a local government to switch on the lights and give water to houses. It's also the job of a local government to care for and protect its youngest children. This is an answer for early nutrition. This is an answer for hot food. We're not giving powders. This is an answer for stimulation, which hasn't even been brought into the discourse. This is an answer for identifying developmental delays and issues and responding to them. And this is an answer for workforce participation of women in rural India. Thank you.
Absolutely. Ma'am, to learn about Kusina Mane, we really just need the entire session on that. So thank you for summarizing this. I'm going to quickly go just to Sampath sir now, given that we have limited time. So every time we go anywhere, we hear about Meghalaya examples, innovations. We very proudly, with a lot of pride, say, yes, yes, we are also working on it. But really, you are the mastermind behind it. We'd really like to know, A, what are the innovations, but also what is your motivation and personal journey to continue to work in this space?
Thank you. So, I am also an ECD child. Maybe that was my personal motivation. So, what I just first of all I would like to appreciate what Uma Mahadevan ma'am actually told about the model of the Karnataka, especially the decentralization, impact of the decentralization. In fact, Mr. Amarjit Sinha, I think most of you are aware, he was there with us in Meghalaya for the Civil Services Day. In his presentation, he had shown a slide showing that how the devolution can impact or is impacting the nutrition. So only few states in the country have actually did the devolution up to the panchayat level. Karnataka is one of those states, I think, and of course Kerala and Maharashtra also did some work. So just something that, so the governance is a very important thing. Like the point is that the governance is a very, very important thing to really bring that change. And I also thank, and I was just listening to the initial remarks of the director ADB, G. Song. What she said is that most of these programs actually which are are important for early childhood development are actually run in silos. so this something that the Meghalaya we are trying to do. So I also studied a course. I think maybe I'm very fortunate that I studied a course on science of early childhood development to drive policy and innovation. I studied in 2014. And I came back and I tried to, experiment. And luckily, I got an opportunity during the COVID to, announce through the budget and, So what I wanted to tell you, like I wanted to show this one. Maybe I just asked, Astha to just put this one. This is in fact, day before yesterday photo, in a block. If you see this, I think what do you see in that picture? Okay, so there is a mother. I think you can say she is already 4 months pregnant, and the child is actually taken care of by the grandmother. If you look at, and when we were actually, this is again a governance program, because we actually, there's a team, BDO is standing there with the court. And next is like you have health educator from the health department, lady supervisor, and also the NRLM community coordinator. So basically, I wanted to say, and also there is a BRP from education department. So the idea is that we do this one every week. It's called Human Development Leadership Program, where I think ma'am actually said one more interesting thing: intrinsic motivation. How do you bring that intrinsic motivation? So if you see the problem, then you actually generate empathy. Through empathy, you can create intrinsic motivation. So that was our actually theory of change, trying to mobilize entire, government frontline functionaries to work for this. So, but the challenge you see, the challenge here is what? Gender. In a matrilineal society, in a Meghalaya, are not only matrilineal society, many places like the women actually have taken a lot of burden, gender responsibilities. Child rearing is our responsibility. In Meghalaya is even more because of the division of work. So men does the public affairs and the women take care of the households. So if you what is the gender? So how to actually break that one? So how to actually tell the woman, like she didn't go to school, how to explain to her that like the importance of having that birth spacing so that her child will not be fed by the bottled milk. So and Meghalaya has the highest stunted population under 5. You know that 46.5% of the children population is stunted. So one of the reasons is the gender. We found like this is something that actually, like ma'am, we found this entire idea during the COVID, when we were actually looking at the deaths. In fact, on a daily basis, we were actually finding more deaths among children and mothers. So our IMR, MMR was high, not because of the COVID, just because of these problems like this. So we started actually understanding that what is the best way to really address all these interconnected issues. In fact, if you look at Meghalaya data, our learning outcomes are also very low. Stunting is very high. So we can actually see that there is an interconnectedness of all these problems. I think ECD is the ideal way to focus upon, to bring that interconnectedness and also see the purpose. Our purpose is what? Like again, someone said like we are all for the, children are the future. So how actually, and the very title of this particular thing, demographic dividend, how actually we are going to unleash the demographic dividend. So when 1/3 of the population is stunted, already cognitively compromised, what we are doing it. So I think if there is any investment that needs to be made, in fact, Heckman curve, what ma'am was also mentioned, like 1:17%, like wanting to, for every 1 rupee or $1, you get 17 times return on investment if you invest in the ECD. So I think trying to bring that research, into a practice, that is something that the innovation we are trying to do. As part of this process, we have created at a state level, at a chief minister level, we have a Human Development Council. In fact, Mr. Amarjit Sinha is promoting that this should be there at a national level too. Human Development Council, where we have all these health, social welfare. That's a WCD in Meghalaya, and rural development. In fact, the self-help groups are going to play a very, very important role in terms of positive parenting practices and all. So and then education. So basically, bringing all these, even urban departments, bringing all of them together. So we started actually brought this a governance framework, and also an independent society we have created, where in fact the MD NHM, director education, everyone are additional project directors of this project. Actually, what Mr. Dinesh is a task team leader for that ADB project. So I wanted to say is that like trying to bring that kind of a thing, and it's actually what we are also learning every day. We are learning. Honestly, it's not that like it's basically every day we're learning. We have learned from Karnataka, Kalike ma'am. These people are working with us, and we went to Odisha. Odisha actually doing some phenomenal work in the ICDS, because we are also underserved states. We are not like rich states, ma'am, in the sense like very difficult for us to mobilize public funds for extra funds for so how actually we can use the existing resources. What are the models where even in under resourced conditions, like how actually we can bring that innovation. So we're trying to bring that entire convergence between NRLM and ICDS, and also as I said, like the education, like now we're talking about NEP 2020, where there is a lot of focus on going for ECC. So so this is just like briefly I just wanted to tell you. And we also have come up with the Teach for India fellow kind of a concept called ECD fellows. So where in the villages, like the graduate people actually will do the give the extra caregiver in the Anganwadi center, so that they would be able to provide the better care, because it's very difficult to appoint an extra caregiver in a government, that like it's tough. So we're trying to bring some kind of these kind of innovations. But one of the important things, like what we did was also that we have constituted elected first time like village health councils, and which are given this responsibility of implementation of ECD in the in fact in the state. And we also have SHGs. We have the village organizations have been leveraged a lot. VIVOs we call. They are the new, I think, civil society organizations, I would say, village organizations. They are very systematically run, and they were actually, again, they are the main people actually providing this entire positive parenting and entire nurturing framework, to take it to the communities. We also got best of the best partners, in fact, right from the Gates Foundation, he's there with us now. We have, we are getting, different ideas through that. And, we also have different partners like, you might have heard of this GMCD, it's a tool developed by this one Umeed, which is promotes. So it's essentially to identify those development delays very early, like on every 3 months we monitor the child. So we are training massively all the frontline workers on this kind of capacities of GMCD. We also have Sesame as a partner in terms of getting those early learning ideas. So I think I just wanted to tell you that like partnerships and also providing this collaborative governance framework, I think we're able to come out with a very important idea. And another thing for this mother, if you tell her that like that health educator is trying to teach her this property and all, she will not agree. Only thing she would agree there is that like your child's brain will develop well, and your child will do well if you give that spacing. Then they will listen. I think that I think we wanted to change this entire narrative from the ECD point of view. So with this, I think thank you.
I think just I wanted to flag one issue, because he meant interconnectedness. Let me say one thing. 35% of India's population is today urban. And as urban health is neglected, so is urban Anganwadis or urban childcare. I think that also discourse we need to bring in, maybe more relevant for Karnataka than Meghalaya. But ma'am, when we are working on this, I think this, this issue needs to be also tackled. Thank you. Thank you so much.
Thank you. So just a quick rapid fire for you. In 2030, when you come back, perhaps in this room, or by 2030, what would you have liked to achieve for Meghalaya in ECD?
2030.
2030. Okay. Just a one-line answer, sir.
Yeah. So I'd like to see that like Meghalaya is producing a cognitive capital. so yeah, thank you. Because we have
That encompasses everything. Yes. Okay. Now moving on to Cynthia. Cynthia, UNICEF is the technical partner for ECD. In fact, even in our work, we've tried to engage with UNICEF. I wanted to ask you, what are some of the global best practices in directing funds for marginalized children in relation to the ECD agenda, and how can that be integrated to India's policy?
Thank you. It is so great to be part of this august panel, but it's also quite intimidating. I think I would start with one of the fundamental foundations that I think we often think about, but it's important to put on the table, is that it's the right of every child to have a healthy start in life. And when you think about that, it shifts it a bit, not just for us sitting here, but also for the decision makers. It's not a nice thing to do or a charitable thing to do to make sure that a child has access to quality health care. It's actually that child's right. It also shifts quite a bit an understanding from a parent. Suddenly a parent thinks, well, my child, as you were saying, sir, my child has a right to a healthy start, to her brain developing. So I just put that as a very strong reminder that all of us here know that, but I think we need to remind each other and remind decision makers that this is our accountability to provide that. If that's not convincing enough, a child's right, then the investment case. And we've heard that for every dollar, you have a rate of a return of up to $17. So that's pretty good, and thank you to the bankers for giving us that value. Frederick Douglass, the American author, leader, and abolitionist, said, "It is much easier to build strong children than to fix a broken man." So that was years ago, and it's true. So the case to invest is there. That's my first point, is the rights and the return on the dollar. The second is, let's just follow a child through the case that India has. Pushpendra lives in Uttar Pradesh, and I met him about a year ago when he was just almost a year and a half. He was born extremely underweight and had trouble breathing, of course, because he was so premature. So he was in the hospital for 2 weeks while his mother and father waited to see if he would survive. He then, after 2 weeks, was able to go home, which is the best place in the world to get better. But he was monitored closely by Saratini and Sudatri, the Asha and the Angawadi worker. And I think that home visit, Dinesh, is important. And there, Babita and his father, Gokran, were taught the importance of breastfeeding. They then helped him with complementary feeding when he was able to take on solid foods. They monitored it in the Poshan tracker, and there may be questions about the quality of data that we have, and we have so much data, but the Poshan tracker showed that Pushpendra was off track and moved into severe acute malnutrition with diarrhea and not growing, and then had to make the difficult decision, again with strong counseling, moving him into a few weeks of care for intense improvement. By the time I met him, he was a year and a half. He was growing, he has gained weight, he was thriving, and it was due to that system of being at home, but a strong healthcare system that also had the intense care. But also, his father spoke about kangaroo care and that safety. They talked about, and when we were with the Angawadi and the Asha, showing how to stimulate him with play. So it was that coming together. So I bring that story to show that it has the elements that we have in India that is a lesson that we have taken back and forth. You had the data, the information. Not just the tracking of how Pushpendra was growing, but also giving the knowledge to the mother and the father about breastfeeding, about how to play with Pushpendra. Secondly, you also had the investment. It takes money. And so how do we talk to our policymakers, the deciders about budgets, that this early investment in what and how we look at where we go for a child, in the Angawadi quality of care. We are piling a lot on the Angawadi and the Asha worker. And this equity agenda. It shouldn't matter where a child is born, that they have the right to survive, and then give them the opportunity to try to thrive. So these incredible important elements that we're cutting across this system that we were seeing and learning from. when we look around the world, UNICEF has seen this, and we've taken lessons that we're learning in India, and we're bringing them back and forth. So in Chile, we've seen since 2017 similar growth with Creche Contigo, which has brought together both that home care but also centers of excellence. So by the time a child is 3, you're also preparing them to go to school when they turn 5 or 6. Similarly, in Rwanda, with their early childhood development program, also in between 2018 to 2024, incredible progress, again, bringing together that early care, that understanding and knowledge, and creating a genuine demand across Rwandan mothers and fathers for how to make sure that they're able to have the services they need for those first 1,000 days.
Thank you, Cynthia. I think this panel needs to be taken to Chile to learn the ECD model well. Now I'm going to move on. We've discussed how many factors are contributing to malnutrition. There's some other factors that get missed out, and I think lead poisoning is one of them. So I'd like to ask Indu sir if he can talk about how can the issue of lead poisoning impact ECD. So really explain that to us first, and then how can this be dealt with in India?
So thank you, Asta. And we've been talking about what we are doing for ECD, and I'll talk about something which probably we are not doing. There's something called South Asian enigma. That in South Asia is the only region in the world where the correlation between economic growth and early childhood development is missing. We have increased our incomes. We are growing for more than 6% per year for last 2 decades almost. But that has not translated into improvement in child health, especially malnutrition. And people are scratching their head that why is it happening? And of course, there are known knowns, known unknowns, and there are unknown unknowns. Yes. And in my view, there's something silent and sinister going on in terms of lead poisoning. And the data that we have coming from UNICEF, Pure Earth, is that 1 in 2 child, 50% of our children have blood lead levels which are higher than what CDC or WHO recommends, more than 5 microgram per deciliter. So the question is that how does it matter? Because we are all of us breathing air which in Delhi, and we have so many impurities in our system. So how does it matter? It actually matters a lot for children because their membranes are very porous, and so the lead goes into their brain, and it has direct impact on their cognitive development. And the research have shown that even at a very low level of lead poisoning, there is impact on their IQ. And there was a recent report from Center for Global Development which has shown that the difference between IQ of children between developed countries and developing countries, especially South Asia, large part of that could be attributed to lead poisoning. And not only in terms of impact on IQ, it has impact on their behavior. I was actually mobilizing some resources for lead work, and there is an organization in the US, and they were keen to support me. And I said, what do you do? They work in prisons, and they wanted to, so I said, why are you interested in lead poisoning? They said, because lead poisoning is linked to violent behaviors, and if we can reduce lead poisoning, violent behaviors will go down, and population in prisons will go down. And it is actually very clearly has been established that lead poisoning is also linked to violent behaviors. And thirdly, lead poisoning is also linked to anemia and malnutrition. It's a very direct link. And like earlier mentioned by Dinesh, that's intergenerational things, intergenerational issue, because pregnant women have lead poisoning and they pass it on to the children, and the children have that high lead levels. And so that has impact. So in fact, now the current research also shows that it has impact on NCDs too, in terms of diabetes, hypertension, heart diseases. There is a clear link between lead level in blood and those diseases. So it's something which is going on in a sinister way. In the US, they have been able to reduce level of lead in a big way in last 40 years after they had banned lead in petrol and then paint. We've been actually slightly slow in implementing many of those regulations, and we still have that problem. Now the question is that what should we do about it? So first thing that we should do about it is that we should ensure that children don't come in contact with lead. And we have a recent research which is shown in Tamil Nadu, which is done for cookware in Anganwadi workers. And cookware in Anganwadi workers, because we buy cookware through L1, they are usually from recycled metal. And from recycled metal, it shows that in 100% of those cookware, lead leaches out, and the food which is made has lead. So I think we have to make sure that they don't come. And the same thing happens with paints, because the cheap paint still has lead, and all the their playhouses, most of their toys which are coming from China and other places have paints which have lead, and they put it in their mouth, and that leads to lead poisoning. Other thing that happens is through cosmetics, because we are very fond of putting kajal in the eyes of children, and most of the kajal which we get in the market have high level of lead. So we have to make sure that children don't come into contact with lead, either through personal use or through the environment where they're living. So that's one. Second is that, and we've been actually promoting this with Ministry of Health and Prime Minister's office, that we should have a program on lead where, like it happens in the US, that every child who's 2 years of age is tested for lead, and if the lead levels are high, preventive measures are taken so that exposure to lead can be reduced, because it has such a influence on their not only cognitive development but also physical development. So that kind of program has to be put in place so that we can take care of that. And third is that we know that there are some industries which have a very high exposure to lead, and one is lead acid battery recycling and places around that. And many of other industries also have very high exposure to lead, and we need to work with the workers and communities around those industries to make sure that that is reduced. So I think there are many things which have been done, especially in our neighborhood in Bangladesh. They have done some very focused interventions, like ensuring that haldi, which is actually a big source of lead in South Asia, especially the haldi that we get, the turmeric that we get from open sources, not the from formal sources. Informal sources, the turmeric has a high level of lead because it's used for making it yellow and making it heavier. And so that actually was focused by Bangladesh, and they made sure that it doesn't happen. And many of these things actually have to come from education, and by ensuring that the existing regulations that we have, which are world class, are implemented. So that has to be done. But while doing this, before I finish, I want to also say that when we look at all those children of the future, we have to see who are these children. As you know that in our country, TFR has gone down in many of the states, and in northern states, TFR is still very high. And if you look at families, the educated families have very low TFR, and future children are largely going to be coming from some northern states in large proportion, and families who are not as educated, and from rural areas. So again, this exposure to lead has a large equity element, because all these families that I'm mentioning are more exposed to lead. And so we have to also see that, in our future plans and programs, lead poisoning becomes one of the integral part.
Right. Thank you, sir.
Thank you, sir. And the two champions sitting next to me both have agreed that in the ECD program, we will have lead as testing and lead advocacy as one of the important components, sir. Thank you.
So rapid fire question for you. One low-hanging fruit for policymakers in implementation. One. If one thing they could take away immediately and do it in their states.
just have testing facilities in and they're not expensive. You know, I have been going around and talking to many states, and I was actually distressed to find that even some AIIMS don't have testing facility for lead. And so I think
it's
just
easy to
doing
make-
that, so that unless we know the problem,
Okay.
we don't, we can't do anything about it, right? So
Yeah. Great, thank you, sir. This was a very interesting discussion about lead. Even I learned a lot. So we're going to zoom out again and go back to the broader ECD framework. And coming to Surbhi here, really. Surbhi, we've learned nurturing care framework is critical. And I'd like to ask you, what are some of the life stage appropriate interventions that the children, that can put children on a health, growth, and development trajectory?
Thank you so much, Asta, and thank you so much for inviting me to be on the panel. As Cynthia was saying, you know, there are people sitting on the panel who actually move things on the ground. So I was wondering what is it that I will bring and what do I say? I'll try and bring some data points and some technical intervention knowledge on this one. So I'll try and bring in some data that's, because ADB brings financing and others bring governance, so we'll try and bring in some technical knowledge. So I
Very
think
holistic panel.
so Dinesh actually, yes, I was actually working with ADB. Yes, of course. Sorry, ADB brings financing and knowledge. No, but my journey on, I've been working in nutrition for a few decades now, but it was really, the culmination of being formally at ADB and working with the government of Meghalaya, where we were really able to, mobilize, think about, what the research says, what are some of the interventions, and how do you layer it in the system. So I think that has been a privilege, and thank you again for having me. Dinesh talked about stunting is a very stubborn indicator. We have not really moved it. I know it's been a very stubborn indicator, but I'll also bring in, some work that has been done through the global exemplars on reduction of stunting and what has driven the whatever gains we have made, what has caused and what has contributed to it. Something that has come out from research is, of course, definitely economic growth does contribute, the household socioeconomic settings, all of that contributes to the reduction. But few things that when we think of systems and interventions that has really contributed is maternal health parameters change, measured by BMI. The prevalence of low birth weight, so the birth outcomes improving in different countries and specifically for India as well. And also access to antenatal health services through the health system. So the robustness of the health system, the services that are provided have really contributed. And if we look at from 2005 to 2020, the reduction in stunting in India itself, about 40% of this reduction can be explained by the three things that I mentioned. What's also, because we talked about that, you heard from Uma ma'am, you heard from Mr. Sampath Kumar, all of the things that they are driving. I want to say that, India's had some right evidence-based policies, and you've heard about how it is being translated on ground. And I just wanted to bring in that, a lot of it is making a difference as well. Now the question is, how do we go to, the incremental gains that we get from some of our efforts? How do we make that happen? And so it's always good to go back and look at meta-analyses and evidence and large data, which helps us get some sort of insight into some of this. And I think end of 2023, a meta-analysis was published that looked at longitudinal birth cohorts, what was leading to reduction in stunting, how things were happening, when stunting starts happening. So what is the incidence of stunting as well? And this analysis actually showed that a lot of children are born with stunted. So, the highest incidence of stunting is actually happening at birth. Then the incidence, the next stage is 0 to 3 months and then 3 to 6 months. And of course, it continues in the first 1,000 days as well. But, this is where one thing to note, it makes you stop and think that how do we actually change the birth outcomes itself. So one very, I don't have my slide right now, but one there is this paper by Harold Alderman which captures that, the idea is there are healthy birth trajectories and there are always risk factors and protective factors in a child's environment. And when the risk factors are dominant, the child is put on a below potential trajectory. So combining this, how do we improve the birth outcomes? How do we improve the healthy trajectory? I think some of what we have heard today, we need to continue focusing on 0 to 3 years, of course, but also look at maternal nutrition. I think one thing that we need to also understand is we talk about nurturing care framework here, which has 5 dimensions. Asta was referring to that, the 5 principles. Now, sometimes it's a very nice infographic and it's very relevant, but people get lost in what is the intervention within each of these principles. I would say a couple of years ago, the foundation funded a study, and this was actually Dr. M.K. Bahan's vision. This was led by Dr. Neeta Bhandari, Dr. Rajiv Bahel, and others. They designed a phenomenal study, the WINGS trial. I think it's quite famous now. Maybe a lot of people over here are familiar. And when you look at the interventions, the detailed, what did they provide, within the health aspect of it. So they moved from like 4 ANCs, which are usually what we look at, they moved at 8 ANCs. They really focused on screening and treating for infections, RTI, STIs, really screening and treating anemia as well. They focused on providing preventive interventions like multiple micronutrient supplements to pregnant women. And they continue to really one thing that I feel like sometimes get lost, and I think Uma ma'am had mentioned it briefly, they really focused on using the Thinking Healthy program, the maternal mental health program, starting from the pregnancy and going till in the postpartum period, to make sure that women have that all the information and all the counseling that is provided for child care, responsive caregiving, etc., is provided using the adapted cognitive behavioral therapy in a community setting, close to their home, by the community workers they are familiar with. So the WINGS trial really focused on a lot of all of these things, and as the children were born to these mothers, they continued to provide responsive caregiving, really focusing on learning through play, etc., that we've heard and talked about earlier in the panels. And so now, one thing that I want to talk about is that they took the nurturing care framework, they put in what were the interventions in all of the 5 dimensions, when it should be provided, and the results are astounding. And I'll very briefly share what this, the children born to women who received the intervention in pregnancy and early childhood, the reduction in stunting for children at 24 months, it was the risk of stunting reduced by 51%. What's also really important to look at, there was benefit on the low birth weight itself. So the low birth weight was a very critical mediating, it was a effect modifier when we think of, how do we go and make that incremental change on stunting and, get the higher marks as well. Is it time? Okay. The last thing that I'll say is, because we are talking about the return as well. So just as of this month, the team published a cost-benefit analysis as well, and they found that for $1 invested, the return is $9.9, $10 if we provide this in the context of India, in setting in northern India. So I think I know the range is up to 17%, but even this I feel is a very, very good return. And so hope the bank will continue to fund these projects. Thank you. I'll stop there.
Thanks, Surbi. Very helpful. But I would have asked the rapid fire, but we are short of time. So just want to move to Dr. Shivam Gupta, who's also from ADB and the associate professor for Johns Hopkins. Just wanted to highlight that we are bringing in technical knowledge. He's working on our impact evaluation work as well. So there. Dr. Shivam, we want to understand from you, what role can real-time data systems play in strengthening accountability and improving outcomes in early childhood development programs in specific?
Thank you. Thank you very much for having somebody who does. First of all, thank you very much for inviting me to be part of this panel.
After the time thing happens, they start doing like that.
So, thank you. So, it's very interesting and important to listening to all this comments around early childhood development. I'll focus primarily on monitoring and measurement. That is my area of expertise. So, Asta talked about real-time data. The issue here, as far as measurement, ECD, or in general health system measurement, as Dinesh is finishing his DRPH at Johns Hopkins, and I'm happy to say that he mentioned outcome indicators, intermediate indicators, and process indicators, and that is where sort of the magic is happening here. So at least from a measurement point of view. So in ECD, several states in India have been monitoring as part of ICDS, and then the recent design changes. A lot of the measurement focuses on these inputs and processes: health workers trained, supply chain availability, nutritional supplements available. So those are inputs. And a lot of time and energy goes in measuring that nutritional supplements are available, the health workers are trained, modules are revised. Then there are the set of indicators around outcomes. Outcomes around, we're talking about the stubborn stunting indicator, but also community participation, community perception, quality of care is an important intermediate outcome. The real-time data, the question that Asta asked, the real-time data that comes from HMIS primarily focuses on inputs and processes. Outcome data on stunting, community participation, does not necessarily come from HMIS routine information system. Outcome data is harder to measure methodologically and also takes longer to change. Stunting doesn't change that quickly. So there are methodological issues, but also the other part of outcome is that is where we want action. So outcome is also linked quite strongly to decentralization. So how Karnataka does things and how Meghalaya does things and how Rajasthan does things, that is the space for innovation given to these states in their governance. How do you reduce stunting? How do you improve maternal nutrition? The trial we heard about is one sort of standardizing the way of doing things. But each state, India being a continent, not necessarily, so the focus on outcomes of stunting. So my sort of take-home message on this would be to the real-time data gives us, HMIS data gives us a lot of information on inputs and processes, health worker availability, nutritional stuff. Good to measure, but what moves the needle is when you actually measure the needle. And the needle is stunting, maternal nutrition. Measuring, focusing outcomes in using high quality data, these are methodologically challenging. That's part of the reason why people not do it. The other problem with measuring outcomes, it leads to accountability. You will be directly held responsible for quality of care and stunting, not how many kits distributed. It's easier to measure how many kits distributed. Moving the needle on outcomes or quality of care, part of the reason, Dinesh, why we are at 65%, that the remaining 30-35% is where quality of care comes in, and that is why it would need to be measured. So there are methodological issues, focusing on outcome, and that also gives the states the innovation for doing things differently. Last but not the least, we can also look at the issue of intersectoral, multi-sectoral work. Real-time data is available from each sector separately, even though it is an input process. What is also needed in this time of technology and artificial intelligence, that this real-time data from one sector talks with the data from other sectors so that we can see that holistic view for early childhood development. So that's another part which can be done with real-time data but requires technology and newer thinking. And there are examples available of that, but we just need to do that at a larger scale. Thank you. I'll stop here.
Thank you, Shubham.
Thank you. I just thought I'll take 2 minutes before you open the floor for discussion of Ayako. We also have Jane, and I wanted to bring one new element, like Sir produced the lead poisoning one, how climate is influencing mother's maternal outcomes and fetal growth. Maybe, and she's doing some pioneering research in India. Maybe off the record, if I can just ask you, Jane, if you can just share this in 2 minutes. And before I go, I just wanted to acknowledge that Nina from Niti Aayog has also joined our team. And Pooja is working very closely with Sampath sir. Both are here also, who is part of the team working with us on the ECD. But Jane?
So can I just say one thing? Just because Shivam said accountability, I'd just like to say that we're doing an impact evaluation of all the work that's happening in Meghalaya. So clearly Meghalaya government is very open to accountability and has allowed the program to be structured in a way where they want to continue to improve.
Thanks, Dinesh, for the off-the-cuff surprise calls there. So my name's Jane Hurst. I'm an obstetrician and Professor of Global Women's Health at the George Institute for Global Health. And as Dinesh mentioned, one of the areas we work on is this intersection of climate change and women and children's health. And we're working at the moment with partners at TSHTI, with Professor Shinjini Bhatnagar and her team, who have the large Garbini cohort, so looking at the effects of environmental exposures, both air pollution and heat and other exposures during the pregnancy. And from their data, they have data on early childhood development and outcomes as well, which we hope to work on in the future. I mean, I think the evidence here, we have some quite consistent evidence about the effects of heat on pregnancy outcomes, preterm birth, stillbirth, etc. What we don't understand is who are the most vulnerable mothers to this, because clearly with 25 million plus babies every year in a hot country, not everyone is having a preterm birth and things. So how do we target interventions to those most at need? But importantly, for babies that do survive, what is the longer term outcome for those children? And I think it was mentioned, sort of when you have, young babies and young infants in very hot environments, what is the effect on their brains and their development being in those settings too? So I don't have the answers to all these questions, but just to say this is, a really active topic of research now, and happy to talk afterwards with others in this space. So thanks.
Thank you, Jane. Ayako. Didn't mean to startle you, but can we just have some key takeaways, last words, or closing remarks from you, and then we'll open the questions for the audience.
I knew it. I was also scared to death that as soon as I start talking, the big bell will start ringing, right? So,
no, we have time.
Okay. All right. No, thank you very much. Excellent presentation, and then we have a lot to think about, and of course to take action. Maybe a few things, and then first of all, I think Surabhi just reminded me of what is the primary expectation from an institution like ADB. Obviously, we are trying to bring fun to some of the most important development problems and issues that our member countries are facing, and obviously early child development is one. Then I've been thinking, why in ADB, despite about knowing the problem, why we have not been able to do as much investment, as much as we wanted. So a few issues, and then the first one, you know it very well. Somebody was also mentioning about yesterday, we're talking about issues of One Health, and then the person was talking about fragmented collaboration, right? So because ECD is such a multi-sector, issues, in ADB we don't have ECD specialists. Right? We have health, education, we have social protection specialists, we have urban development specialists, we have gender specialists, but we don't have ECD specialists. We go to government, I will say, okay, I see we would like to work with you on ECD. We talk to who? Health, education, social welfare. At the end of the day, we go to the planning agency. planning agency often do not execute programs. So they do coordinate, they do planning, but they're not necessarily professional when it comes to real investment. So this is where we have a problem. So I think one solution, and I really hear you very well, it's about how robust you could have this governance framework, right? The governance framework that gives you an overarching result framework on what you want to achieve. We have an issue of when we're talking about channeling ADB funds, we have to look at what are the expenditure framework. If the expenditure framework is cut across so many ministries, we have a difficulties. So how you bring also the expenditure framework together to the extent possible, right? So once we have this governance framework, that's the first step for ADB to say, okay, can we do more together? How can we help you more? And this is where I really, really have a respect to the two representatives from the states government here on the models that you are building with a lot of issues, what I understand, but that helps also institutions such as ADB to help you. So I think it's really this governance framework that matters. Second, as you know, there are many, many priorities that the government bring. And as you know, whether we like it or not, development has trend. So maybe now ECD is a trend, tomorrow it's going to be different. It's going to be different. Now, compared to, for instance, talking to a country about youth employment issues and ECD, which is more attractive, right? We are talking about youth losing job and having societal problem compared to ECD. ECD, as we all know, we all agree it's a child right. We all agree that there's a huge, huge return when it comes from the economic point of view, right? But this is not enough. So therefore, again, really appealing on a good models coming from municipal government, state government, and countries. And that helps ADB, again, to help. Lastly, again, knowing the problem is really something that important, right? So lead poisoning, I didn't know much about that last year. Now I know more because our own vice president covering East Asia and Southeast Asia Pacific Island, he's leading that work. So now we got to know more about lead poisoning. The research that Jane is doing was also, it's still an eye-opener. I didn't know about, the impact of extreme heat into pregnant women, lactating women, and a birth outcome. So we need to know more about. So we're ready again here to support any evidence-based knowledge, data, and research that matters to human development. That's all. Thank you very much.
Okay, we're going to open the floor for questions, knowing that we are done with time, but the other panel also took extra 5 minutes, so we should also take that. But before that, feel free to reach out to the experts outside in the corridors as well in case your questions are not answered. They're very interesting models. And open for questions, please. Okay, we'll start with 2 questions. I'm going to need help from someone. Okay, I'll move to
I just want to say one thing. The room was small, but there were too many people. The best part was nobody moved out during the discussions. Yeah, and that's something is actually a metric for me. The needle for me is that nobody moved out of the room.
Whom do we go first? Wherever. Okay.
Thank you very much. Fantastic presentations. Just one quick question. We've talked about the investment case. Very clear, everybody agrees. We've talked about the multi-sectoral components, and thank you for bringing the nurturing framework and what it actually looks like on the ground. Now, in implementation, we've talked about governance as a vehicle, But if I may ask this question, what would be the biggest barrier to really getting intersectoral engagement from state to district to community level to really lens in the efforts that we have under ECD to get that result? The investment case, if I remember correctly, actually is not just that we're doing ECD. It's a multi-sectoral engagement platform that gives us the $17 return on investment. So how do we really translate that in terms of making it happen at the state, district, and community level?
Can we
Thank
know
you.
your name and
My name is Zelalem.
organization?
My name is Zelalem. I work for UNICEF.
Thank you. And I think I will pass on to Mr. Sampath first, because we are implementing this and we are breaking this barrier. But let's hear from the horse's mouth.
So, no, the biggest barrier I would say is that basically the purpose. You know, understanding the purpose of, you know, as a state, what is the purpose? You know, so I think if we can. Basically, if you can invest on bringing that purpose among the leadership, especially at a different levels, I think we can really break those barriers. It takes some time, but definitely that's how do you really restore the purpose? Otherwise, what happens is that there is a concept, you know, that like donut, you know, concept center is missing. We are all talking about everyone. So, what is the purpose? The child should be the center, you know, not the programs. You know, I think if you can bring that.
Thank you. One last question, and then you can reach them separately. Maybe a woman.
Yeah, go ahead, ma'am. Go ahead, ma'am. Don't wait for the mic.
Hi, I'm Shonali from Sesame Workshop, partner of the Meghalaya Initiative. But I just wanted to sort of from experience say that culture eats strategy for breakfast. And it has taught us deep lessons. So while we heard great evidence-based initiatives, but the focus on culture, and we know that for the case of Meghalaya as well, and how are we integrating that into our design, understanding that that can really upend projects. So are we conscious of that? Are we giving enough timelines, enough budgets to actually handle those variables?
One more question, then we answer this question.
One more question.
Can I ask? Okay.
My question is for implementers, that what is the role of technology? Now we are moving towards digital health, and there are a lot of digital interventions happening in the area of health. And also to Dr. Shivam and Cynthia, that what are the experiences in other parts of the world where the technology plays? My name is Angad Karande. I work with ADB.
I think so. Culture, as you said, is inbuilt, and we need to work on this. So in Meghalaya, the interventions which we have classified is one at home-based, center-based, and community-based. And community-based is where the culture comes in place. Village health councils, when they own it, you know, they bring their own way. We have faith institutions working there. We are conducting meetings, doing brain wiring exercises with them. Point totally taken, and this needs to be customized at every level. You're partners with us there. So I understand this is more of an observation rather than a question to us. Sorry, we do not have time, but on digital, Angad, this is the backbone for us to do this. Yeah. There are two ways I look at this. One, you should have a technology which is there. We have a portion tracker, we have HMIS system, but they don't speak to each other. The idea here is to have like a ECD mission or a health mission speaking to each other. And then the second point is adoption. We are having technologies, we are having apps, but we are not using it for decision making. And that's a point, I think, which is being drilled into Meghalaya. And we hope to do the same in Karnataka when we are working there on these lines. But absolutely, technology will drive it.
I'll just add one line, which will respond to both Zelalem as well as the question about culture eating strategy for breakfast. There were three things. One is that, you have to trust local governments because departments work in silos. That's also government culture. Local governments bring the pieces together. That is one. Second is, what is our understanding of development? We talk about early childhood development, but development as such is usually understood as roads and bridges. So we have to break that and unpack that as well. And the third is about, again, culture. The biggest challenge that we have faced is that care of children below 3 is seen as women's work. It's deep patriarchy at work. Why should women's workforce participation be important as long as we're generating the person days? Why should the whole question of separating a mother and a child seemed to be so suspicious because you're actually providing for the need of a mother. So the patriarchal angle is the one that is the hardest one to crack, and we're still working at it.
Can I request for one picture? Ayako, can you join us for the picture?
Can I request,
For a picture.
We'll do a panel photograph, and I'll request Ayako and Nina to please join us for this photo. Pooja, Pooja, are you there? Jay, do you want to please join us? Please, please join us. So,
Not done? Sorry.
thank you.
WhatsApp. I don't have my. Yes.
I didn't get your name, but it's fine. I didn't get your name. Okay, sorry. Sorry, I'm going to request if people can talk outside so the other session can start. I would request everyone to step outside so other session can start. Thank you.
Also, I don't know, like you know,
I don't know. Acha.
Yeah, we can do it.
How do I do this?
Just like you have to, I'm sharing, ma'am. There's a net is some issue, otherwise it quickly, it actually goes.
Should I unlock it or something?
I'm sharing. Maybe your Bluetooth is okay? Otherwise, I'll just take your number from.
Yeah, just tell me.
Yeah,
Tell me.
99. Culture eats strategy for breakfast.
Yes.
And I would say that leadership eats culture for the lunch. It is actually the leadership.
Say hello finally.
Shivam, lovely to meet you. Shalini has told me so much about you. I'm very
Okay. So, before he runs.
I'm leaving now.
So I will see you in Washington.
Super.
In 1 week.
Look forward.
And then
Yeah.
We will work together in Karnataka. Very nice to see you, and thank you for all the great work you have done.
Okay, great. The same thing. Like from, yeah, you also like, You are very familiar face. You are Krishnan. Yes. Where are you working?
So there's another session going on about urban health and the funders roundtable. Both our chair and the moderator are there. We'll just take 2 more minutes and then maybe we can start. Welcome from KHPT and also from the organizers, meanwhile, by the time they actually come in. Sorry, we can't find chairs. We've asked them to find chairs for everybody. I don't know if we can, though. Yeah, thank you so much. So, thank you for joining today and officially welcome. Um, uh, and I'm happy to see a packed hall. Hope we have a fruitful 1.5 hours ahead. At the outset, I'm Dr. Pratna, representing KHPT as of now, and we are an NGO working with multiple thematics within the health sector. And currently, we are hosting a few sessions in World Health Summit. And thanks a lot to the organizers for giving us the opportunity, both the WHS and NIMS. And not taking your time up, I want to invite our moderator, Dr. Anuradha Jain. She's a health system specialist. We are lucky in the panel that we have a lot of expertise from different levels, and she represents the health system expertise. Ma'am, thank you so much. And she was just in another session, so she's rushed from there, and thanks for that as well. I'll just take 1 minute to go to the context of the session. When we started actually working on women beyond uterus, we just basically trying to think of women beyond periods and pregnancies, whether there is anything at all beyond this, or whether we restrict ourselves to this. I mean, or are we being, should we question ourselves on the way that we have actually looked at women's health? Is it health of the women, or is it women's health, or is it maternal health? Is it what? So some of these questions, which I think a lot of us have in our own minds as well. And I thank the panelists a lot because they gave me so many insights, and I hope we can all benefit from those as well. I'm handing over to Dr. Anuradha for everything else. Our chair is Mr. Anant Bhagwati. He'll be joining us in 2 minutes. The next person whom I want to invite on stage is Dr. Shivkami, and she's from Tata Institute of Social Sciences. And she's an academician with a lot of expertise in gender and health systems. And then there's Dr. Pawan Kumar, who is Sir Additional Commissioner from Ministry of Health and Family Welfare, Government of India. Sir was actually nominated from the ministry, and thank you so much, sir, for giving me time in the evening for actually listening to us. And he's very important to us as well because he's heading the whole maternal and child health portfolio within the government. And then is Dr. Praveen, who is an intervention cardiologist. Praveen, please. And he is from Narayana Hridayalaya. He is an out-and-out clinician, and he is pretty much feeling like fish out of water in our public health platforms. But I'm hoping he'll learn to swim by the end of 1.5 hours. We'll help him swim. And then there's Blessina. She is the CEO for Global Coalition of TB Activists, a very warm person and a very vocal person for patient rights, and she doesn't like me using the word patient also. She has taught me that I should be using people with TB or people with any other disease. So yeah, sorry, Blessy, for actually again using the word. And then there's Dr. Anna. She is a microbiologist from University of Columbia. So, and she has multiple degrees as well, and she brings a lot of experience from South American region. And then there's Maxine. Professor Maxine is a medical anthropologist from James Cook University, Australia. And I'm hoping that her data insights will again help us for the session. Thank you, and over to you, Dr. Anuradha.
Good afternoon, all. Am I audible? I am audible because I have a loud voice, and I hope there are not people online. No. Okay, so this is, am I audible? Yes. The mic is not working, but you're audible. Yeah, it's not working. Welcome all of you. Our chair is still missing in action, and I'll speak from here. That's a better idea. Yeah, hi. So good afternoon, everyone. This is a post-lunch session, so I believe half of you may doze off, which is absolutely fine. But you know, the speakers are so vibrant, and I've heard them speaking in our conversation. I'm very sure you're not going to do that. Anant is missing in action because he's in other rooms, so let me start. And without wasting your and the panelists' time, the topic today is very important, and one of the questions the panelists asked the organizers were, what is the outcome you are looking at? And so I'll start with what outcomes are we looking at. So to be very honest, this is a conversation that may not have a very concrete outcome at the end of it, but what we are trying to look at, the issue where we are talking about a women beyond uterus, is looking from the lens of what the data says and what the evidence is around the fact that even if a woman is in the reproductive age, she's not about producing babies and doing family planning. She has other comorbidities that she undergoes, and how the data is saying that those comorbidities need to be addressed. The post-COVID era is showing that the effect of various diseases on a woman is as as critical as on any other men, and the world has moved on from the way it used to function, where men used to go out, work, and come back, and a female would take care of the household. Now it's a equity world, and women is as much under pressure, and how morbidity is affecting a woman is something, the evidence that two of our panelists would talk about. The second lens that we are going to use is more from a clinical facility-based lens, where we are going to talk, one, on the national health programs, of how they are addressing an integrated approach to women, what is existing and what needs to be still done in those programming. And the other specialist who's sitting, who feels like a fish out of the pond, as somebody just said, would be talking about a very, very important topic, and the topic would be what he observes in his clinical arena of how women take their own health and how they reach his tertiary level much, much beyond than they should be coming, so that he can provide an ample care to them. So he would be looking from that lens. Last but not the least, our other speakers would be talking the community perspective of it. What is the socially ingrained structure that does not let women seek health or allows a woman to seek health? What can you do? So let's not take it from a negative lens by saying does not allow, but let's look at from a very positive lens. What can be done so that a woman looks at health seeking more positively and tries and approaches either a primary or a tertiary system. So that's how our panel is built today. Thankfully, Anant is here. He'll take over. But once Anant is done, I think we'll start the panel. Thank you.
Hello, everyone. It's nice to see a small room, cozy room, and lots of people here. And hello to my panelists. The topic here is obviously something which is close to heart. I just wanted to start with a few quick questions. How many of you feel that NCDs for women is a big issue? Non-communicable diseases. Okay, how many of you think, like, just this is a quiz, if 36 per 1,000 is the male stats of NCD, NCDs are basically cardiovascular, diabetes, hypertension, and cancer. If 36 is the number out of 1,000 for men, what is the number for women? Shout it out. 50? 40? Okay. 60? Well, thankfully not. 62. 62. So 36 and 62. Now, is this something which is common knowledge? Maybe. Is this something which is common action? Maybe, maybe not. Is this something which needs to happen now? Very much so. So, in some ways, I just wanted you to think of that statistic obviously we have a very, very eminent group which cuts across different profiles. And before we get and hear more about them, I think 2 points really I'd love for us to speak about and the audience to think about is, as we think of women's health, there has been a disproportionate focus on really SRH. The reality is it's very important, but this statistic which you just heard, it essentially is telling us that there is much more. In fact, if you were to look at statistics across, for example, mental health, you'll find, unfortunately, the prevalence is higher, not just because of anything else, but simply because of the cycle that a woman is subjected to. Now, the point is, it could be argued that public health without women's health is actually not going to even make a dent. So the question really right now is, why does it not happen? And one of the things that we find is because there are silos in the system. There are silos in terms of academics, there are silos in terms of philanthropists, there are silos in terms of government. This does not cut across. So simply put, women's health needs to be seen more like a horizontal, which cuts across all elements of health. Today, love for the panel to share more thoughts about that, but also think about what's needed to happen for this to happen in a big way, so that, for one example, in X years from now, instead of a 62 per 1,000, that number can be potentially lower than 30, because ultimately, if some of these don't kick in, we'll have a multiplier effect on our country. Thank you.
Thank you, Anand. Thanks for your opening remarks. And I know our time is limited, and I would like to give more time to the speakers as well as audience to ask their questions. And without further ado, just a housekeeping announcement that I will be a little stricter on time so that we have more question and answers, because that brings out the beauty of your knowledge more than just giving your remarks. So please, bear me on that. I would like to start with our, the question on identifying the problem per se. And can I request Dr. Sivakami to please come forward and give us some guidance on that, what data says about the Searo region.
Thank you. Thank you. It's absolutely, absolutely wonderful to be here. I love the post-lunch session, because most of my classes in TISS is post-lunch. So, I know how to keep the students awake. So let me try. So let me start off by saying that we have made significant progress in women's health. I want to make that very clear. We made significant progress in women's health over the years. Yet, we have a long way to go. I think that's why we are actually going to be talking about. We are really meeting at a defining moment in our history in public health. In South Asia, we must elevate from a side agenda of women's health to the central pillar in our national and the regional strategies. I think that's the defining moment that we are meeting here. Across the South Asia, women are underserved, not because inherently they are vulnerable, because we have failed to see women beyond the uterus. We have failed to see women as whole and women as full. That's the reason I think this panel is so important. And drawing from our recently published 2 volumes on sex, gender, and health, perspectives from South Asia, one message I want to actually make it very loud and clear, which is gender disparities in health are not incidental. They are systemic, they are predictable, and they are preventable. I just want to make that very clear. They are preventable. What does the large-scale data and also the lived experiences say? I think that's where I'm standing here. In our synthesis confirmed that. Women face delayed diagnosis. Women have diminished voice, not just in the community, but also in the health system, across the health system. Our synthesis using the life cycle approach reveals that women's health needs are boxed into narrow reproductive health brackets. The chronic disease, mental health, disability, health issues in the later reproductive years, and the aging issues are treated as peripheral or invisible. While many of us know women in South Asia live longer on average than men, our synthesis point out that they live sicker and with fewer healthy years, which is a paradox, which is what I think it's important that this session brings us to. Let me take few key messages. I think our chair started off by looking at the data on non-communicable disease. Non-communicable disease now represent the leading causes of morbidity and mortality among women across South Asia, with the widest male-female gap in Nepal, where NCD death as the proportion of deaths from all causes is 47% for males and 63.3% for females. For other South Asian regions, the difference vary between 1 to 11%. Yet, cardiovascular disease in women is underrecognized and undertreated in the region. Further disaggregation of the data shows that this higher burden of NCD death among women in the region is due to the higher proportion of cancer deaths among women than the men. Yet, cancer services are far-reaching for many women. Coming to the risk factors, because for NCD, risk factors is a very, very important determinant. The prevalence of physical inactivity and obesity are significantly higher among women, especially in India, with 25% physical inactivity in men and 44% of physical inactivity among women. Similarly, the obesity, and obesity is actually 2.7% for men and 5.1% for women. Next to mental health conditions, including the depression, anxiety, and trauma are significantly more prevalent among women. In all South Asian countries, if you look at the DALI loss to mental disorders are higher for women than men in the age group of 15 to 49 years. However, the stigma and the weak mental health infrastructure across the region in South Asian regions actually kind of silence both the suffering and the response. Now, when it comes to injuries, that's another thing that we look at. When it comes to injuries, often we all know that the men have a higher proportion of deaths coming from injuries than the women. Although the proportion of DALI associated with lost from road injuries for women is only a fraction of men's, because men have a higher burden, road injuries constitute a significant proportion, really significant proportion in three countries: Bangladesh, India, and Sri Lanka, ranging from 5.8 to 12.2%, which often do not get noticed. Infectious disease remain persistent. Our synthesis shows that women are often lost to seek care due to caregiving burdens or intra-household decision-making hierarchies, which are leading to later diagnosis and worst outcomes for disease like TB, HIV, dengue, and malaria. Gender-based violence. I know that many of you in this hall would know that gender-based violence is an old issue for many of South Asian countries. We've been working on for 30 years, but still is both a health emergency and a human rights violation, because South Asia ranks alongside Sub-Saharan Africa as one of the 2 regions with the highest known prevalence of IPV, with 35% of women aged between 15 to 49 years experiencing IPV in the lifetime, and 19% in the 12 months before the survey. So, health issues in later reproductive years and older years are neglected a lot. Issues like perimenopause and the consequence you won't hear, we barely have any evidence. We have so little information on older women and their health needs. And lastly, evidence on the health and well-being of transgender persons in South Asia is limited, and whatever the evidence that we have, it's often viewed from the HIV/AIDS umbrella. Their health needs beyond HIV/AIDS umbrella and their unique health needs, we have minimal understanding. So women may be living longer, but they are living sicker. That's a quiet epidemic and the elephant in the room that we must confront. The critical driver of the problem is what we do not know because we have not measured it. Too many of national data systems in the region are blind to sex and gender disaggregated data. We are not disaggregating our data by age, geography, migration status, disability, or other intersectional vulnerabilities. Disaggregated data is not just a tool for measurement, it's a tool for transformation. And without robust intersectional data, we cannot understand the true scope of inequity. What we do not know, we render invisible. It's time we move forward with ambition and urgency in generating robust evidence for women beyond the uterus and use it frame our policies and programs, because the question is no longer whether we can afford to act women beyond uterus. The question is, can we afford not to look at women beyond uterus? Thank you so much.
Thank you, Dr. Sivkami. That was a grand opening, I must say. And you raised a very important point, systemic. So systems are not allowing certain things to come on surface. And we would like to hear from you, Professor Maxime, what is the micro and the macro data gaps that obscure accurate identification of disease burden? Because what you don't see, you don't measure, you don't measure, you don't act.
Thank you very much, and thank you to the organisers for inviting me to come to join all of you. I just want to start first with the inherent bias that we've all inherited into our health systems and into the corpus of underpinning knowledge like anatomy, physiology, biochemistry, neuroscience. And that is that most of these have been based on the typical 70-kilogram white male. Although coming from a country that there's not that many 70-kilogram males around anymore, it's not doing its purpose even for them. So that's a problem we have, and I'll explore that when I come particularly to innovation. And as was already said, even when we view women as necessary to include, and that's not that very often, it's still those things that they exclusively experience, pregnancy and all things uterine. So the need for gender disaggregated data, both quantitative and qualitative, and its analysis has often been seen as unnecessary, a complication, an expense, a waste of money, because of this deep-set bias. So what sort of data do we need? I've broken it into two parts, data for service and implementation and data for innovation. So service and implementation, firstly, we need to think about utilization of services from prevention through to palliation and end-of-life care and everything in between. We need to look at the role of a woman, and when I use women, a woman, I want to also include all genders, but the title was woman for this panel. But being a woman affects utilization and creates data gaps, therefore, in what we collect and therefore what we analyze. We need to have disaggregated data, but we need the system to look for that. And that may need to be complemented with qualitative data. Secondly, acceptability and accessibility of services. And here the role of qualitative data is extremely important. Although in the wonderful session I just went to about EPI data and the role of digital, we are bridging some of those gaps for some health programs, but it's not being extended across all. And we need lived experiences to be highlighted as part of what's important in any data we collect. Thirdly, we need to think about needs. What are the risks? What are the vulnerabilities? And how do we collect this data? Of course, we can collect it epidemiologically, we can collect it through clinical trials, but we also need to look at it qualitatively. The National Institutes of Medicine in the US in 2001, maybe this data's not there anymore, concluded that being male or female should be recognized as an important variable in all health-related research, including biological, cellular, organ, and social behavioral. For example, women who smoke are 20 to 70% more likely to get lung cancer. Differences in pharmacokinetics and pharmacodynamics may change the safety, efficacy, and adverse reactions from all health products. Women's roles, risks, and vulnerabilities are really important to include. For example, brucellosis. Women who are involved in milking, livestock breeding, animal care often are not put into the data, but they have increased risks of transmission of brucellosis. Women are less likely to produce sputum with TB, and so therefore are more likely to be socialized to feel uncomfortable to cough in public. And so we get an underdiagnosis of TB in women. And TB contributes more than all causes of maternal mortality to women's deaths. And we also know that TB kills more women than any other infectious disease. We may need to go beyond routine health information systems for this data because it is often inadequate to provide such social stratification and depth of understanding and lived experience. And don't forget intersectionality. So women are not just women. All of you in this room also have different other identities. And that needs to be taken into account as well. So data for innovation, like developing diagnostic tools, clinical treatment. Firstly, it is often not inclusive. It tends to be often male. And it is, even if they do include women, it's often not disaggregated in that analysis. Some examples of what hasn't been done and the consequences. Cardiovascular disease. Only 1/3 of the women in cardiovascular disease clinical trials in a study done a couple of years ago were actually women. But 50% are more likely than men to be misdiagnosed. Alzheimer's and diabetes too affect men and women differently because of diagnosis, the prognostic classifications, and the treatment. ADHD women are diagnostically more likely to be introverted, disorganized, and scattered, whereas men are more likely to be hyperactive. And in an autism review done last year, of 120 brain imaging studies for autism, 70% of them were only done on male brains, less than 10% on female, and the rest they didn't state. Yet all of the diagnosis, classifications, etc., are based on those studies. Pain. Women do suffer more pain than men. It's not emotional. It's not just that we're having one of those periods of time. It actually is real physiologically, and that's been proven when you look at pain pathways. And in head injuries, women recover from head injuries differently. Women are twice as likely to have concussion than men and are slower in recovering from it. And I'll just finish with one case we've been dealing with in the work I do in the Greater Mekong sub-region in malaria elimination. An RDT to diagnose, a rapid diagnostic test which was qualitative based, look at glucose 6-phosphate dehydrogenase, and we need something that can be done as a point of care test. It actually was under and over diagnosing deficiency in women because women, it's a hereditary disease and women have only one, not two, carrying it on their gene, so they're heterozygous. And so that meant either women being diagnosed as deficient and not getting the treatment for Vivax malaria and the subsequent problems for that, or were being said to be, to actually not have it and therefore get the disease, get the treatment and have the consequences of that. Many countries have removed that, but in the design of it, initially it wasn't a gendered analysis. Thank you.
Amazing, Dr. Maxime. And I cannot go to the next speaker without taking half a second to tell you an anecdote in one of the slums in Mumbai, where I met a woman who was using very efficiently, at that point of time, the organization I was working was looking after the maternal wallet for women. And maternal wallet is where women keeps her money, and during maternity she uses it. And this woman I spoke to, she said, I said, why don't you keep your money in bank and why in a wallet? Why do you need a wallet? So she said, oh, I have a Google Pay and I keep paying for my things from Google Pay. When it's in a wallet, I can't use it beyond my maternity time. So I said, you don't have an Aadhaar card. Why don't you just go to internet and look at how to get an Aadhaar card and get your Aadhaar card done? She said, sorry, I am not that literate to go on and look at those intricacies of getting an Aadhaar card made. So, when you design things, a literacy for financial payment, which is so user-friendly, versus getting an Aadhaar card itself changes for a woman. And we are talking about big things like morbidity and mortality here. So with that anecdote, I would go to our next speaker, Dr. Pawan, who comes from running a national program for women in the country, and Government of India is, dedicatedly looking at, Ayushman Mandirs, where integrated primary health care is being provided. So I would invite you, sir, to speak on how integration is being practiced in primary care in India, and I think we are one of the pioneers in this country who's looking at women in such an integrated way.
Thank you very much for giving us an opportunity to discuss about maternal health. And I was wondering about this topic once I was invited for this. Women beyond uterus, actually. So task given by Government of India me is to look after the uterus, basically, for during. And today I will be discussing beyond uterus. So. So, because I'm an additional commissioner, I'm a national program manager for looking after the maternal morbidity, mortality during that pregnancy period only, very important period of that life course of every woman in the country, and that should be a very enjoyable period for every mother to become pregnant, and that pregnancy 9 months and delivering a newborn, coming a newborn into this world is a joyful period for each and everyone, all of us. So coming back to the progress that India has made in last 3 decades about the maternal morbidity and the mortality, the big words, big jargon words, but they are very important at the international platform. We stand at a maternal mortality ratio of 80 per 100,000 live birth as per the latest UN MMEIG estimates. Target for SDG 70 by 2030, and the trajectory by which we are progressing about the maternal health in the country, we are pretty sure that by before 2030 we'll be able to reach 70. So beyond uterus, because for uterus means the pregnancy, and beyond uterus, as madam has told about the Ayushman Arogya Mandirs. So Government of India have brought many strategies, interventions. Government of India is also looking beyond uterus for the women health. One part is with the uterus, the women health, and one is beyond uterus. So today I will discuss about beyond uterus only. So beyond uterus means integration of, in an opening session by our chair, other colleagues from different regions, about the NCDs, non-communicable disease. The most common is the CA breast for the country, the most common cancer if you talk about a non-communicable disease. Second is the cervical cancer. Third is the diabetes, the hypertension, the pregnancy-induced hypertension, the infections which are, and then injuries, road traffic accident, then geriatric problems, then menopausal problems, then oral cavity problems with the progression of age, eye problems, specs problem, hearing problems, all are beyond uterus. And the Government of India is looking after all programs actually. Under the one umbrella of Ayushman Arogya Mandirs, we have 12 packages under Ayushman Arogya Mandirs, which talks about not only the family planning, maternal health, child health, but beyond that, talking from NCDs, means screening of cervical cancer with high precision, VIA test at the sub-center level, the PSC level, so that as early as we can pick up the cervical cancer. And once we have pick up the cervical cancer, the management, timely management through the secondary and tertiary care system, CA breast, self-examination, palpation, then infection control measures, then eye, ENT, oral cavity, all these issues, they are very important. Important strategy of 90, 70 and 90 for the women actually to eliminate cervical cancer by 2030 from the country. Means if you give a cervical cancer vaccine to 15-year-old age, 90% of the population, and if you are in the middle age of 35 and 40, having high precision tests of screening for the cervical cancer and pick up cervical cancer as early as possible. And then once if you are detected, if you are in stage 1, 2 and 3 and 4, having a timely management of the secondary and the tertiary care system under the Ayushman Arogya Mandir. PMJ scheme is there, which is basically a cashless scheme for the people which are there in the country. Then elderly and the palliative care. Because women, as she grows beyond the menopause, around the menopause, during the out of pregnancy period, then taking care of that part at the Ayushman Arogya Mandir, then to and fro referral mechanism from Ayushman Mandir means primary health center to the sub-centers and then upper level to the community health center, then sub-district level. How you manage that, that is also important. The government of India, almost 1.7 lakh Ayushman Arogya Mandirs which are working in the country, and having a dedicated 12 packages for the services, then having a 12 package of laboratory test near to the vicinity of the women, because women neglects herself. She take care of the father, the husband, the kids and everything, and she doesn't take care of her. If you provide services within the vicinity where the woman lives, in the morning she takes care of her, the morning household work. Then around 11 o'clock she finds time for herself and goes to the sub-center or PHC, or Ayushman, where she get detected for all those elements, maybe a hypertension, which we will talk about in cardiological issues, the NCD issues. Then we can have a obesity problem can be there, the nutritional problem, the anemia, that is also can be taken care of the Ayushman Arogya Mandirs. I think these all activities that, then most important is the yoga, which is being a part of one of the package of Ayushman Mandirs. If you have visited some of those sub-center where the mat is there once in a week, there the tutor is there to just teach you the importance of a yoga, medication and all those things, they are very important for the women of the country. And during that period of a women health, if you become pregnant actually, that is also equally important, and you need not to spend penny from your pocket. We have a JSSK, Janni Shishu Suraksha Karyakram, in which during pregnancy, all tests, if you are hospitalized for 3 days in a normal delivery, let it be a food, let it be a transport, let it be a drug, diagnostic, blood bank, all are free. For 7 days, if you happen to be a cesarean section mother, then all those expenditure, they are free. That is a beauty of this JSSK program. Then we have a PMSMA program, Pradhan Mantri Surakshit Matra Abhiyan, where we want that during 9th of every month, there should be antenatal care checkup by a specialist doctor or comprehensive trained doctor or BMOC doctor, so that if you are in high risk pregnancy, even in high risk pregnancy, there are the non-communicable disease are there, like you can be hypertensive, you can be diabetic, you can have obesity, you can so many other problems also. So they as a high risk pregnancy, because pregnancy plus beyond uterus wali problem, they can be taken care of that also. And once you are detecting as a HRP, even if you have delivered actually, those non-communicable diseases, they persist along with your life also, so that they can be, if they are first time they are captured during the pregnancy only, because the mother is not able to take time for herself, but first contact with the healthcare system is during pregnancy only, and she is detected first time as a hypertensive or a diabetic or any other problem. Maybe her breast is palpated first time and she may or have a nodule. So in the future also that follow-up period then can be taken care of during that period also. And in the postnatal period is also equally important, because for the women she is neglected in a postnatal period. Family is overwhelmed by a newborn child, in the grandfather, husband, everybody is overwhelmed with a newborn child. But where is the mother? During 42 days of pregnancy, there are warning signals in spite of pregnancy. Maybe some rupture is there, infection is there, some bleeding is there, and then Government of India have brought another strategy, postnatal optimization, where at least 6 visits by auxiliary nurse or a ASHA worker in the field, if she is delivered in a hospital, to pick up those warning signals. If it is a home delivery, 7 visits by the first link worker, that is ASHA in the field, to capture those warning signals and then attaching to the next higher center. I stop here only. Thank you very much for this important topic actually.
Thank you so much, sir. Thank you for bringing the integration for us on the platform. And I just want to give you another good news. A study done in the previous organization where I used to work showed that if the triple Ds are available closest to women in the field, the out-of-pocket expenditure for various diseases on the drugs and the diagnostic goes by half if the drugs are just prescribed from the EDL that is given to the facility. So that's a wonderful news. The out-of-pocket expenditure analysis shows that it has gone down for NCD drugs for women. So that's a great news. So with that NCD, can I go to Dr. Praveen and request him to come and present his views on what does he faces in his tertiary care center while he's treating women for NCDs and the heart diseases. Over to you, sir.
Thank you very much. And I would like to thank the organizers. When I got an invite for this, I said, initially I was a bit perplexed. But I thought there are not many champions who are going to talk about beyond the uterus. There's a lot of people, there's a lot of good work. The Honorable Minister has already said there's a lot of integrated work going on. But I do see, being in a clinical practice, I do see the reality. Although I must admit, most of my work is in the urban center, so I have little experience of working in the rural center. But this is not going to be, it's going to be a general thing that we're going to see in the coming future, because India is no longer an underdeveloped country. So there's a lot of migration from the rural center to the urban center. The capacity of the buying capacity of the people are going up, which is all a good thing. However, with it comes the challenges of health which women face. So what are the things? We would not be here if there was no problems. That's the reason there is a problem with women's health. I would, rather than calling it maternal health, I would like to call it as women's health, because, as I said, maternal period or the reproductive period is quite short. For example, if a woman lives for 70 years, arbitrarily, that's about 10, 15 years. Nowadays, you don't see a long period of reproduction, in general, at least. Where people used to bear 10, 15 kids is probably think of the past, which probably 30, maybe 50, 60 years back was common. But nowadays you see pregnancy being related to 1 or 2 children. So I think there was some mention of breast cancer, which is quite important. Okay, but if you look at the data, women are twice likely to die from cardiovascular disease compared to breast cancer. So it's the elephant in the room. No one is actually discussing about that. And looking at some of the risk factors, because I think there was also a mention of risk factors. So there are what we call traditional risk factors, like diabetes, hypertension, high cholesterol, obesity, smoking, and sometimes genetic factors. So of all those things, what we do find is, I think there was already brief mention, smoking increases the risk of having your heart disease, or what we call cardiovascular disease in general, is about heart attacks as well as stroke. So it's a combined term. 25% higher risk in compared to men. So if both men and women are smoking, there is a 25% higher risk in women. Even alcohol, yes, it affects much more adversely in women compared to men. That is why if you look at some of the international guidelines, the cutoff for alcohol, there's no safe level of alcohol, however, but the recommended guidelines suggest, for example, in the UK, it was about 21 units for men, it's about 14 units for women. So that also, it just shows that there is a difference. There's a sex difference between the two. Diabetes, 44% more risk. It's much more potent in women compared to men. So for example, if both men and women have diabetes, there's a 44% more risk compared to men. The incidence is much lesser, because 65% of cardiovascular disease happen in men, 35%, although the incidence has been actually going up. So over the last, say, if you look at 20, 30 years, the incidence of the cardiovascular disease is going up. So if you take everything as a whole, cardiovascular disease, hypertension, and diabetes, the risk is much, much higher Only cardiovascular disease is 35%, but if you start adding diabetes, hypertension, the risk goes even higher up. One of these statements which holds true even today is women are underdiagnosed, undertreated, and underrepresented. Why that is the case? It's a complex issue. The data, the research has not been able to come up with concrete answers, but I believe there is some subconscious bias. I'm talking about the clinicians, not necessarily a conscious bias, but subconscious bias. So that leads to underdiagnosis. Even if they come to treatment, you come to the hospital or to a healthcare center, the chance of them being dismissed. For example, women present with less typical symptoms compared to men. For example, they don't have, if they come in with a heart attack, they don't have to complain of a typical chest pain. But it can be an atypical pain. It can go to the jaw, it can go to the back, it could just be a gastric. That's what the most commonly people will dismiss, saying that it's a gastric problem. But data shows that there is at least a 6 percentage point difference between women presenting with atypical symptoms compared to men. So it is much easier. So you cannot blame the clinician. It is much easier if someone comes with the typical symptoms and say, I'm having a heart attack. It becomes difficult for the person who is treating them as well. But these are the challenges that we need to accept. So there is a sex difference among how cardiovascular diseases affect women and men. Some of the other things that we see is what we call syndrome X, or coronary microvascular circulation, which means that when we do an angiogram for a woman who comes with symptoms either typical or atypical, the major coronary arteries are normal. There is no major blockages causing the blood flow. However, the microcirculation inside the muscle is dysfunctional, and there is no way you can actually prove that. I mean, you'll have to do an MRI scan to find out some of those things. But in general, most of us would do an angiogram and say, fine, everything is okay, we're going to dismiss you. These patients can, especially to have effects in women, they keep coming back to us and then they are dismissed, saying that you're mad, go to the psychiatrist. So all these things happen. So this is a clinical problem that we understand. There's another typical example, what we call Takotsubo cardiomyopathy, where it's a broken heart syndrome. That's a colloquial term that we call for it, where due to acute stress, the heart stands still. And then either they can have a heart attack, sometimes they do die with it as well. This is more common in women. And if you do once again do an angiogram, it's completely normal. Unless we look at the myocardium, we look at do an echo or an angiogram of the LV muscle, we may not find that problem. So most of the time, they would just end up with an angiogram and then say everything is fine, go home. But the risk for them, because these are not benign conditions, they tend to have problems. It's recurrent, and then people die as well. So there is a lot of underrepresentation. The next thing, the point I'm going to try would be underrepresentation in clinical trials. I think as many of you have already mentioned that from a cardiovascular perspective, I'm going to say that from all the trials we have, for example, if any of you in this room, God forbid nothing happens to you, but if you have a heart problem and then we give some treatment for that, sorry, am I audible? So if there is a heart problem, the treatment I'm going to give you is what we call GDMT, goal-directed medical therapy. So what treatment I'm going to give you, there's no evidence it's going to work for you guys, because all the evidence comes from the clinical trial. In fact, I should say cardiology is one of the best subjects where there's a lot of clinical trials. So that if you think about other medical problems or anything else, the evidence is even weaker. Even in cardiology, where we got so much of evidence, 70% of in any trial, especially from the Western world, the 70% would be a white male. The rest 30% would include everyone, including women, non-white, everything else. If you dissect the data, it's about 15 to 20% might be women. And if you look further, Asian women is less than 5% or probably none. So absolutely there is no data of how we are treating women. So that is a big problem. And what works for, because as I said, there's definitely a race difference as well. As I told you, diabetes in an Asian woman is much more dangerous compared to a white woman. This data is proven, but we do not know how to treat because absolutely there is no data. So there's a lot of sex differences, but there's less recognition So I think got instructions that I should stop. So, but there is definitely, there is a lot of work that needs to be done. We'll come back to that.
Thank you, Dr. Praveen, for holding your thoughts. And with that, let's move to Blessy, who is synonym to community voices in TB when it comes to it. So Blessy, the question for you is stigma, social challenges faced by female TB patients. Why should I say just patients? By female who are both impacted and affected with TB, because they are not just patients, they are people living with patients. And the lens to understand community access issues, if we can hear it.
Thank you. Thank you so much. And thank you to the organizers for including TB into these discussions. TB actually holds a mirror to the status of women within the society. But just to start off by giving you a little bit of a shock with the numbers we're looking at, want to remind everyone that TB is totally curable. It can be diagnosed, it can be treated. Yet the Global TB report from last year, 3.6 million adult women developed TB, and 423,000 women died from TB. This is global, of course, but still, almost 500,000 women dying of a treatable disease is something that shouldn't be acceptable by anyone. So epidemiologically, if you can look at the numbers, men tend to get more TB than women. But TB really affects women very disproportionately. The TB journey is extremely arduous for a woman. And if I can just divide that into different issues of access, nutrition and norms, and reproductive health, access becomes a big issue. Women are not allowed or hindered from seeking care. And always, like we've heard from my other esteemed panelists, always put themselves behind everyone else in the family. They eat last, they eat unhealthy. Everything is, for the women, is very, very much delayed. And again, leading on to nutrition, look at our rural and some of the urban settings. And look at our own homes, the so-called urban homes as well. Who eats last? Who eats what is left over? Who thinks of nutritious diet for the woman? If as a woman, in any family we say, oh well, I need that vegetable and salad to be kept for me, there will be a stigma with that. Definitely. And I don't think any of us women in this room would have ever said that. And had we said that, we would be immediately seen as a bad woman who doesn't care for the family. And women in some of the rural settings across the globe, and more so in our region, need to be accompanied or given permission to seek healthcare. And healthcare is never a priority for women. So that really becomes a hindrance as well. And when it is a woman who is running the family in terms of doing the chores, looking after the children, taking time off to seek care is actually seen as something negative. Why do you need to care about your health? You have to look after all of this. And there's also a lot of tension within the family when a woman puts her foot down and says, I need to go and seek medical care. And then, of course, TB is all about the uterus when it comes to it. It's all about pregnancy. It's all about, postnatal, perinatal. So just to, give you some of the, not figures, but points from reproductive health and TB. Studies show that early reproductive years, if women have TB, they may have faster progression from TB infection to TB disease and higher mortality rates. Tuberculosis in pregnancy risks poor pregnancy outcomes, while one can take TB medication during pregnancy, there are higher risks of a child being born, stillborn, and after effects of postnatal effects on the women, mortality, kind of not being able to get back to normal health, really, really delays the well-being of the woman. And we also see that there are some studies that show that diagnosis of pulmonary TB happens if it happens in late stage pregnancy, the chances of death is increased by 4-fold. So these are really huge burdens that women actually carry, not just with TB, but with many other diseases. And another form of TB that is coming into light now, it must have already been there, but I guess we've become a little bit bolder to talk about it, is genital TB. And numbers in our part of the region, in our country, it's going up. Women become infertile. Again, an added burden and stigma around that. So I think with TB, early diagnosis, early initiation of treatment, support to complete treatment would be a huge asset for the women to take use of. Now, looking at stigma very quickly, it's like a triple-edged sword, because you already are stigmatized because you're born a woman. We've heard from other panelists as well. You have TB, you get further stigmatized, and because of TB or anything else, you can't produce children. You're not good marriage material. So this all hangs on your head. And how do you, get over this? And, we've talked to women across the globe, and many of them have told us that it isn't TB that kills. It's actually the stigma that kills you first. I have quotes, but in the interest of time, I'm not going to say that. But I want to just take 1 minute to tell you about a young lady, a doctor who came to us for help. She was doing her MD in a central Indian state where she was diagnosed with pre-XDR TB. She was married to a leading specialist from the city. She came back and she explained to her husband what she had been diagnosed with. The next day, the husband took her, a leading specialist in the city, took her back to her parents' house and left her there. She wanted to commit suicide. Somehow she was looking for help and she found us, hours of listening to her, talking to her, and literally forcing her to go, take treatment. She completed 2.5 years of painful injections and treatment with daily counseling. We also got her to go and give her MD exams, and she passed out. She finally decided to step out of that marriage. So the burden is not just the disease, the mental trauma, the lack of support. She lost everything. The marital home abandoned her. Parental home accepted her but lived with the stigma around them as well. So, when we look at women, the burden that women bear, not just with TB, any infectious disease, any NCDs, is huge. And unless we really look at women beyond the uterus, it's not all about marriage, children, and uterus. We are individuals who can contribute valuably to the society as just us. Thank you.
Thank you, Blessy. Thank you. That was a wonderful pitch. And, somebody to be blamed is also our fashion industry, which encourages zero figure. And people think with zero figure, you can't have NCDs. So that's a myth that's coming up. So with that, let's move to Anna. Anna, my question to you is largely about why don't women want to access care? What happens to them in facilities? How, the treatment in the facilities lead them to that not availing services over there? If we can take us through that journey of a woman in a facility.
Okay, thank you so much for this question. I want to answer the question in the field of infectious diseases. That is my deepest experience. But first of all, I want to say good afternoon to all the audience and my colleagues, for sure the organizers. And it's truly an honor for me to be here today. My deepest thanks to KHPT for inviting me to be in this critical conversations and alongside with this kind of prominent panelists. Since the time is short and my English is not my native language, my apologies for that. I've prepared notes that will help me to be clear and concise. I appreciate your understanding. So I want to build my speech in regarding to all the things my colleagues are talking about. Let me highlight three key challenges in addressing women's health in infectious diseases, and for sure it's included the facilities and the journey to take care. So these three challenges are systemic, are interconnected, and ultimately all of them are solvable. Sorry. Okay. So the first one is the silent burden of dual disparities. So as my colleagues say, frequently women face a perfect storm. They are biologically more vulnerable to some infectious diseases like HIV or like UTIs, while simultaneously facing cultural barriers to care, but also stigma and discrimination. Globally, societies, health systems, and health providers still predominantly view women through two reductive lenses. The first are all of them talk about it as reproductive bodies, and the second one is as caregivers, no more. So often denying them, the woman, the agency over their own bodies and over their own health decisions. Let me share with you some information about Latin America. I am from Colombia, South America. In Colombia and in Venezuela, we see adolescents and women from indigenous communities in higher burden of Chagas disease and in a higher rates of fatality of Chagas disease than males. Why? It's not because different infection in Chagas disease is not different between male and females. But when the women are the last line for the treatment when families prioritize male health. So they are going to the facilities late. Even most of the times, they are not going to the facilities because they are the last in the line of the treatment. But I was talking about indigenous women. That is happening not only in vulnerable population, not only in the rural areas. Even in urban areas with better healthcare, women are facing hidden gaps. Take dengue fever in Sao Paulo, Brazil, or in Buenos Aires, Argentina. Working age women with health insurance are more likely to be hospitalized than men with similar cases. Why? For sure, as epidemiologically, point of view, there are a lot of factors, but we need to take into account one factor, that is a possible contributing to that. And it is doctors often dismiss the symptoms of the woman when they have acute fever, in this case, dengue fever, as a stress or a period problems, delaying care of the woman until they need emergency treatment. Because of that, they are going more hospitalized than males. But we don't think that in our minds. We had a tragedy in the recent years with Zika virus infection. The Zika tragedy exposed this systematic failure. While a pregnant woman reported unusual rashes and joint pain for months, their symptoms were dismissed as pregnancy discomfort until microcephaly cases exploded. This tagged us the cause of ignoring women's reports. They are early warning about unusual symptoms were initially discounted and delaying crucial public health responses. The second point, I will rush. The second point is healthcare system that inadvertently perpetuate the harm and the exclusion. Poor facility conditions aren't just about broken equipment. They are about broken trust. When a woman walks hours to a clinic only to find no female providers, or gets scolded for irresponsible behavior when seeking STI care, that facility becomes part of the disease vector. There are experiences that show women in rural areas would rather treat malaria at home than face humiliation at understaffed clinics. So sorry. When I speak about the healthcare system perpetuating inequality and exclusion, I am not just referring to health workers, facilities, or ministers. Economic interest and industry practices equally contribute to this problem. In Colombia, a pack of male condoms costs about $1, while a single female condom is priced at $6, placing prevention literally out of women's reach. In 2021, I led the design of Colombia's national protocol of HIV pre-exposure prophylaxis, PrEP. We did this with collaboration in PAHO and UNAIDS and the Ministry of Health. And during this process, we identified a critical gap. While pharmaceutical companies had made oral PrEP available, also you know that oral PrEP is for male and female, they showed no plans to introduce the vaginal rings for cisgender women, despite their proven efficacy. This neglect has deadly consequences in our context of entrenched gender violence, particularly in rural areas. Countless women in heterosexual relationships where husbands forbid condom use or even hide their multiple partners, the woman cannot protect themselves through oral PrEP or condoms without risking physical abuse. For them, vaginal rings could be a life-saving discreet option. Yet, 4 years before our protocols was approved in Colombia, there is not this option in a country, but also there is not option in Latin America and other regions. So the final, I don't be so good, I don't need to take more time, just to say that the data gap. Dr. Maxine and my colleagues were talking about a lot of that. And if we don't have disaggregated, thank you so much, data from gender, it's impossible to know the reality of the burden of the disease, non-communicable, communicable, and of the disease. So we need to address that also. Thank you so much.
Thank you, Anna. And I think in the interest of time, because 3 o'clock we'll be thrown out of this room, literally, I would request Dr. Anand both to wrap up the session, as well as if he can speak for 1 minute on the very specific point Anna raised, which is systemic, but I think also financial gap, which is not looking at evidence of how to finance health for women. There's no time for questions. We'll have 10 minutes for questions. That's why he's wrapping up. And
yeah, questions and 1 minute, Dr. Will also. So thank you. Very, very, not just powerful, I think emotional. I think 3 points which are jumping out, and then 2 points I want to put as provocations to this group. I think one is data on disaggregation, data on how it affects, South Asian women, data on how symptoms present or don't present. There is a, crying scarcity of data. Without data, this won't work. So clearly that's something coming across strongly. I think intent is there. I mean, even sir, like you spoke about, while your mission is the uterus, I think you are already focusing deeply on what are some of the other things. But here's the challenge. The political will finally is going to be at the center. When we hear Nari Shakti in translated is woman's power. That's one of the biggest themes in India right now. There is a lot of focus on livelihoods. How will women entrepreneurs, get loans? There's a lot of focus on, cooking gas. How will, how can safer fuels be there at home? But can, for example, women's health, Nari, Swasth, be an integral, because if a woman is not healthy, where will there be Shakti? So really, one part maybe is where is the political will? How can that happen? The interesting part is women are now the swing voters in pretty much every election. So maybe it goes back to our women themselves aware that they have the power to drive political will. Now, you said this, right? Like in our own homes, women tend to give away that power. And I'm sure that happens in society. And then the last point I want to, sobering thought. All of this in data, all of the innovations, all of the new treatment protocols will need money. Globally, focus on gender, capital which is coming through there is actually coming down. There is a sobering effect and a long winter. Now the question is, can India, can this country actually buck the trend? Because if money is not there behind any of this, none of this will really happen. As the audience, it'll be great to hear a little bit about where will the money come from. The good news is India is already bucking the trend. In some ways, Nari Shakti as a theme, there's a huge momentum around women nano entrepreneurs, many of them. But can Nari Swasthya, women's health, be an integral foundational layer to Nari Shakti? Because there are also people in the senior, bureaucrats, politicians, etc. in this audience. So with that, of course, there are Q&A, which I think Anuradha ma'am will, moderate. I know Praveen had 1 minute interjection before we pass it on to you.
Thank you very much for that. I'll be very brief because I think the pitch I want to make is slightly different. I know we are all focused on reproductive health and everything else, but 10 years from now, we'll be talking really different. Okay, so that is where I am pitching myself. So that is the reason I came to this conference when I was invited, because the global, it's an epidemic. What we're seeing, non-communicable diseases, diabetes, hypertension, obesity, smoking, everything is going up in women, unfortunately. India is a diabetic capital, India is a hypertensive capital. We are going to be the #1 capital for cardiovascular disease as well, which is very, very sad. every day I see in practice young men and women coming in their 30s. My youngest patient is 22. Okay, so a lot of people in their very young age, reproductive ages, as well as prime ages, having their heart attacks and then having their life turned upside down. So what is the solution for all this? Obviously, there are a lot of solutions. One simple solution is screening. The Honorable Minister is here. That's the reason I wanted this pitch of 1 minute. What we can do is definitely everyone can have a screen above the age of 40. I don't want to go beyond less than 40, but definitely age of 40 plus, which can be done on the community level. 5 basic tests, which I'm going to ask for, and then ECG and echo. That can probably pick up about 70% of all the problems. A CBC, like white blood count, complete blood count, kidney function test, thyroid, HbA1c, which will tell us the sugar and the cholesterol levels, along with the ECG and echo. So that can definitely pick up, and it can be done anywhere. Most places are able to do this, and that can change a lifetime. Otherwise, we're going to see a lot of people, especially in their kind of 40s and 50s, where they'll be, they may not necessarily die, but their productive life, their quality of life will definitely be different to what we're seeing today. So that's something we should all wake up to and then work towards it. Thank you.
Thank you, Dr. Praveen. So, Honorable Chair, with your permission, I wanted to put Dr. Pawan on spot by asking Nari Shakti to Nari Swast. Can you help us?
Really, this discussion was very useful and fruitful, and brainstorming which has happened. So many pointers I will be taking with me, and many of things they are already in place, starting from Ayushman Arogya Mandir, basically preventive, promotive, curative, rehabilitative, basically. Once we talk about the non-communicable disease, we start from the prevention itself. Screening comes second step, then is a cure. Once we talk about the prevention, basically that starts with the lifestyle disease, change in lifestyle. Teach and preach. Teaching is very easy, preaching is very easy, but practicing is a difficulty. So once women, I will not call as a maternal health, but once a woman visits nearest Ayushman Mandir or sub-center, basically, talk about the lifestyle that should be inculcated into healthcare system. Let it be a diabetes, let it be obesity, let it be a nutrition, because what we have heard and we practically know, women neglects herself in all aspects. Let it be a nutrition, let it be a diet, let it be a physical walk. Once we talk to the women, I do lot of household work. My exercise is completely within the kitchen itself. No, that is not like that. She has to move out of the kitchen, have to have a round within the society, outside the society, near the park actually. Then second part is the nutrition. Why she is taking the left out food? I think she should also have proper portion of food with all nutrition within his or her, within her diet only. That is an important thing. Third is basically a basket of choice, as my colleague from another country was telling. In India, we have a basket of choice, and all is free of cost for contraceptives, starting from condom, OCPs, copper T, till a subdermal implant, which protects the mother for 3 years for the pregnancy. That is also women empowerment. You empower women to control her fertility. It's not controlled by the husband or a mother-in-law, because by giving a contraceptive within time when she needs them, and that is free of cost, which is accessible near to her vicinity only, which is affordable, where she need not to pay any price, and you are empowering women to control her fertility. Once she controls that, that also empower women for a better health in the future also. And then during that small phase of pregnancy of 9 months, if you have 2 kids, 1 kid, whatever is there, that is a kind of a screening for her. In a routine time, she never being subjective for the screening, or let it be a ECG, or let it be a hemoglobin, anything else. I think that is a first window. Sometimes she visits to the health clinic during ANC, and once she is captured, I think that life course can be taken care of. I stop here only. Last bullet on fiscal, basically about the pricing, actually the out-of-pocket expenditure. As far as the healthcare seeking behavior is concerned, about the 12 packages which I have narrated, starting from from NCD to communicable disease to the life course of a disease, IENT, geriatrics, screening all, that is all free of cost. Basic tests, they are all free of cost. Basic drugs which are required as per the essential drug list, they are free of cost at the primary level, secondary level, tertiary level. I think that majority part of the out-of-pocket expenditure is also taken care of. I stop here, Ronnie. Thank you very much for giving us the opportunity again.
Thank you so much, sir. We'll open the floor for questions, but before, yes, we'll take 5 questions quickly because we have 5 minutes extra and it will be for the panelists. But we have already achieved one outcome. KHPT should be happy, and that outcome is, sir, started with pregnant women and ended with the women. Floor is open for questions. 1, 2, that hand went first. Yes, please. Third, yes.
Okay, hi everyone. My name is Ahana. I'm been part of the startup and the innovation ecosystem, and I work in design, which quite literally puts the user in the center, right? So I do have one question, but I have maybe a few points that I did want to highlight maybe over the next minute, right? So an esteemed panel member, to start off with, mentioned that women kind of give away their power at homes, and I would just like to gently call out that, women don't really give away power, right? So it's systemic oppression. Over decades, we have been fighting modern liberation movements, have been happening for over a century now, right? So it's a systemic process of oppression and misogyny that directly impacts the quality of women and everyday lives. Right? So honestly, if you see even legally, things like battered women syndrome or learned helplessness has been medically proven, and now that has been put into policy and law. So I do think that maybe blanket statements like that do not, I think we need to be better informed. That is one, right? Now, second, I think it's also important about inclusion, and not just women, but also trans women, right? Going back to the clinical trials, lack of evidential data, I think that's a really concerning point, right? Why we do have clinical trial design, regulations and rules and guidelines and best practices. Why don't we actually include a representation in the study, right? If a disease or any affliction affects across genders, those genders must be appropriately represented in your clinical group, right? The participant group. And I don't know why this has not been made into a policy yet when we can actually do it. We have control over it, and it's the 21st century, and we are worried about climate change and the collapse of the planet. Maybe this could be the point in time where we finally start including intersections, before we decide to impact thousands of lives out there, right?
Arvind,
okay.
Can I just, sorry to cut you short, sorry
Please.
for being the villain.
Not worry. I'm going to move on. I just want to...
Just 1 minute.
Yeah.
We wanted to give a mementos to the panelists, and we have actually invited one of our trustees to do that. Maybe we could just finish it because
Yeah,
has
as
another
he walks,
meeting.
I'm going to finish one more point, right? I'm going to take this second out there. Okay.
This is sorry. No, I'm still in the discussion. Sorry. Yeah, to Dr. Anuradha. Also, this is a book called The Invisible Women. I think we got a lot of our learnings from that. I think I would recommend it for anybody who is interested. To Dr. Pawan. Dr. Shivagami. Anant, please. Thank you, Arvind. Thank you. And also, sorry.
No worries. As a woman, we are used to being interrupted. No, it's not about you. panelists.
That
no
was
worries.
a good one. Continue, please.
No offense, just taking that moment, right? Okay, so I think what is concerning for me, as someone who's starting at the peak of their career, right? We've got another 30 years, maybe I'm 30, before we retire, right? Hopefully. So one more thing which is actually concerning is there is a growing interest in women's health. And this is also, represented in the startup ecosystem where there's a lot of femtech movement that focuses on feminine health, right, across fertility, reproductive systems, and etc. That affects women's health. Now, what is actually concerning is that when we actually looked at the funding data of these startups, especially in the VC ecosystem, right, I'm going to read out some stats to you, and this is from the latest 2024 report. Right now, all female founding teams working on femtech secured approximately 0.7% of the total startup funding in India. Now, founding teams that were mixed gender, had both men and women, accounted for about 8.1% of the total funding. And all male founding teams innovating in women's health secured 91.2% of the total funding share. Now, if this is not concerning, right, and if the startup ecosystem that is being promoted by the government, and I promise I'm really done,
No, but
right?
the question, we
The
agree.
question is actually the clinical trial, like why is it actually not possible? Because we have panelists, we have processes, this has been going on for a very long time. So why are we, I'm sure regulations are revised. So what is stopping us from moving there, right? Because medicines are in and out, right? That's a big problem. That is the actual question. That's the highlight. I'm done now.
So no worries. That was a wonderful commentary, and we really respect your point of view. We can request you that panelists would be out for tea after this. You can actually get together and they can respond, because there are multiple responses to this question as far as I understand. So can we go to the next question very quickly, and third, and then we'll wind up. Thank you. And only question, please.
Yeah, this is a one question, but it's kind of building up from what Ahana said. It's a different point, not about men getting funding for women's health, but I wanted to understand, why do we not include men in taking care of women? Women are men's caregivers. Women take care of everybody. But somehow I feel like whatever policies or discussions we have, the onus remains on women to do something. And so I want to understand, how can we think about involving men? An example I think of is family planning, where it was so directed towards women. We have so many products for women to not have kids, or control, or have control over their fertility to some extent. But for a lot of men, there is just there's just a condom. So I worry that if we just keep it about women in health, we forget involving men and men's responsibility towards the women in their lives. So any thoughts on how we can engage more men?
Lovely. We'll come to that question. Yeah, you raised your hand, right?
It's a wonderful panel and wonderful presentations. I think all of you presented, so I agree with all of your points. The point I want to say that since we are talking about women's health, it's good looking at women beyond uterus. Yes, women are much more than uterus. So the point I want to make it that when we talk about the women's health and all that, it's totally become very biomedical, clinical, still talking about presentation of the symptoms, how it could be cured, but we completely ignore the social and the gender aspects of it and what it actually affects women's access to health. And I'll give one example which, sir, you would agree, because you talked about maternal mortality, how it has been brought down. So what has been the game changer? The game changer was the transport. When you provided 102 services, when you were able to bring women to the facilities, it brought down the maternal mortality, like one of the major contributor to it. And another example I would talk about it, like in health, we do not even talk about having the construction of toilets, how important it is. I'll talk about one sector.
Sorry,
domestic
can we
health.
request you for the question, because
I'm
we'll be
just
thrown out
saying-
of this room very soon.
So I'm sorry, I'm just saying that in the women's health, my question is that it should not be included only to the biomedical and the clinical aspects of it, because women health go much more beyond that. And whenever we should have a reflection on it.
Thank you. So can we, sorry, we are running out of time. You can get together with the panelists outside, and can some of the panelists, one or two, respond to the family planning question that was asked?
I'm the right person to respond on that, actually. Thank you you very much for those questions which you have raised and she has raised. Pertinent questions. Why burden of controlling fertility lies with the female only? Why not the male engagement is there? I think the program is there regarding the tubectomies and vasectomies, male and female both. I think that engagement, but burden lies again with the female only. So it's a more of a gender bias, basically, you can call, and there are programs, and we encourage male participants also to come forward. Not only for this, for doing immunization sessions also. Always child is in other lap of a mother only. Why father is not coming for the immunization? So I'm looking after the immunizations also for the country. I talk about in IEC posters, please bring family in the poster for communication, IEC, not female. With lap of child, mother, child in her lap only. Father and mother both should be there. And she talked about the women health, it's a beyond women actually. Women health is beyond women. Other people, other parameters, other social determinants, they are equally important. You talked about there's a transport, I will say health seeking behavior within the family itself. Why mother is or female is neglected actually. Some of those mother, they don't come for the institutional deliveries also. They suffer those morbidity at the home itself. I'm talking about a maternity period. It is same with the non-maternity period also. They are the last one to seek health services nearest to their health facility. So accessibility is the important part. Second, the transport reaching, and then once she has reached there, take care of those mothers during that period, not in maternity, beyond maternity period also, let it be a primary health care system or secondary. And if they have visited, she should not be able to spend a single penny from her pocket actually. All test, investigation, whatever is required. And somebody was talking about the data analytics, I think is a study design bias. Why females were not kept into equally into that study design. Why those study design were male dominated. I think it's a high time that our study design, the sampling framework should be such that such data is being generated for future. I stop here. Thank you.
Yeah, very quickly, I want to make literally two lines. Yes, we must include men into the umbrella in taking care of women's health. But I want to conclude by saying that I want men to take care of their own health. If they don't take care, the burden is on women. And it is, in fact, it is affecting women's without even we can imagine, okay? You don't take care of women's health, but please take care of your own health. Also take care of their illness, their care responsibility. For that sake, please take care of it. That's all I want to put on.
Thank you very much.
Just thank you. Thank you very much. I think it was a very nice session. And before we forget, I also want to thank the organizers for the session and WiproCares for actually doing this.
Yeah. I know I'm snatching the mic from you, but Dr. Pratana, the KHPT and you, the amount of time you spent in putting together this panel, and I want to thank with a big clap and big applause. And it's really, and you know what, I don't like to go out on Saturday, Sunday because I want to be with my daughter. But the topic that you came up with, I couldn't morally say no. Okay, thank you so much. There's so many cameras now. Thank you. Thank you. Thank you.
session. Pleasure to be here discussing other things.
Thank you. Although I'm actually qualitative, but that was assistance.
Yes, yes, thank you very much. Thank you very much.
Pose. Listen, enthusiasm is what matters in palms.
Municipal Commissioner in the Mumbai Municipal Corporation, he spearheaded the HPT Apna Davakana project. HPT Apna Davakana project is the state of Maharashtra's flagship primary healthcare scheme, and that created elastic impact within the communities that he served. Thank you, sir, for coming to our session. Project director has assistance with data tasks, mechanical engineer with MBA in systems, HR and expansion mass, went on to study. Okay. Don't worry about if it happens, it happens. If it doesn't, leave it empty. I want to after that. Alright, then don't take too much stress. I'm just trying. Okay. Alright. That is cool. Okay. Mechanical engineer. Sunita said this has to be like this. I was telling her that I want like a big one so everything is covered up. She said no. Yeah, I actually quite like it. Nice. Okay. If you're practicing on your own, hey, questions, Hindi questions. Team kaati hai roz? If anyone wants, they can come and take it. हम बोल सकते हैं हाँ, and maybe have more copies and all. हाँ जी. हाँ हाँ. I will distribute it towards the end. हाँ. Questions, the Hindi question translation.
लिहून घेताय का?
हो.
पहले से स्टार्ट करोगे ना?
कविता जी, हे हिंदीतच आहे. उनको पूछती हैं क्या लगता है अभी वगैरह. दूसरा आहे ते जो where is the button?
हमारे, लेकिन देखो चेहरे अनजाने अपने। अधिकारों के लिए दौड़ते, दिन डूबे लगते थकने। नहीं ठिकाना इसी शहर में, दर दर भटक रहे सपने। बंद रहे मौकों वाले खिड़की दरवाजे सुबह के, काम काज से वापस लौटे खाली हाथ रहे अपने। संविधान ने दिया सभी को दर्जा बराबर का, फिर भी ना अधिकार मिला है सबको एक बराबर का। बिजली, पानी, सफाई, सेहत के खातिर बस दौड़ रहे हैं।
everybody. Good evening. Thank you for turning up at a 5 o'clock session. It's a difficult thing to be up and about at this time after a full day's work, but thank you so much for joining us today. Welcome to this conversation on last mile connectivity, hurdles in urban healthcare. My name is Shachi. I am the replacement moderator today. So last minute adjustments, please be nice. I am the director for monitoring, evaluation and learning with Apnalay. Apnalay is the host organization for this panel discussion. Apnalay has been working in Mumbai since 1973 in the space of health, education and livelihoods. Although health is our oldest and longest serving intervention. It started with servicing the community with the felt need. We started with service delivery, as most of us do. However, now, after over 50 years of engagement with different urban poor communities, we focus on building community collectives. We focus on increasing footfall with government services that are created for urban poor communities. And we also engage in connecting the urban poor communities with the government systems that are serving them. So, before we start, I'd love to set a little bit of a context. We have a video here that gives you a little bit of an understanding of the community that Apnalay and other organizations that work in urban spaces like us serve.
उम्मीदों का शहर, शहर की आंखों में सपने, है विकास के चांद सितारे, इसके हैं सूरज अपने। शहर हमारा, लेकिन है हम ही गिनती से बाहर। हाथ हमारे लेकिन देखो चेहरे अनजाने अपने। अधिकारों के लिए दौड़ते, दिन डूबे लगते थकने। नहीं ठिकाना इसी शहर में, दर दर भटक रहे सपने। बंद रहे मौकों वाले।
Thank you. I'm sorry about that technical glitch. Let me set the context. I hope some images were attractive to you, and I hope some of the wording still caught on despite everything. Let me just set the context. Last-mile connectivity, the issue that we are talking about today, isn't just reaching physical distances, specifically in an urban setting. It's about reaching invisible households, informal workers, unregistered migrants, communities that the system still doesn't fully see or serve. So these gaps are most acutely felt in, say, slums and resettlement communities, urban homeless population, or those people who are without, say, ID proof, ration card, or any kind of official documentation. So today we ask, how can the systems be redesigned to meet people where they are? What roles can governance, civil society, and community participation play in bridging this gap? And to answer these questions, we have some very, I beg your pardon, we have some very hallowed members at our panel today. Let me just introduce them to you. We are very happy to welcome Dr. Sanjeev Kumar. He is currently posted as Chairman and Managing Director of Maharashtra State Electricity Transmission Corporation. However, he started his career as Assistant Commissioner in Aurangabad, Maharashtra. He donned various hats like Collector Ahmednagar from 2011 to 2014, Commissioner, Tribal Secretary with the Railway Department with the Government of India, Commissioner Health, and Mission Director for the NHM. He was also Divisional Commissioner with Nagpur. In his role as Additional Municipal Commissioner in the Brihan Mumbai Municipal Corporation, he spearheaded the HBT Apla Davakhana project. Now, the HBT Apla Davakhana project is State of Maharashtra's flagship primary health care scheme. We good? Are we good? All right. All right, so HBT Apla Davakhana was one of the flagship government schemes for the state of Maharashtra, and that sort of engaged a large community of urban poor space. So we are very happy to have you here, sir. Thank you for joining us today. The next person on our list today is Dr. Rajesh Khanna. He is working currently as medical officer with the WHO Southeast Asia Regional Office. However, he is trained in pediatrics and public health with 24 years of experience as a leader, researcher, expert, and policymaker. He has also been advocate for healthcare solutions in the field of maternal newborn child health as well as nutrition. When he led the Health and Nutrition Department at Save the Children, his projects covered maternal and child health, nutrition, adolescent health, WASH, and health and nutrition for children affected by emergencies. So he has a solid experience to talk about urban poor communities around here. In his current role as the medical officer for newborn child and adolescent health in WHO, his role spans policy development, implementation with member states. He also assesses training needs, builds capacities to strengthen regional and national programs focused on child health, development, research, and evaluation. Thank you so much for joining us today, sir. Our next panel member is Mr. Srinivas Hundi. Mr. Srinivas is currently working as project director for health systems with Tata Trust. However, he started his career as a mechanical engineer with the MBA in Systems HR and Marketing. Mr. Srinivas went to study international business at IIMC and healthcare delivery and healthcare strategy at Harvard Business School. So he came a roundabout way to urban healthcare, but we are very happy to have you here, sir. With over 28 years of experience in healthcare operations, people development, and stakeholder management, he has leadership experience in hospital and pre-hospital setups, such as startup, ramp-up, and process stabilization for care delivery. In his role as healthcare lead with the Reliance Foundation, Mr. Srinivas led and managed Reliance Foundation's community health initiative centered mainly around Mumbai. His current role as head of health in Tata Trust, he helps develop process innovations and develop proof of concept models that can overcome supply side constraints in primary healthcare in India. Thank you so much for joining us today, sir. Our next member is Mr. Shalin Mitra. He is currently working as state manager with Ayushman Bharat Digital Mission with the government of Punjab. Previously, as a secretary to Minister Health and Urban Development, Mr. Mitra played an instrumental role in formulating and implementing key healthcare initiatives, notably the establishment of Mohalla clinics, community health centers aimed at providing accessible primary healthcare in for Delhi's residents. As state manager for Ayushman Bharat Digital Mission in the state of Punjab, he oversees the implementation for strategies for effective implementation of the ABDM initiatives within the state. He's also currently pursuing his PhD, and Mr. Mitra continues to integrate academic research with practical policy making, emphasizing the importance of mental health in public health frameworks. Thank you so much, sir, for joining us today. Our next panel member is Dr. Mangala Gumare. Dr. Gumare is a retired executive health officer with the Brihan-Mumbai Municipal Corporation. Dr. Gumare is a distinguished public health leader with over 30 years of experience in the healthcare sector. She retired as the executive health officer of the Public Health Department, where she played a pivotal role in shaping Mumbai's health policy initiatives. Throughout her career, Dr. Gumare has been instrumental in launching and overseeing various public health programs aimed at improving community well-being. One of her notable contributions including advocating for the establishment of Hindu Hridaya Samrat Balasaheb Thackeray or HBT Davakhanas, which provide accessible healthcare services to underserved population in Mumbai's slums. Dr. Gumare also led efforts to combat tuberculosis in Mumbai, aligning with the city's goal to become TB-free by 2025. Her leadership in organizing vaccination drives to combat TB and public health campaigns has been crucial in addressing communicable diseases within the community. So thank you very much, ma'am, for joining us today and bringing your wealth of experience to this discussion. The next panel member, who is very, very important to organizations like Apna who work at field level, at the community level. Kavita ji is an ASHA worker who has been a pillar of strength and service in the M East ward, one of the most densely populated and vulnerable wards in Mumbai. She has played a crucial role in connecting communities to essential healthcare services. She has been working as ASHA since 2020. At the height of COVID pandemic, when fear and uncertainty gripped the city, she stood at the front lines. She worked on conducting door-to-door screenings. She created awareness, facilitated testing and vaccination drives, and also ensured that pregnant women, children, and elderly continued to receive care. Her work also strengthened trust between the health system and the people that it serves. Thank you, Kavita ji, for coming to us today and sharing your valuable experiences. All right, thank you very much for our panel. So we can start a little bit of the conversation about working and sort of ensuring last mile connectivity. So why don't I sit down? Hello? Yes? All right. Let me start with Dr. Sanjeev Kumar. Sir, with your experience in public health governance at the city level, how do you see the structural barriers that limit last mile service delivery? Recently, many states have sort of implemented affordable and accessible primary healthcare schemes, and one such scheme being Apla Davakhana, whose implementation you led during your time with the BMC. How was the experience of planning and implementing this scheme? What were your learnings from it?
So thank you so much for invitation and opportunity to interact with you. Let us first understand that urban health is a neglected issue historically in the country. Right from the Board committee, we had the structure at the village levels, the sub-centers, the primary health center, the community health centers. There was nothing such created, thought of in the urban areas. So that was the one. Second, for thousands of years, we have been living in villages and we know what village is, what are its requirements, that we need to intervene for people in villages. That is something which is very natural in our psyche. But cities and urban areas have come up in the last few decades only. And psychologically, mentally, we have not been able to keep the pace. Another problem is that development is not like the villages are uniform. Every district, every block, every state would have the villages. But that is not the case when it comes to urbanization. It is not uniform throughout the country. The states like Maharashtra, Gujarat, Tamil Nadu, you will have huge urbanization. Some of the states like Himalayan states or northeastern states may not have that much. So at the policy making level, at the highest level, that shift which we have to make from rural to urban, that is slightly difficult to make. Just as the shift we have to make from the communicable diseases to the non-communicable disease. By and large, we are still stuck in the communicable diseases. When we know that 18 to 69 years age group, about more than 60% of the people die because of the non-communicable diseases now. So these are the challenges we have historically, and over the decades, mentally, when it comes to the problems of the urban health. We know there are large number of issues like huge densities. We know, I think far more important issue in urban area compared to rural areas is that even if you are a big landlord, you are rich, you avail the same health facilities, same health and wellness centers, same PSCs, same community health centers. Rich, poor, upper caste, lower caste, everybody goes to the almost same health facilities. That is not the case when it comes to urban areas. There is a clear-cut division that middle class, rich are able to for them there is a private sector available. So they are taken care of by the private sector, though at a high cost. And the poor, the marginalized are not. They don't have the cost. There is a geographical isolation as well. So in a village, you would have the rich and the poor mixed by and large at the village level. That is not the case when it comes to the cities. That's in some corner somewhere you have the geographical isolation of the people who are very poor. To that extent, if you see the media coverage, the setting of the narrative at the city level, the elected representatives, and so many the institutional arrangement we have at the village level, the marginalized poor by and large are neglected, ignored. Does that mean that when it comes to cities, we only have the weaknesses and no strength? When I say that cities are densely populated, it essentially means that geographical distance is not the barrier. For a healthcare worker to reach to large number of people in a small distance, to some extent it becomes easier compared to, let's say, in a tribal area, in a hilly area, in a village, where the distance itself is a barrier. We floated advertisement for recruiting doctors for our Apla Dawakhana. I think we needed somewhere around 400 or 500, and about 1,000, 1,500, 2,000 people applied. Will that happen in some tribal area, remote area, that you are advertising for recruiting doctors with a salary of 1 lakh rupees, which if I remember correctly, base salary plus the incentive somewhere on 20,000, 30,000 rupees. So 1,30,000 and with that much salary. So will you get the doctors availability somewhere in Gadchiroli, somewhere in tribal areas, hilly areas and rural areas? May not be. Nursing staff not available. But at least in the big cities, metropolis, Mumbai, Pune, Delhi, Bangalore, Chennai, you may not have problem when it comes to the availability of doctors, nurses. Then the distance in small geographical area, you have the people. And if not the municipal councils or small towns, at least cities like Delhi, Pune, Mumbai, Chennai, they I'm sure are not short of funds. They have the resources also. I think Mumbai has somewhere around 70,000, 80,000 crores of annual budget. And when I was there, we had about 8,000 crores health budget. So there is no shortage of funds when it comes to at least Pune, Mumbai and Chennai. I'm not talking about the big hospitals, the complex surgeries, but I am definitely talking about the primary health care when it comes, or the basic care. There I don't think, at least in big cities, you have the shortage of funds. So no shortage of funds. Availability of manpower is there. Geographical distance is not a problem. And when it comes to cities, these big cities, you definitely have the medical colleges, the government hospitals. So if you screen people, if you refer people, so there are medical colleges to take care of the further treatment and complex surgeries, which is definitely not the case when it comes to rural areas. You will have to hire a vehicle, go 100 kilometers away, spend your whole day, and even then you may not be sure about the kind of treatment or the quality of treatment you are going to get. So you have certain strengths when it comes to the big cities. The issue is, where are the problems? Then the issue is the vision, the leadership, and putting in place the right kind of systems. So what to do, for example, and what we did is that you put in place the human resource at the community level. And by the way, healthcare is a one sector where you end up providing the services, but at the same time achieve another objective of creating large number of jobs. The general narrative, if you see in the society now, the lack of jobs. But healthcare sector is one sector where you can provide services, at the same time create large jobs for many people. So what can be done? So recruit the manpower at the community level, the nursing, the doctors. Doctors are not that much required. I think we tend to somehow think healthcare is equal to doctors. That is definitely not the case. Healthcare is not definitely equal to doctors, because we need lot of nursing manpower, lot of paramedical staff at the community level. The availability of medicines, for example, so at the community level. So, and then the physical infrastructure. So when it comes to, for example, the physical infrastructure in a city like Mumbai, where space is a huge constraint. So we decided not to go for the concrete structures, because once you put in place a concrete structure, then lot of permissions you get from corporation, then this limitation, that limitation. So we thought of going for what we call the POTA cabins. Of course, beautiful POTA cabins with ACs inside. They are also sufficient. I think the life would be not less than 10, 15 years, 20 years. And then of course, after that, you can replace them again. And not very costly, within a few months, or you can do them. So that is one. More important is the manpower, the medicines availability. For example, one is the health department procuring medicine, but we have the authority and power to make purchases with the ward officers as well. So we said that whenever there is a shortage of medicines, you don't wait. The ward officer can also procure. So health department will procure, but in case there is a shortage, the ward officer must also procure. The another problem, so this is how, and then our experience is that once you put in place 1, 2, 3, 4, 5 these community health centers, or what you can call the Apla Dawakhana, our experience is that people come forward and they ask you establish in our community as well. So so I don't think the space becomes limitation. By the way, when we started these Apla Dawakhana, there was no elected body, and even now there is not an elected body. The point I am trying to make that once you have the elected body, the elected representatives will themselves become proactive in providing you space in their communities and having these Apla Dawakhana or community health centers. Then we said, what should be the timing? The routine timing for us is 10 o'clock and then 4 o'clock. We said, no, we will not have, because space is a limitation. We will have start with in the morning or in the afternoon, but once we come to the conclusion that large number of people are coming, we will increase the timing. So in those cases, in many cases, we increase the timing from 8 o'clock in the morning to 10 o'clock in the night with 2 shifts, doctors and 2 set of people. But then I think the challenge is slightly more. Once you put in these Apla Dawakhana or Mohalla clinic, I don't know, but I have a feeling that it is a kind of a taking care of psychological satisfaction of people. For example, if I go to a doctor in UK or somewhere and I say I have sore throat, so what will be the question? Or if I go in India, so what will be the response? Immediately paracetamol and amoxicillin and antibiotic. But if I go to in UK somewhere, they would say, what is happening to your sore throat? Is it increasing or decreasing? And he said, no, it's coming down now for the last 2 days. Then he would say, just wait. You don't need to have any medicine. Point is that we overprescribe, overuse of medicine, but at the community level for the people. I'm not saying that is not, the curative part is not important. It is also very important, but at the same time, we must agree that that is just small part of the whole primary healthcare or the preventive healthcare. The bigger part of the healthcare is screening people for hypertension, screening people for diabetes, screening people for example, there are 32 crore people in India who are having hypertension. 25 to 30%, more than 20% incidence at the community level. By that, let's say Mumbai is 1% of the whole country in terms of population. So there will be somewhere around 30 lakh, 40 lakh people with the hypertension in Mumbai. There are roughly around 3-4 lakh people who are in the net and medicine is being given. At the national level also, our community control rate when it comes to hypertension is not more than 10%, roughly around 10%. Similarly, diabetes, similarly, how many of us who are sitting here are wearing specs? I think at least 50%. Same would be the case at the community level. But how many of them have the specs? Yeah. Because there's no testing and it doesn't cost much. I think those are things, so maybe 300-400 rupees low cost specs you can provide, but there is hardly any testing, hardly any screening of the people. So so I was aware about that. So I then that decision was taken that not only the Apla Dawakhana will have an MBBS doctor plus the nurses, we will also have a BMS doctor for the preventive services. So we recruited them as well. Then I said, who will do the preventive services? Because the whole training, I'm a doctor and I know the medical colleges, the whole training is very reactive. That as a doctor, I sit in my chamber and I wait for the patient comes, I prescribe something. After that, whether he buys medicine or doesn't, or whether he takes medicine or doesn't, the responsibility lies with the patient. The whole system is slightly reactive. I said, when it comes to the non-communicable diseases where there is no pain, no fever, and most of us even don't know, that approach cannot work. So we have to, on our own, screen people, move from house to house and screen people for hypertension, diabetes. I think we recruited, took the decision to recruit about 7,000 ASHA workers. Roughly, later on I was told roughly around 5,000 were recruited. We, at that time, about 3 years back, took the decision that the incentive for ASHA worker would be double than the national incentive, which we have. Later on, I realized that probably we committed a mistake. I should have done 3 times in city like Mumbai. But even then, double the incentive. And we gave them target to begin with for hypertension, then we'll go for diabetes, then the other diseases, and the BAMS doctor. So I think that when it comes to the primary health care, it is not the availability of just the health and wellness centers or the primary health care or community health care, the availability of manpower and the orientation to be in proactive mode instead of being just in reactive mode. For example, to find out people with hypertension, you will have to screen people who are 30 plus, 40 plus, which is 50% of the population. So in Mumbai, you'll have to screen somewhere around 70 lakh people, 80 lakh people. This is a huge task. I think he's here. In Jammu and Kashmir, where I am from, so we gave BP apparatus to ASHA workers in 2 districts, Kathua and Kishtwar. Now, he has told me that response is good, or they are doing, screening is going on. I don't know whether that is correct or incorrect. But anyway, so I mean, point is that you have to be proactive. You will have the manpower. Then when we are dealing with the human beings, I was listening. I have time, no? 1 or 2 minutes. Just 1 minute, huh? Just so when there is one resolve to save life, Dr. Tom Frieden. His father, I think, he was just wrote that he said, I like politics and I like health. And then he said the primary health care combines both. It is health plus politics as well. Politics is not in the negative sense. Politics in the sense it is dealing with the people. It is mobilizing people. So the point is that it is not a pure health. It is much beyond the health intervention, where you need to have people who have the capacity to mobilize people, sit with them, motivate them for participating in these challenges. I think then we of course need a kind of the leadership in the cities. At least in Mumbai, for example, the health department has no relationship with the state health department. They are not transferred to other municipal corporations, or they are not transferred to state health department. So what is happening at the national level, or what are the national priorities, what is happening in NCDs and other things, doesn't get translated automatically to the people in cities particularly, because they're more closed, isolated. That also we need to correct. The leadership challenges we need to reform, we need to modify. And when we are dealing with the lakhs of people, then the only way to control, to monitor, is using the IT systems. We cannot do it manually. So, of course, these days you have at least the Aadhaar and other enrollment is not very difficult. If we put in place the good IT-based systems, then it will help us in monitoring. The periodic research and monitoring, regular monitoring, that to what extent we have been able to make the difference. If my strategy has not been able to provide or contribute, let me change the strategy. What has worked, what has not worked. I think that is a constant dynamic interaction between the people who are providing the health services, between the administration in the city level and the people at the community level. I think a lot can be done. I don't think it is that difficult really, but if we make that, if we start, and if we decide, we can make difference. Thank you.
Thank you, sir. Thank you for the comprehensive explanation. All right. So if I go forward to Dr. Khanna, with your sort of experience, and what are some with WHO growing in focus on maternal, child, and adolescent health in urban context, what are some key factors that ensure quality, equity, and inclusion in health services as per your point of view? What are any global examples, any successful models that you might want to share with us that broadens our horizon a little in urban context? And sir, 5 minutes, please.
Okay. Thank you, Shachi. And, glad that actually, do you want me to speak after Dr. Sanjeev has given such an excellent background? Thank you, sir. I think it's good that I'm coming after him because he's already cleared a lot of things about what are the challenges, what do you see. One important thing that, of course, this shift from rural to urban is a huge challenge and it's in the mindset. But also we have to understand one process that urbanization is happening. Okay. And it's not merely a demographic shift. It's not only just populations moving. There's a huge change in terms of economic growth. Of course, it's contributing to the economic. And it's usually ill-planned and ill-prepared. You don't prepare for it, how things move. And especially when we are looking into the equity purposes. I will speak from India's perspective. You will see, I'm at the regional office, but, I grew learning in India. I'm a pediatrician, but what I'm doing here is I decided to shift to public health after working in an urban slum. Okay, and a lot of my work, I've been in WHO for past 2.5 years, but all my friends, I've been working with them on health systems, urban health systems so I will give you perspective from urban health systems in India. Now, India has made huge progress. You had NUHM 2013, and now you have the revised NUHM framework coming. National health policy focusing on preventive, shifting from curative to preventive promotive care. You had urban PHCs, community engagements, all sort of things have happened. But still, when we see into the data, urban poor, the lowest 20% quintile, when you compared it to the wealthiest quintile, huge discrepancies. Coverage of interventions, immunization, stunting, wasting, 2 to 3 times higher in urban poor population. Challenges, Dr. Sanjeev has already shared. He shared about infra, HR, medicines, all the system blocks, health system blocks that we are in. I will go into the processes, and this is coming from the experience that I have gained. Now, in 2016, when I was with Save the Children, so 2014, 15, 16, we had a chance to work on urban because NUHM had just come, and it was a replication of the Rural Health Mission. So what we realized is it's not going to happen in urban scenarios. So fortunately, at that point of time, we were at the government, we had Joint Secretary Urban Health and Joint Secretary RCH coming together, and they said that why don't, because the project was based on evidence generation, why don't you help us create a model on how things can work in urban scenarios for maternal newborn child. We thought it would be easy. We said, okay, let's do a systematic literature search. Evidence did not generate anything. Okay, we said, let's look into the models that are there. Hardly any scalable model was there. Then they said that why don't you conduct primary research? We said, okay. We went to the field. We took hold of Pune and Bhubaneswar. Pune, just like Bombay, a very rich urban local body. Bhubaneswar, a state government-led initiative. Both of them, we looked into assessment, realized huge challenges, and we said things will not change if we use the government system of planning. What does the government do? This is a resource envelope. The same plan has to be done from the top right to tier 2 cities, 3 cities. Rural planning being used to make plans for urban scenarios, it's not going to work. So we did a bottoms-up planning out there. So 2 specific city health plans were created, Pune and Bhubaneswar. That was the first instance of a bottoms-up approach of city health planning being done using evidence. Pune successfully implemented for 4 years, 5 years because they had money. Bhubaneswar did it for 1 year with our support. After that, failed miserably. The reason? Planning, decision makers, they take it, compare rural planning and urban planning in the same things. And I'm talking of tier 2 and tier 3 cities, not metropolitan cities like Bombay, Delhi, Ahmedabad and all those stuffs. So first thing if I look into it is how are we planning for it? Is it a need-based planning? Is it a bottoms-up planning? Or is it a resource-based planning that you are doing? Secondly, who's planning? When we talk of tier 2 and tier 3 cities, it's the urban local bodies which have to do. But do they have the capacity to do it? You have the 15th Finance Commission, lot of money being given to tier 2 and tier 3 cities. But how has been the money been allocated? Importantly, what we are seeing is that whatever the money is being given, you have the money now, but it's underutilized. They're not able to utilize it. They don't know where to spend because they don't know how to plan it. Third very important thing, when we have such a rapidly changing scenarios, urban scenarios are rapidly changing, heterogeneous group of communities, are our health systems agile and proactive to respond? After 11 years, you have NUHM being revised. And that's also, we don't have clear-cut evidences that whatever things have been included are still workable. Fourth, what is the most important thing for planning? Data. Do we have good data? We don't have. And fifth, who are the key stakeholders? We have few models where public-private partnerships have happened, philanthropics again, all excellent NGOs, you have Tata Trust work being here, you have Apnale, and there are lovely CSO models which are there. But is there a whole of society approach? Are we including philanthropies? Are we including private sectors? All these technological innovations that we are talking of, point of care devices, AI, digital tools, these are the things that all need to be taken together in a collaborative partnerships. So coming to the situation, yes, India has made a lot of progress in terms of policy, but at the grassroots level, I think lot of things to be done. Secondly, coming to some good examples, Brazil, I would say, especially when you look into inclusivity, is a wonderful example. They had a PHC approach, they went into it, and then they realized that on the hills and on the outer reaches of the cities, there were some specific areas which were not reachable. So that was a public-private partnership that they did. Excellent. They brought together a team of doctors, nurses, and they were given incentive to reach out to those communities regularly. They did screening, and ideally, Brazil was one of those countries which did not go with the World Bank driven approach of verticalization way back in 1994. So that's why they have a very strong public health system. If I look into the Southeast Asia region, India also has excellent models, but are we able to evaluate it? Are we able to monitor it? Are we able to ensure that they are systematically evaluated and taken up by the government? That is where I feel the challenge is. One last thing, from the region again, Thailand is one country that we can really learn from. Thailand has a very robust primary health system. But when you compare it in Bangkok, 70% are going to private providers. And lot of urban slum communities there are also there, not as big as we have it in India, but they have. So they went into this PPP model, but the best thing was when they created that model, the private providers were a part of the guideline development process. So you have them on board right from step one. Accountability, transparency, what are the processes, performance metrics, everything decided. again one of the best. I know I'm in getting glances that the time is up, so thank you from my side.
Thank you so much for the examples. It's good to see where we are and how much further we need to go. Mr. Srinivas, I'll come to you. All right. So, Tata Trust has worked across geographies and to strengthen urban healthcare systems. And so I want to sort of pick your brain on the CSR and philanthropy perspective when it comes to urban healthcare space. What is the larger outlook when it comes to corporate social responsibility funding perspective? What is the focus for urban context specifically? How do they evaluate, say, proposals? What importance is given to last mile connectivity? Is it considered important when these plans are being made? Would you like to comment a little bit on that?
You want to understand whether we'll fund the next proposal from Apnala? Okay, thank you so much, and privileged to be here, being part of this panel.
After this workshop, they will definitely fund it.
Hello. A few perspectives, after both the senior policymakers and the doctors have given the context, we'll just go into the thinking from organization like Tata Trust, which is not driven by a CSR policy. It's a philanthropy. I mean, one of the unique institutions in this country. Right, so doing right, what is right for the country has been there at the heart of the whole thing. The advantage we have is I'm allowed to fail sometimes. So when we deploy philanthropic capital, we are essentially taking some risks in experimenting, which I don't think the governments have those leeway, right? So over the years, we have tried multiple solutions, both working on the demand side as well as the supply side. Now, one principle we have followed is we're a little more biased towards supply side, that if we can create the right ambience, infrastructure, and get the people competency, supplies, and the process right, and the service is so good, it will sell itself. That you don't really need to work a lot on demand generation, because what is required for the public is to have trust that if I go here, this facility, I'll get the service I want. And that's primarily, again, what we have seen is there a good competent doctor or a staff? Am I being received properly? Third, are the supplies consistent? The supplies as in the, mostly for the chronic diseases as well as conditions. So these were some of the lessons that we tried to bring back and try to leverage what was existing. Like Dr. Sanjeev knows the experiment we did in Nagpur. My colleague Amar headed that entire intervention. It was about an integrated way in which you would want to approach a city like Nagpur, which had 25 urban health centers that were having a footfall of an average of around 25 to 30. 3 years down the lane, it increased by almost 200%. So what were the things structurally? There were some immediate things that were undertaken to create the right ambience, to ensure that the doctors are available at least 8 hours a day, to make sure that the patients feel welcome. The nurses were given not just clinical training but also soft skills training, and to ensure that the supplies are consistent. The central warehouse was actually upgraded and IT system was put in place to ensure that there is, the reorder quantity, reorder levels are all followed rigorously. For an urban setting, for say 25 clinics for a city of 25 lakhs, that was probably little, little less than what was required. But looking at the success of whatever we could achieve, the government actually went ahead and doubled the number of PHCs, right? It sanctioned budgets. So when philanthropic capital is deployed and moves the system from a particular orbit to the next orbit, I think the government steps in and ensures that the gains are not lost. So that's what on the supply side, when we could do, this is what we were able to achieve. I'll just go back again to a little more on the demand side or on the behavioral change side. I'll go to experience from my previous organizations where we created the 108 program, where your first reaction when you see an accident victim is to run away, not to go anywhere near to him or help him. India did not have a Good Samaritan law. It required a lot more of the senior public health officials and the police officials to own up and assure the general public that we are not going to harass you just because you're going to report. So please use this 108 number, inform. So when you created that confidence as a society after 3-4 years, you actually have the first reaction if somebody is having an emergency is you call 108 or whatever is the helpline in that particular city. So there are ways in which behaviors can be impacted, but to do that you have to be assured of the supply on that other side, that there has to be trust that I'll be able to get the supply I want. I'll just leave it at that. Any other questions I'll take later.
There will be, I'm sure. I wanted to connect this conversation with Dr. Gumare. You have worked on the... Sorry about that. So you have worked on with a direct community engagement. So Dr. Sanjeev has explained on Apla Davakhana and how that process kind of functioned, and you were very much a part of that process. So I wanted to get your perspective on the community engagement piece. What role do you think community engagement plays in connecting government services to the last mile? Mr. Srinivas did mention about like quality and access and everything. Do you think engaging with the community just as a matter of fact would be something that would be useful?
Everybody, hello, am I audible? Hello, yeah. Good evening, everybody, and thank you, Sashi, for having me here. Working in public health department more than 30 years in a city like Mumbai has given a lot of learnings while working there. And it is not that learnings are only coming from COVID period, but COVID has done that. And from COVID, government has understood the magnitude of the problem and even decided to bring the changes. That is more important, because ultimately when government decides, then only we get some fundings and other support. Sir has already done half of the work, which I wanted to share with you. But then thank you, sir. And I have enjoyed working with sir because I feel he is the most public health person I have seen amongst the commissioners, which I have worked with them. Coming to certain challenges, sir has already narrated the learnings and what interventions has been done. Population-based surveys we started. We started so many Apla Davakhanas. We started recruitment of frontline workers, ASHAs, and so many things. I feel this is a kind of a milestone which I have seen in history of public health department, because since last so many years, more than 30 years, I have not seen such kind of a moment which we have seen after the COVID. So this is, I will say, a good start which has happened in public health department. But is it enough? Again, it is only, I can say, is a good start, but lot many things needs to be done. The adversities, the challenges remains the same, because at the same time, parallelly, the issues are also increasing. Urbanization issues are there, plus staying in Mumbai has its own toll. When people, they stay in unsettled, unplanned settlements, then there are issues of sanitation, there are basic issues of electricity, water supply, and so many other things are there. So, though it is a good start, still we are facing lot many issues while dealing with public health department. And very important into that is regarding fund flow or the budget allocation. Sir has mentioned that Mumbai is one of the richest city in country, and we have thousands of crores of budget is available for health department, but still when it comes to primary care, it is always a biased decision. We have seen lot many high-rise buildings coming up for hospitals, but when it comes to maintenance of some of the primary health centers, there is an issue when it requires thousands of rupees or sometimes lakhs of rupees. So budget allocation is not happening as per the requirement which is there for the primary care setup. That is one of the biggest issue. Plus, even the NHM has started giving some funds, some allocation is happening, but that funds though are coming very late, sanctions are coming late. Then after some months, that actual disbursement of funds happen, and then ultimately we turn up into the last quarter of the financial year when the activity starts. So this also needs to be looked into that, and some budget allocation sanctions should happen in time so that that budget also can be utilized properly for the primary care strengthening. Infrastructure. Again, Mumbai has its own problem, scarcity of this space, and very small dispensaries or clinics are there where it is very difficult to even sit. Then the question of providing the services again comes in. Hardly some health post or some UPSCs are there placed into 10 by 10 feet area. So it is very difficult to even accommodate some of the primary care centers into that. But then when we started with Apla Davakhana, the porta cabins and containers based clinics we started, that has a good change has happened, and because of that we could reach out to the community. Door to door step facility can be provided because of all these clinics. Availability of the staff, again, at any given point of time, 30% vacancies are always there. NHM provides all the contractual staff, temporary staff, and then there is a tendency nowadays that even against the vacancies of the regular staff, contractual staff is being appointed or outsourcing of the staff is happening. So we need to really decide percentage of the regular staff versus the percentage of the contractual staff, because that is hampering the work, and that kind of a wisdom which we used to get, having the regular staff is not nowadays not there. Attrition of the staff is very much maybe because of the poor salary structure, as well as no satisfaction, no work satisfaction, no personal growth. So many issues are there. So that also needs to be thought about. Then capacity building and training of the staff, which is it's not happening at all, I'll say, in urban setups. Whatever issues are there, most of the time we have seen, because as sir has said, we have never gone out of BMC limits. We were like born and brought up in Mumbai, And so we are knowing a lot of issues of the Mumbai, but at the same time, as sir has said, that exposure to various districts or the states has not happened. And even at the trainings and capacity building as per the state guidelines or the government guidelines also needs to be taken care when it comes to urban staff. Then already overburdened staff with lot many programs and schemes coming in. That is also a big issue. Digitization is happening, and at the same time, because the portals or the software is not updated or completely not taken over by for reporting, so people have to work doubly, like manual registers also needs to be maintained, and portal entry, data entry also needs to be taken care. So somewhere that shift is happening. More thrust is given to the reporting and updating the portals than to the service delivery actual, which should happen in the urban setups. That is also a big issue. Then changing trends. No, communicable diseases are already there. They are re-emerging again. And on the top of it, urban setups, they are now hub of the non-communicable diseases. We did the WHO STEP survey. Into that, sir has already mentioned that hypertension to the tune of 37% and diabetes 18 to 20% prevalence has been seen. So that also is again a big challenge that we have to tackle the non-communicable diseases in urban setups. And added to that, climate change and pollution is again a big issue. So these are some of the challenges what we are facing. So you were asking about the probable suggestions. Should I tell in next thing or?
Yeah, that is probably a good idea because I wanted to sort of
Yeah.
from your comment about digital data and the difficulties that are being faced by that to Mr. Shaleen. He has experience with the primary healthcare schemes in Delhi and Punjab, and Ayushman Bharat Digital Mission holds great promise. But as ma'am said, there are some challenges still being faced at the community level. What are the challenges you have seen in last mile communities? According to you, what could be the solutions suggested to these kinds of challenges?
I think the conversation where we started and the term demand and supply emerged. And if we primarily talks about the supply side, the supply of intention is very crucial. There should be a political will to invest on primary healthcare. That's one. So how much budget are we spending on the entire primary healthcare sector, not just the digitalization part of it, is very crucial. Next is the understanding of the entire primary healthcare system. Are we designing something for the poor? Are we designing something for the rich? If you're designing something for the rich, it'll be used for everyone. Everyone will use it. If you're designing something, if the concept of a primary healthcare center is being emerged, like we're designing something for a poor man, then not even the poor will use it. So that understanding of investing into primary healthcare is very crucial. And when I say demand, I mean, people are willing to seek support from the government. People are coming to the center. But are we taking care of their experience? Are we just making arrangements for telemedications, but the medications are not available? I mean, we are talking with the, we are ensuring that the digital experience is very good, but are the medicines available? Whether the bond between the individuals who are at the primary healthcare center is being set up in a way, are they being trained on soft skills, as Dr. Khanna mentioned? And when they are trained into soft skills, are they also trained that how do we understand the pain of a patient once the patient reaches out to you at a center? We also face challenges in terms of bringing public-private partnerships together. And when I say public-private partnerships, it's not just with not-for-profits.
if we really want these young champs to work in health sector, we also need to partner with for-profits, because they would, I mean, the salary, everyone wants good salary at this moment. They would be, if they're working just for not-for-profits, salary will always be a challenge. So public-private partnerships have always been a crucial task to work on. And if we really wants to invest into digitalization, government is not capacitated to work on AIs right now. I can safely mention that. Because our systems, be it NIC or CDEC, they're working on systems which are not as well versed with the current technology. We need to work with private players. We need to bring in their expertise into this. And are we investing on behavior which seeks health? Are we making our students understand what is health? Are we investing on mothers to make them understand what the health of a child means? Are we working with schools? Are we making them understand what is health, nutrition, and sanitation? So I think in my experience of working with the Delhi government or now with the Punjab government, will has to be there, that's one. And will to participate with, work with partners who are, whether in private sector or in public sector, should be there. And if we club the entire, I mean, if we work together, things become much easier. However, cities behave differently than villages. Punjab has 5 commissionerates. So working in those cities has always been a challenge, because the understanding of health is something we are currently even working on. Like we, even after struggling with, I mean, getting them registered on the ABDM portal, it is still a challenge. They understand, I mean, they will always question as to what we will get, even if we get registered there. So making them understand that is a challenge we are working on. I think working with, if we really want to ensure that the urban healthcare system is being taken care of, the school system is very crucial. We need to work in schools. We need to, if we really want to build on the primary healthcare system, the primary healthcare center is not just the only venue. We need to work with schools.
Thank you so much. It is really interesting to see the conversation turn to multiple expertise that different departments bring. We've all had a little bit to say about the frontline workers and the training required for them. We do have a frontline worker with us today. So it would be good to have her opinion on and her experience about working in one of the most difficult communities in Mumbai. Kavita ji, आप हर रोज लोगों के घर जाकर उनका हाल पूछती हैं, ठीक है? क्या लगता है आज भी अर्बन स्लम्स में सबसे बड़ी दिक्कत क्या है? क्या सही समय पर दवा, सेवाएं या सहायता मिलती है? आपका क्या विचार है?
और सबसे पहले तो साफ पानी, साफ गटर, साफ कचरे के डब्बे, साफ नाले सफाई होनी चाहिए। इससे ही ज़्यादा बीमारी फैलती है, जैसे कि उल्टी, जुलाब, डेंगू, मलेरिया, इसके पेशेंट हमेशा मिलते हैं। और फिर हर एक सरकारी हॉस्पिटल में हर एक टेस्ट होना चाहिए, हर एक रिपोर्ट होना चाहिए, हर एक दवा होनी चाहिए, और हमेशा डॉक्टर होने चाहिए। जो ना होने के कारण पेशेंट को इधर उधर दौड़ना पड़ता है और फिर वो बड़ी बीमारी का शिकार होते हैं। और जैसे हमको बोला जाता है, हर एक गर्भवती महिला की डिलीवरी सरकारी हॉस्पिटल में होना चाहिए और उनको जननी सुरक्षा का लाभ भी मिलता है, लेकिन वैसा होता ही नहीं है, उनको मिलता नहीं है। और जब दूसरे दिन या फिर कभी हम मतलब जाते हैं और सरकारी स्कीम के बारे में बताते हैं, तो वो लोग हम पे भरोसा नहीं करते हैं और हमसे अच्छे से बात भी नहीं करते हैं।
और आपके जो अनुभव है वो सिस्टम के लिए एक आईने की तरह काम करते हैं। अगर आपको मौका मिले तो आप हेल्थ सिस्टम में क्या बदलाव लाना चाहती हैं?
सबसे पहले तो जो भी स्कीम आती है गवर्नमेंट की वो हमेशा होनी चाहिए। जैसे कि प्रधानमंत्री मातृवंदना योजना बीच में बंद हो गई और स्वास्थ्य को संपूर्ण रूप से देखना चाहिए। बस्ती के हिसाब से शौचालय होने चाहिए, इससे बीमारी फैलती है। फिर स्वास्थ्य विभाग ने साफ सफाई विभाग, पानी विभाग और शौचालय विभाग इनके साथ मिलके काम करना चाहिए। और जैसे कि मेरे बस्ती में मेरे मतलब स्लम एरिया है, तो उसमें लोग थोड़े दिन के लिए आते हैं, जैसे 6 महीना 1 साल, तो उनके पास ना आधार कार्ड होता है, ना रेशन कार्ड होता है, ना कौन सी आईडी होती है, मतलब जैसे कि डिसेबिलिटी कोई है तो उनके पास वो भी नहीं रहता है। तो उनको जो भी गवर्नमेंट का स्कीम आता है तो नहीं मिलता है। तो ये बनवाने में ज़्यादा ध्यान देना चाहिए।
अच्छा, और अगर आपको सिस्टम को लोगों के ज़्यादा करीब लाना है तो सबसे पहला काम क्या होना चाहिए आपके विचार से?
जैसे मेरे पास 650 घर है और 2 ही आंगनवाड़ी है और एक आंगनवाड़ी के पास 200 ही घर के बच्चे और गर्भवती महिला आती है, तो 400 बच्चे मतलब जाते हैं आंगनवाड़ी, तो बचे हुए बच्चे कहाँ जाएंगे? उनको तो ना पोषण आहार मिलेगा तो कुपोषण बढ़ेगा। तो जितनी बस्ती उतनी आंगनवाड़ी होनी चाहिए। और फिर एक मिनट, जैसे कि मेरा आरोग्य केंद्र बस्ती से थोड़ा दूर है तो पास होना चाहिए, जैसे 60 साल ऊपरी लोगों को बीपी शुगर का दवा लाने में दिक्कतें ना आए। फिर बड़ा अस्पताल भी नज़दीक होना चाहिए ताकि होम डिलीवरी ना हो। होम डिलीवरी होने के वजह से मदर डेथ, चाइल्ड डेथ होती है। और जो भी सरकारी स्कीम आती है वो हर दवाखाने में होनी चाहिए, हर पेशेंट को मिलनी चाहिए और हर टाइम पे मिलनी चाहिए।
Thank you, Kavita ji, for your input. We she absolutely did. We had a few cross-cutting questions to ask a few of our panelists to engage in discussion. How much time do we have left? Okay, all right. In that case, maybe we can take one cross-cutting question and then move on to taking some questions from our guests here. All right. So let's talk about community center design and implementation, right? How can systems be better designed to involve communities in the delivery of healthcare services? Now, as per your perspective, all of you might have different opinions on this, which is what we would love to hear at this panel discussion. What have you seen work in terms of community awareness, perhaps trust building, increasing uptake, any sort of in urban informal settlements? Is there anything that the panel would like to say about what do you think should be used?
Can just have a discussion, I guess. Everybody
Yeah.
can.
Can I say two lines?
Please go ahead, ma'am.
Yeah. When we are discussing about the reaching out to last mile, so this is something a very important thing that whenever interventions are planned, there is no mention about the strategy to be applied for community participation. That is really very, very important. Our IEC activities or BCC activities limits to only that health awareness was done, health talks are given, so many leaflets distributed, some do's and don'ts given, and then report comes like number of beneficiaries, so many. So this needs to be changed. Otherwise, it's very difficult for us to have a community participation and community-led actions. That is one thing. very important thing is that for that is capacity building and training of the community leaders or the community people again is very important. And at the same time, training of the health staff or the frontline staff so that they will learn to work in a team and they will understand the importance of team. Whenever we see any citizen as a patient or as a beneficiary, instead of that, we must start looking at them as a participant so that they will also give some feedback to us and they will also be part of the planning team. That is very, very, very important. And another important thing is that in urban setup, we have community processes like MAS, and now the JAS also is coming in. But in urban setup, we have seen that those schemes are failing. That was not an attractive scheme for the citizens or the frontline workers. Because of many issues, I think Kavita has forgot to tell about that, but she can tell why MAS is not being taken up in the community. So we really need to invest more into the MAS and JAS formation and its functioning. That is very, very, very important. Nowadays, under the NQAS, whenever we go as an assessor, we do ask one question, whether you are taking any feedback from the ASHAs while you are working in the sub-center or the PSCs. For sake of just replying, they say yes, but actual feedbacks are not taken from the ASHAs. And then the question of taking feedback from the community is far away. It's not a reality. So that is again very, very important aspect which we'll have to think about it, and we really need to formulate a good community participation policy brief so that we can reach out to the last mile.
You have mentioned the impact that ASHAs can have. I'd like to extend it to Kavita ji. System को हम कम्युनिटी की भागीदारी प्राप्त करने के लिए कैसे डिज़ाइन कर सकते हैं? आपके अनुभव में कम्युनिटी भागीदारी से कौन सा यशस्वी काम अच्छी तरह से होते हुए आपने देखा है आपके एक्सपीरियंस में?
सबसे पहले तो सबसे पहले तो स्वास्थ्य का लोगों के नहीं, सबसे पहले तो कम्युनिटी अवेयरनेस का लोगों के स्वास्थ्य पे जल्दी असर होता है। जैसे कि मेरे हिसाब से मेरी गली का काम बहुत दिनों से नहीं हो रहा था, गली के गटर का काम। तो कुछ महिला मिलके गली में एक लेटर लिख के और उस पर सिग्नेचर करके वार्ड में जमा किए, तो उसका तुरंत काम हुआ। और जैसे तुरंत काम हुआ,
आपके दिमाग से बोल दीजिए कविता जी।
हाँ, और जैसे कि सरकार ने जन आरोग्य समिति और मास आरोग्य समिति बनाने का प्रावधान रखा है, लेकिन इससे जुड़ने के लिए जो प्रोसेस रहती है वो बड़ी कठिन है। मतलब जैसे कि 10-12 महिला का ग्रुप करो, उसका मंथली मीटिंग ले लो, फिर बैंक अकाउंट खोलो, और इससे उन लोगों को तो कुछ नहीं मिलता है, तो वो लोग आसानी से जुड़ नहीं पाते हैं। तो ये जो भी स्कीम है वो जुड़ने का जो है वो आसान तरीका होना चाहिए।
Thank you, Kavita ji. Maybe Dr. Sanjeev?
So I think the issue is about the involvement of community and building trust. Now, if you go to the poorer part of the city slums, and you just try to find out how many of those people spend money and go to the informal service providers, the quacks sitting there, who provide poor services but provide some kind of services. I think large number of people would be going. Now, when they are providing poor services, they are not qualified, and still people are going there. Why? And they don't go to our primary health centers. One, of course, is the distance. Then you will have somewhere in the 10th floor the primary health center. No, the most important is the certainty of services. So when I have to go somewhere and I am not sure whether I'm going to get the service or not going to get the service, and particularly when I am suffering, I am having fever or something else, then the best decision to make for me is to try something else. I think the most important is at the community level, provide certainty of services. That when you go to the primary health center or the HBT, or you will have the doctor there or the nurse there, the medicine availability, and then of course psychologically, socially also, they will descend to the level of the people at the community level. They would not behave differently. So, I mean, one of course is the felt need. Is there a felt need at the community level for the services or not? There is a huge felt need. That's why they are going to the quacks and spending the money and taking the services. Then why are they not coming to us? They are not coming to us because first the services are not available. They are somewhere far off. Then we don't know the doctor will be available or not. Then we don't know that when we are going, we will have time somewhere at 6 o'clock in the evening, your primary health center will be closed. That's why we said that we'll have to have our Apna Dawakhana within the community. That's one. The timing will be flexible and certainty of services will be there. So I think if you take care of these things, certainty of services, certainty of medicines, the people sensitivity at that level, the community involvement automatically happens. That's one. The second, of course, what has been said is these are the broader long-term issues in terms of health being an important, when you go to school, the focus should not be A plus B whole square, but focus should be on your health needs, what should be done, what should not be done. So that if it becomes part of the curriculum at that level, automatically it will become the priority at the community level also. Another very important point which has been said and which we always keep, I also feel, always keep repeating again and again and again, is that we talk only about the urban slums, the marginalized, the poor, and as a result of that, they are the people who they don't set the narrative at the community level. They are the people, nobody for whom speaks, neither in the media, nor at the community level, nor at the political level. And that's why the service delivery is ignored. Is the primary health care providing very costly? Definitely not. Then should you provide it for all or only for the poor? Leave aside top 20%, 30% people, those who are very rich, they will not come to you even if you provide services. But even for the middle class, the lower middle class, the people, if you start providing services for them, then automatically it will become a priority. You know the direct cash transfer, which is the discussion now in Maharashtra and other places and in the country, is that direct cash transfer was never there. Direct cash transfer was there earlier as well for destitutes, for the marginalized at the village level, 1 or 2 persons, but it was never discussed at the community level because people were not involved in that. So when you start providing services for the middle class, the not that much the lower middle class, then automatically that becomes an issue at the community level. It becomes a political issue. The different stakeholders start discussing, the media starts discussing, and as a result of that, the quality of services improve, and the poor people are also, lifted up as a result of as a result of that. So and as a government, it is our responsibility to provide basic services for the all. And I believe that to that extent, otherwise which is the disconnect between the rich people and the government, that they go to private school, they go to private healthcare, they don't use government services. That connection has got to be made for the good, better functioning of democracy and better functioning of the country as well. So that I think we should start thinking in terms of providing basic services. I'm not saying the big, complex surgeries and treatments, but basic services, let us start providing for all. And once we start providing for all, the whole narrative will be set, the whole community will be involved, and the poor also will be benefited. Now, there are certain diseases, particularly the NCDs. Let us say if you come to me and say, will screen you for hypertension. The people say, why do you want to screen us for hypertension? We never had a hypertension. So there are those diseases like diabetes, hypertension, other diseases where involving public would require greater skill set, greater motivation, greater involvement, will take time. But there also, I think what happens when you intervene at the community level and when 10% people start responding, then as a result of demonstration over a period of time, you would find that from 10% to become 60%, 80% doesn't take much time. The involvement of the community level is not such a huge challenge that we cannot deliver the services. More important is to provide the good quality services at the community level with certainty of services, with the sensitivity, and the rest of the things automatically follow.
Anybody from the panel would like to respond to Dr.
Just one point I wanted to add here. When I was talking about partnerships, in our country, mostly we see that there are examples when technocrats are working in this direction, bureaucrats are working in different direction, and sometimes academia is working, building researchers in one direction. So there has to be cohesion and synchronization between the efforts made by three, right? There has been a long debate about technocrats being into the system, how much can they influence the design of a program. But then if we create a system where three of them can work together, the result will be good, and we'll be able to lead our initiatives much, much better.
The last point, I'll just take 1 minute. The philanthropy or the NGOs are the CSR services. And Tata Trust is a wonderful example. That one learning which I think we must all know, there are certain strengths and weaknesses. What is the strength of the government? The strength of the government is the reach. In every village, every community, they would have 10 employees. You will have Gram Sevak, you have Patwari, you have nurse, you have Asha worker, and the Sarpanch. And that is the reach of the government. And then another very important is the historical memory. You have been working over the decades. So people know government, people know the community level workers. Now, when it comes to the NGOs or the non-profit sector, they don't have that kind of reach. They don't have that kind of historical memory at the community level. But then at the community level, the government has certain weaknesses. What are those weaknesses? First weakness can be because they have been working in that particular area day in and day out. They don't know what is happening in Brazil, what is happening in Thailand, what is happening at the international, in other states. So that expertise, the new ideas, the latest innovations, they may not be knowing. And maybe because it's such a huge system, the level of commitment, the level of dedication may not be there, which is definitely the strength of the non-profit NGOs and the CSR. They are there in that sector, not because they wanted a job. They are there because of their dedication, because of their commitment, because of their motivation. And they have the international exposure, the national exposure, and other places. So how these two things can be combined? So my first point is that for NGOs and non-profit to work, you cannot work without government. That is one. Your government must be a strong partner working with you. For example, we have seen with the Tata Trust, that is one. Second is don't repeat just what government is doing. Add value to what government is doing. For example, I say that he is a great expert, consultant, expertise, but his services, he's going to charge me 10 lakh rupees a month. In the government, I cannot pay. So in that context, at that time, the non-profit, the NGO, CSR can pitch in that we will provide you this expertise even at the higher cost, which I can't do in the government. So that is there. The third is, don't unnecessarily, I think that is a problem we also make, mistake we also make and others also. We reduce healthcare everything to the construction part, building construction. So you would have seen large number of primary health centers there in villages and cities and blocks, but no service delivery. So don't indulge in that construction part because that is costly. So add value and put in place the systems like IT-based systems. How can we, create those systems which are foolproof? What they said about the IT is, my opinion, is also same. Because the system has to be 100%. For example, you write on a piece of paper when you collect the information. You collect information from each and every health and wellness center, each and every PSCs. Whether that is correct or incorrect, that is a separate issue. But we have information. Now, when we shift to the IT, and if you are able to do only 60%, 70%, I cannot rely on that. Then I have to rely on the, you submit this also and the paper also. So our people at the community level will have to do two works. Right. Paper bhi karo, and at the same time, they will have to do data entry. Now, she can't do data entry. He cannot do data entry. They hire someone else to do data entry and spend money there. So IT-based systems are good, great, but they must be 100% foolproof and 100% replacement for the paper-based work. So that is there. I think on the the final point is that it is not as difficult as we think to make changes, make difference, but the leadership and the vision at the institutional level, at the community level, is important. And if we make effort, things improve. We can make differences.
How about we take maybe a couple of questions from the group? Keep it crisp. Identify who do you want the answer to come from, and guys, try to keep it short and sweet. Sir, you start first.
I'm Venkat here from Karuna Plus. We are working for last 30 years in primary healthcare in rural and. Is it Karuna or Karuna? Karuna Trust. Not Corona, Karuna. Karuna is from compassion. And we are working for last 30 years on public-private partnership with different state governments. And recently, I think maybe last 7 years back, we entered into urban health. When we enter into urban health, we have seen a lot of chaos in the urban health system. I want to point out basically urban health is more clinical and very less public health. And and also urban health is the subject of local municipality. And see, I am talking about Bangalore city. Bangalore city, 1/5 of Karnataka population is living in Bangalore. And all the expertise of state government is almost just 5 kilometers from the municipal office headquarters. And the top experts have nothing to do with Bangalore health. Absolutely, they cannot interfere in any way. They have nothing to do with health of Bangalore. So my question is, till the NUHM and NHM has come in, even then, the structures are, NHM want to put the structures of rural health into the urban. That is where exactly the confusion of MAS and JAS and everything is happening. Now, how do you solve this problem? Because the municipalities have nothing to, municipality, their autonomy on health. And the state government have no role. And we constantly talk to the state government and they said we have no role in urban health. How are you going to solve this problem?
Would somebody from the panel like to take this?
Other questions also, or all? Yeah, let's do one thing. Yeah.
Hello, I'm Hilmi from ZMQ. It is an NGO, and we are working for last 25 years. So 18, 19 years we have worked in the rural areas, and 7 years back we moved to the urban slums, and it has been a different experience. And I came with the hope here, and I'm so happy today that it's the last session, but I think it has been one of my best sessions. Yeah. So I have a question to the panel, and especially to Dr. Sanjeev Kumar. That I have two small questions. First is that when we talk about urban healthcare, all the policies and planning are basically are focused toward the formal city areas. So here we are able to neglect some kind of urban slums, especially it has issues about pattern of diseases, demography, immigrant, marginalized, and then we have the infrastructure is poor. Also, access is a barrier where they don't have IDs and all. So it is one, but if you work in the urban areas, we are able to solve up to 70, 75. If I talk of the immunization, 75, 80% saturation is there. So the whole game lies, how to work on those last 20% is the main area, because even in the cities we have 85, 90, 95% of immunization. Yeah. So I just want to give one example that 3 years back we started working in Thane. I am from Delhi, but it was a big change for us to go there, and we have used intermediate health workers as transgenders, and they are doing fantastic work, because Asha Kenneth go up to the 8th floor every day and work with, and so the 2 years back we had around 25 or 30 cases. Yeah. So I want to talk about the new role of intermediate health workers, which I'll talk to you after. Yeah. Thank you very much. Yeah.
Thank you. Sir has one question. Please keep it crisp.
Sir, I am currently working in community, and I noticed that people do not prefer to visit the community health center because first there is no fixed time for doctors, and secondly it is very procedural. First they have to collect prescription, then they have to go to a doctor, and then they have to register which medicines they will be taking, and then they can get medicines. And sometimes these medicines are also not available. So, but with coax they can get the thing done in 5 minutes. So, what reforms can we do in the PHC that can make them more accessible? Thank you.
Okay, quickly, sir, I think from Karuna Trust, I think you came a little bit late, because earlier we had discussed these challenges only, and NUHM replicated on NRHM successes. Then after 11 years now, we are having a revised NUHM in India, but urbanization has moved rapidly. The changes, you need to be very proactive, need to have an agile health systems, but that's a challenge with health systems. It takes a long time. Best thing with urban is that urban needs to have context-specific local solutions. Each city needs to find its own, but for that to happen, you need to have capacitated urban local body who has the understanding of what are the real needs of the problem. And then you're talking of Bangalore. Bangalore, I think, has the capacity. It's just about getting the right people at the top. You have, IS officer from BMC. Bombay created this wonderful model. Mohalla Clinic, you have Sanjeevani Clinic in MP, you have Apla Dawakhana. So there are about 8-10 models of community clinics already available in India. No. What I'm trying to say is that's at least one step. The idea behind moving to the promotive and preventive aspect, comprehensive, takes some time. And our health systems are not structured to do that. That will require some innovation. That will require some different thought process. Huh? So why are we here? This is what. At least you have seen some movement happening on urban health.
You see, just 1 minute. I think he has raised very important point that in Bangalore they say we are not in Secretariat they say we are not bothered with urban areas. That's what that's what is the historical context it is. That's what is the understanding, na? What is the reason? You see, you go to Mantralaya or Secretariat, you have 10 different departments looking after the state. There's a water supply department, agriculture department, PWD department. When it comes to corporation, when it comes to city, all these functions are combined in one city, one corporation, and there is one municipal commissioner or additional municipal commissioners. Today I am working in energy, and I have, in the last few years, people have been asking me, you come to health. I said, no, I don't want, I want to work in energy. Because it's very comfortable to work in infrastructure sector. You float a tender, then people keep working. In health, every day there is a challenge. Someone somewhere has died, this is the problem, doctor is not there. So all these complex functions combined in one municipal corporation with one municipal commissioner, then with the, and with the people in the health system who are not well trained, well equipped in municipal corporations, and that's why they say we are not bothered with the, and historically, people sitting in Secretariat in Bangalore, they have handled only the rural areas. Na? They have not handled the urban areas. So that is the disconnect. How to reform that disconnect is a huge challenge. There are various reforms which can be made. For example, you have if you go to Mumbai, you have UD1 secretary, UD2 secretary. You create another secretary looking only after urban health at the secretariat level. And then that secretary will look after 24/7 only for urban health. Na? Things will improve. I don't know, but there can be other ways of reforming. So I think there are complex challenges in urban areas which require a detailed discussion, detailed workshops and conferences, and how to put in an institutional arrangement in the cities to reform that.
That is a lovely idea, and we have it on camera now, so we can get back to sir with a proposal for it. Thank you very much, everybody. If you have further questions, the panelists will go have a cup of tea. Feel free to corner them there. And what we've heard today is a powerful reminder that urban health needs more than infrastructure. It needs accountability, dignity, and proximity. True last-mile connectivity means recognizing informal communities in official systems, investing in frontline workers, bridging health and civic entitlements like water, sanitation, and waste management, and co-creating solutions with the people and communities that they serve. Thank you, everybody, for coming and talking with us here. Thank you, all of you. Please give them a round of applause. Everybody, if anybody requires the policy brief or any material that Apnalaya has produced, somebody at the gate will be able to hand it out to you.